Once again, please find seats. Everyone has to be in a seat or you have to wait out in the rotunda. Thank you. And good morning and welcome to today's hybrid New York City Council hearing for the Committee on Civil Service and Labor. To minimize disruptions, please place all electronic devices to vibrate or silent. If you'd like to submit testimony, please send via email to testimony@council.nyc.gov. Thank you for your cooperation. Chair De La Rosa and Speaker Adams, we are ready to begin.
Good morning. I am Councilmember Carmen De La Rosa, Chair of the Committee on Civil Service and Labor. Thank you for joining today's hearing on intro number 874, which I have introduced at the request of the mayor in relation to health insurance coverage for city employees, city retirees, and their dependents. The city's commitment to offering premium-free health care to its employees, retirees, and their dependents has ensured that quality health care remains accessible and affordable for the current and former members of the municipal workforce. Following through on its commitment is not without its challenges, particularly as the rising cost of health care have forced the city to reconcile shortfalls in savings intended to cover these costs. Although there are challenges, they are not insurmountable. I view it as my responsibility as chair of this committee to set a table for a clear discussion that will lead to solutions. In 2018, the city's Office of Labor Relations and members of the Municipal Labor Committee agreed to savings goals associated with the city's premium-free healthcare options and formed the Healthcare Savings Tripart Committee to implement their agreement and explore innovative ways that could yield savings and sustain premium-free offerings. A major result of this initiative is the city's plan to switch to Medicare Advantage for the Medicare-eligible persons. That switch has been delayed due to a number of issues, including disagreements between the city and the MLC on how to reach saving goals with Medicare Advantage in light of court rulings that local law prohibits the city from passing off the cost of GHI senior care to insured. On December 15, 2022, Martin Scheinman and the chair of the Tripart Committee issued an opinion and award directing the City and Municipal Labor Committee, the MLC, to work with Aetna to implement Medicare Advantage plan for municipal retirees to help alleviate the savings shortfalls promised in 2018. He also made clear that a failure of the MLC and the city to ratify the agreement on Medicare Advantage plan would require him to find another revenue source, which he wrote would inevitably lead to premium contributions for members of $1,250 to $1,750 annually, resulting in the elimination of some premium-free healthcare options for municipal employees and retirees. Furthermore, he determined that GHI senior care must be eliminated from the city's health insurance plan offerings if the city council does not act to amend the administrative code to authorize the city to charge retirees for GHI senior care, and thus preserve some degree of choice between GHI senior care and Aetna Medicare Advantage. We recognize that this presents an unbearable choice for retirees on fixed incomes and creates a disparate impact on low-income retirees. Given that the administration and the Municipal Labor Committee are moving forward to implement, please remove him from the floor. Thank you. All right. So let me set some ground rules here. We are in the chamber of the City Council, which is led by the Speaker to my left, which is a body that is duly elected by this city. And we will respect this chamber and the opinions put forth today. We are laying a table for a conversation. And if you have no respect for this chamber, I will ask you to be removed. Everyone, every single person here will have an opportunity to testify, and we are listening. So please, wait for your turn to testify. There is no need to stand up. There is no need to be removed from this chamber. We don't want to remove you from this chamber. We want to hear everyone's voices, but please be respectful of one another. Thank you. Furthermore, he determined that GHI Senior Care must be eliminated from the city's health insurance plan offerings if the City Council does not act to amend the administrative code to authorize the city to charge retirees for GHI Senior Care, and thus preserve some degree of choice between GHI Senior Care and Aetna Medicare Advantage. We recognize that this presents an unbearable choice for retirees on fixed incomes and creates a disparate impact on low-income retirees. Given that the administration and the Municipal Labor Committee are moving forward to implement Medicare Advantage in alignment with the courts and the arbitrator's decisions, today, the City Council is hearing legislation at the request of the mayor. This legislation would authorize the city and the MLC to adjust the cost threshold in local law that currently requires the city to pay the full cost of any health insurance plan offered to employees and retirees if the cost is the same or less than the rate of HIP HMO. This legislation seeks to preserve retirees' abilities to choose health care plans that best meets their needs by authorizing the city and the MLC to set a lower cost threshold for Medicare-eligible retirees with Aetna Medicare Advantage, and to charge retirees for GHI Senior Care, thus mitigating the risk that it would be eliminated from offerings altogether. Given the importance of this issue, it is critical that this bill gets a public hearing. Today, we will hear testimony from all stakeholders, examine the details of the newly negotiated Medicare Advantage plan, and evaluate the paths forward for the city and the municipal retirees. We applaud the efforts of the municipal unions, the retirees, advocates, the current workforce, and this council for their commitment to organizing their voice to uplift their concerns we will discuss today, as well as for their years of service to the city. I firmly believe that healthcare is a human right, and I take the responsibility of finding solutions to this problem seriously. I'd like to first thank Speaker Adams for her leadership in allowing us to bring this hearing forward, and I'd like to thank the committee staff and all of the staff here at the council for their hard work in preparing for this hearing, most especially to Assistant Deputy Director Nick Connell, Policy Analyst Elizabeth Arts, as well as my own staff, Chief of Staff James Burke, Legislative Director Kiana Diaz, and Communications Director Frey Familia. Now, I would like to turn it over to our speaker for her opening remarks.
Thank you very much, Madam Chair. Good morning. I am New York City Council Speaker Adrienne Adams, and I want to give a special thanks to Councilmember Carmen De La Rosa, Chair of the Civil Service and Labor Committee, for providing this opportunity for everyone here today to present their positions on Introduction 874. Before I begin my remarks, I want to make it clear that had it not been for this hearing today, I would be standing with the nurses in front of Mount Sinai. No applause necessary, and the way that we cheer each other on in the People's House is this. So I wanted to make it clear that I would be standing with our nurses had it not been for the important item on our agenda today. I encourage all management at the outstanding hospitals to take into consideration our first responders and respect their right to fair pay and fair staffing. Introduction 874 would change the administrative code at the request of the Municipal Labor Committee and the city to continue offering retirees access to supplement GHI senior care coverage at a cost. In my tenure as Speaker, I have made expanding civil service opportunities one of my priorities because a civil service career is one of the best pathways to economic stability for all New Yorkers. The benefits it provides, which include the ability to retire with dignity, are unmatched in other careers. I know this from my own family's experience. I especially want to again thank our chair, Carmen De La Rosa, for convening this public hearing to examine the administration and MLC's Medicare Advantage plan for retirees and proposal to change the administrative code as part of their health savings agreement. These issues are not simple or easy to confront, and I must say, it is unfortunate that Chair De La Rosa has been unfairly attacked and has had her intentions mischaracterized with untruths simply for scheduling a public hearing on this issue and the requested legislation. Her introduction of the legislation upon the request of the city's collective bargaining parties is routine as chair of the Committee on Civil Service and Labor. It is the role of the chair to be responsive to labor agreements that impact city workers and retirees, and it is responsible to give them a fair hearing that facilitates transparent public conversation. Chair De La Rosa has demonstrated tremendous leadership for this city by prioritizing the public interest through this committee's work at a critical juncture, despite being the subject of unfair attacks. At no point did she or this council say we are forcing passage of this administrative code change and denying fair opportunity for those impacted to be heard. Yet, that is largely how she and this committee have been attacked and characterized, at times including attacks against me, even for deciding to hold today's hearing and consider the legislation. It is counterproductive for our public dialogues to proceed in this way, which stifles conversations that we need to have. These are important issues for us all to better understand, and public examination is critical to sort through the complexities that carry serious consequences. The purpose of this hearing is for the council and the public to hear from all stakeholders regarding these issues about the potential outcomes and impacts on retirees and our current city workforce. And today, I look forward to hearing from all sides: the city's Office of Labor Relations, the Municipal Labor Committee, the Organization of Public Service Retirees, and everyone providing testimony. I know that many of us have very strong opinions and perspectives on this issue, but I do ask that we all treat each other, as the chair said, with respect and maintain decorum during this hearing in this people's house. It is essential that serious public consideration and examination of these complicated issues be achieved, with all voices respected and valued. Again, I extend my thanks to the council staff who have organized this important hearing, and again to our chair, Carmen De La Rosa, who I now turn it back over to. Madam Chair.
Thank you, Madam Speaker. Before we turn to testimony, I want to recognize all of my colleagues who have joined us today. Let me start with Councilmember Eric Bottcher, Councilwoman Julie Menin, Councilmember Hanks, Councilmember Chris Marte, Councilmember Gennaro, Councilmember Feliz, Councilmember Vernikov, Councilmember Ariola, Councilmember Kagan, Councilmember Palladino, Councilmember Hanif, Councilmember Dinowitz, Councilmember Carr, Councilmember Schulman. I think that's everybody. Oh, I'm sorry. Behind me. Councilmember Barron, how could I ever forget? Councilmember Nurse, Councilmember Brennan, and I think I saw Majority Leader Powers in the House as well. And virtually, we've been joined by Councilmember Sanchez, Councilmember Moya, and Councilmember Lee. Thank you to all our colleagues for staying present here today. Before we turn to our testimony, please be aware of the following administrative matters. Today, we expect to hear from witnesses testifying in person and virtually. If you are registered to testify, please listen for your name to be called. At times, witnesses' names will be called up in groups to facilitate council member questioning. Additionally, if you are testifying virtually via Zoom, council staff will unmute you when it is your turn to speak. This may take a moment as we expect a large number of virtual participants. Please be patient if you are not immediately unmuted, and please accept the request to be unmuted when you receive it. In order to accommodate the large number of witnesses registered for today's hearing, each witness will be limited to 2 minutes. Please stop your testimony when the sergeant calls time. Your understanding of these procedures is appreciated to ensure that everyone has an opportunity to be heard today. And as a reminder, you can submit written testimony at testimony@council.nyc.gov up to 72 hours after the conclusion of today's hearing. We will begin to hear testimony from the following members of the administration: Daniel Pollack, First Deputy Commissioner for the Office of Labor Relations; Claire Levitt, Deputy Commissioner for the Office of Labor Relations; and Ken Godnier, I think I messed that up. Please clarify. First Deputy Budget Director. The committee council will now administer the oath.
Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before these committees, and to respond honestly to council member questions? First Deputy Commissioner Pollack.
Yes.
Deputy Commissioner Levitt.
Yes.
First Deputy Budget Director Godner.
I do.
Thank you. You may begin your testimony when the sergeant calls time. I'm sorry, they won't be calling time. Please begin your testimony when ready.
Thank you. Good morning, Speaker Adams, Chair De La Rosa, and members of the Civil Service and Labor Committee. I'm Daniel Pollack, First Deputy Commissioner of the Office of Labor Relations. I'm joined at the table by Claire Levitt, Deputy Commissioner for Healthcare Strategy at OLR, and Ken Godner, First Deputy Budget Director. Thank you for the opportunity to testify here today in support of the proposed amendment to Administrative Code 12-126. The amendment before you is a continuation of the unprecedented labor management collaboration on employee and retiree health benefits that we at OLR and OMB have been engaged in with our partners at the Municipal Labor Committee for the last 8+ years. The MLC and the city jointly drafted this bill and are mutually supporting it, as it is essential to our joint goal of maintaining high-quality, premium-free health insurance for city employees and retirees while providing options for retirees. The city will be proceeding with implementation of a Medicare Advantage plan. This amendment to the code will ensure that retirees continue to have the option to keep their current senior care plan by paying a monthly premium. As a result of the federal government's subsidy of Medicare Advantage programs, the city is able to save $600 million a year by implementing a Medicare Advantage plan, or $3 billion over the next 5 years, given the 5-year guarantee we have received from the insurer. Those subsidies, combined with the city's market power due to our large population of retirees and dependents, allows us to offer a Medicare Advantage plan that provides superior benefits to senior care. We believe it is the best choice for our retirees. However, we prefer to offer our retirees the ability to stay on the senior care program if they choose, and this amendment will permit them to have that choice. I mentioned that this is the continuation of an effort we've been engaged in since 2014, and it's important to understand the scope of that effort to understand why we are now implementing a Medicare Advantage plan and requesting this amendment. First, I want to go over some basic facts about the city's health benefits. The city provides premium-free coverage to its 1.2 million employees, retirees, and their dependents. Premium-free coverage is rare in this country, even for public employees. For example, New York State requires employees to pay premiums of over $6,000 per year for a family plan. The city also provides premium-free coverage for any retiree that worked for the city for 10 years. Any retiree that worked for the city for 10 years and their dependents. And in addition, reimburses Medicare-eligible retirees and dependents for Medicare Part B costs. These are increasingly unusual and increasingly expensive benefits. Today, the cost of health care for the city's employees and retirees is over $11 billion a year, about 10% of the entire city budget. To address the escalating costs of health care while preserving premium-free, high-quality coverage, in 2014, the city and the Municipal Labor Committee reached a landmark agreement to save a total of $3.4 billion in healthcare costs over 4 years, including $1.3 billion on a recurring basis. In 2018, the city agreed with the MLC to target another round of savings for 2018 to 2021 of $1.1 billion, $600 million of which was to be recurring. These health savings were an essential part of reaching labor agreements to provide fair wage increases to all employees. The city and the MLC have been working together on a regular basis since
Sorry, Deputy Commissioner, may you speak a little louder?
Sure.
It's a little hard to.
My apologies.
Sorry.
The city and the MLC have been working together on a regular basis since 2014 to reach and maintain these savings. In doing so, the city has made extensive changes to reduce costs in the employee and pre-Medicare retiree plan, while leaving the plans for Medicare-eligible retirees untouched through 2021. A listing of many of the changes made to the employee and retiree plans is included as Appendix A to our testimony. The city and the MLC have also now put out a procurement for a brand new plan for employees and pre-Medicare retirees, seeking to save over $1 billion through that effort. But we cannot achieve the necessary savings based on active employees alone. Since 2000, the cost to the city for Medicare retiree health coverage has nearly tripled. In 2021, we spent $600 million on retiree health premiums compared to $200 million in 2000. In addition, the reimbursement of Medicare Part B coverage has increased over 700%, from $54 million in 2000 to nearly $440 million in 2021. In fiscal year 2022, the city spent over $1 billion on retiree health costs. As part of the 2018 Health Savings Agreement, a tripartite committee was established consisting of leadership of the MLC, the city, and Martin Scheinman as mediator and chair to work on identifying additional cost management strategies. With the tripartite committee, the city and the MLC began exploring changes to Medicare-eligible retiree coverage. Knowing the escalating costs of these benefits needed to be addressed, in 2020, the city and the MLC agreed to add $15 copays to certain benefits in the senior care plan for doctor visits, radiology and lab services, and other services. Rather than implementing these copays, as had been agreed in July 2020, the city and the MLC decided to refrain from changing these benefits due to the COVID-19 pandemic. Instead, those new copays were implemented in 2022 for the senior care plan. The city and the MLC agreed that a Medicare Advantage plan was an important cost-saving strategy that could protect the benefits of both employees and retirees. Approximately half of the nation's retirees are covered by a Medicare Advantage plan today, rather than traditional Medicare. This includes numerous public employers and union-administered health plans, including the states of New Jersey, Connecticut, Pennsylvania, Maine, and Ohio, and 1199 SEIU's retiree health plan, all of which are provided by Aetna, the insurer with which the city is currently negotiating. A Medicare Advantage plan allows the city to benefit from the federal government's subsidy of these plans nationwide and save a remarkable $600 million a year, while still protecting our retirees' access to high-quality, premium-free coverage. We understand that there's always fear of change when it comes to health insurance and changes in health insurance, and that's why in developing this program, we were committed, along with the Municipal Labor Committee, to offering similar benefits to the existing program while optimizing the federal funding available through Medicare Advantage. The city worked hard in collaboration with the MLC to offer this new plan that was not only premium-free with benefits equal to senior care, but also provided important new benefits designed to support the health of our retirees. This new program is a win-win for everyone. In agreement with the MLC, the city arranged for the expected $600 million a year in savings to be redirected to support the benefits provided by the Health Insurance Stabilization Fund. This fund is jointly administered by the city and the MLC and was originally established in the 1980s to ensure there was sufficient funding to equalize the costs of the PPO plan and the HMO plan so that employees could have a choice between two plans. Over time, it has also covered other important expenses, including specialty drugs, a portion of welfare fund contributions that help unions maintain their drug coverage and other benefits, care management, and other costs. The ability to continue covering these important benefits is one of the many reasons we support the adoption of the Medicare Advantage program. The city and the MLC's intention had been to offer current retirees the ability to opt out of the program and remain in the senior care plan in which they were currently enrolled. However, the existing programs would require an additional premium. For senior care, that premium would be approximately $200 per month. Retirees who did not opt out would be automatically enrolled in the new Medicare Advantage plan. Unfortunately, a lawsuit prevented this program from moving forward, with the court holding that the administrative code prohibited the city from requiring retirees to pay for the cost of senior care to remain in that program. While we disagree with the court's interpretation of the administrative code, we must find a way to move ahead to achieve these vital savings. The court specifically provided that direction by determining that the city could offer only a Medicare Advantage plan and no buy-up plans and remain in compliance with Admin Code 12-126. Without the expected $600 million a year in savings from Medicare Advantage, the stabilization fund is depleted and cannot continue to support the benefits it provides. As a result, the city and the MLC have agreed to even more changes to active employee coverage, including preferred radiology and urgent care providers, a mandate for all new hires to join the HIP HMO plan, suspension of $165 per employee and retiree per year contributions to union welfare funds, and the suspension of certain payments owed to the city. But that does not begin to cover the fiscal hole. At this time, the Stabilization Fund owes approximately $2 billion in reimbursements for costs the city incurred in prior years. The city continues to incur costs that we will not be reimbursed for, including an estimated $536 million for the cost in fiscal year 2023 of providing the Emblem GHI plan premium free, in which 70% of city employees are enrolled. Every dollar lost by not implementing this program is a dollar the city must cover amid a time of numerous other fiscal challenges. The delay thus far has already cost the city close to $1 billion. Recently, Martin Scheinman, in his role as arbitrator for disputes arising from the health savings agreements, ordered the city to move forward with a Medicare Advantage plan to achieve these savings. Pursuant to the court's decision, as I mentioned, the city is not required to offer senior care or other plans, and therefore can achieve the full savings by implementing Medicare Advantage and eliminating senior care and any other plan that charges the city a cost. That is exactly what Mr. Scheinman ordered the city to do if this amendment is not enacted, and he further indicated that a failure to implement a Medicare Advantage plan and obtain those savings would inevitably result in co-premiums for active employees. That is not the outcome that the city or the MLC want. We're here today to ask the City Council to amend and clarify the language in the administrative code to permit us the latitude to provide this important program to retirees while maintaining options for those retirees who want to pay to remain in senior care. The legislation would allow the MLC and the city to jointly agree upon a plan for health insurance for any class of individuals that would be a benchmark plan for such class. This would ensure that the city and the MLC have the flexibility to obtain quality and affordable health insurance by allowing the parties to designate different plans as the cost benchmark for the two different classes, one for employees and pre-Medicare eligible retirees and another for Medicare eligible retirees. As is currently the case, any agreed upon benchmark plan would not require any employee premium, and the obligation of the city to provide premium-free healthcare coverage would remain. This would allow the city and the MLC to designate the new Medicare Advantage plan as the cost benchmark, to allow those who wish to keep senior care to do so, and to continue what we have been doing for almost a decade, making necessary changes to deliver healthcare more efficiently to provide extraordinary premium-free benefits to employees and retirees. At this point, I'd like to turn it over to Deputy Commissioner Claire Levitt to talk a little bit about the details of the Medicare Advantage plan.
Thank you, Dan, and thank you to everyone for listening with an open mind so I can try to explain why we're so committed to this plan. To understand how Medicare Advantage plans generate savings, it's important to understand how traditional Medicare and Medicare Advantage work differently. In traditional Medicare, the Centers for Medicare and Medicare Services, CMS, directly pays hospitals under Medicare Part A and also directly pays medical expenses to doctors and other healthcare providers under Medicare Part B. And Medicare Part B generally pays 80% of the Medicare allowable rate. A Medicare supplemental plan, like what senior care is, pays after Medicare pays and generally covers.
Apologies, we're getting requests if you could please lift your voice a little, speak a little louder.
Sorry. A Medicare supplemental plan, like senior care, generally pays after Medicare pays and covers the 20% that Medicare Part B doesn't pay, subject to any copays in the plan. Medicare Advantage plans, sometimes called Part C plans, are offered by Medicare-approved private insurance companies. In a Medicare Advantage plan, both the Part A and Part B reimbursements come from the Medicare Advantage plan, not from original Medicare, along with any supplemental benefits from the same company. A Medicare Advantage plan can include benefits not covered by Medicare. Medicare pays a fixed amount for coverage each month to the company offering the Medicare Advantage plan. Under the Medicare Advantage plan, the private company must follow all of Medicare's rules, and a retiree has all of the same rights and protections that retirees have under original Medicare. Right now, about half of Medicare recipients in the country receive their Medicare coverage through a Medicare Advantage plan. Medicare Advantage plans can provide better and more efficient programs, address care gaps, and support the health of the program's members in ways that a supplemental program can't, using the amount of money provided by Medicare while charging an employer little or no additional premium. In our case, as a result of the city's size and our leverage, we were able to negotiate a program at a zero premium cost to the city with benefits that exceed the benefits of senior care. Now, the plan we expect to offer is a customized plan developed exclusively for New York City retirees. Some people confuse the Medicare Advantage program with some of the individually marketed Medicare Advantage plans you may have seen marketed on late-night television. But this is an exclusive group plan only available to New York City retirees and dependents and has special benefits and provisions just for our group. This expected Medicare Advantage plan would replace both the traditional Medicare and a Medicare supplemental plan with a single integrated cost at no premium cost to the city and no premium cost to retirees. The plan would provide all of the healthcare services previously covered by original Medicare, as well as those supplemented by the senior care program, and also adds important new benefits not covered by the current senior plan. Retirees lose nothing that they had previously in this plan. Now, there's in the testimony, there's a major plan design comparison chart of senior care and the proposed new Medicare Advantage plan. I don't want to take the council's time going through this line by line. I just want to point out a few of the important changes here. In our current senior care plan, there's an annual deductible of $276. That's the Medicare deductible plus an additional $50. In the proposed new Medicare Advantage plan, the deductible is $150, not $276, which is immediate savings every year for our retirees. That $150 deductible is also a fixed deductible. It's in our contract. It will be in our contract with Aetna, and it doesn't go up every year the way the Medicare deductible goes up every year. So we think this is a great benefit for our retirees. There's an annual out-of-pocket maximum in the proposed new Medicare Advantage plan of $1,500. After $1,500 is spent, everything is covered at 100%, and there's no additional cost to the retiree. There's no such protection like that in the senior care plan. In our senior care, in our new Medicare Advantage plan, a primary care visit has zero copay, while the senior care plan has a $15 copay. Likewise, for ambulance services and durable medical equipment, there's zero copay and there's no annual maximum, unlike the senior care plan that has $2,500 a year maximum on ambulance and durable medical equipment. And with the expenses of those types of services today, it's easy to go through $2,500. We've also added new benefits that Medicare does not cover, and I'll mention a couple of the important benefits. One is for transportation to go to and from the doctor. The plan will cover 24 trips annually to a doctor, going up to 60 miles, and that is a great benefit for our seniors. It covers hearing aids, which are not covered right now under senior care. It provides an incentive card for completing, a $200 gift cards for completing certain wellness activities. It provides an over-the-counter drug benefit of $120 annually to purchase over-the-counter drugs. It also provides a medical alert system, one of those systems that helps you identify if you are having an emergency or you fall, so you get immediate assistance. So these are things that our retirees just don't have right now that are important new benefits. In addition, the other benefits that are listed in our chart remain exactly the same. There is nothing in this plan where the benefit is less than the benefit in the current senior care plan. Now, we've been negotiating this with Aetna to be the Medicare Advantage insurer, replacing the original provider, the Alliance, which was a joint venture of Empire Health, of Empire and Emblem Health. Now, Aetna has over 25 years of experience providing Medicare Advantage plans. One of the major concerns we've been hearing from retirees is that they won't be able to see their current doctor. And in almost all instances, this is not the case. Aetna's been offering Medicare Advantage plans for over 25 years and has an extensive national network of providers that understand and appreciate the program. They have over 1.3 million in-network providers nationwide. And in addition, they have approximately 5,000 hospitals nationally in network, and all of the hospitals in our area either participate in the Aetna Medicare Advantage network, or there's one that does not participate but accepts Medicare Advantage patients from Aetna. The plan that we're offering is not a limited network HMO type of plan. Some of the plans that you'll see on late night television have limited networks. This plan is a PPO plan, or it's called an extended service area plan. This means that retirees can go to any doctor or provider nationally and in the US territories, including those that are not in the Aetna network. Out-of-network providers have to be accepting Medicare, which 99% of the doctors in the country accept Medicare, and they have to accept the plan by billing out-of-network. Aetna reimburses out-of-network providers at the same Medicare allowable rate, just as with original Medicare. This is so important to understand. There's no reason that doctors would not want to accept our patients because they're getting the same allowable amount that they get from Medicare. Now, Aetna's planning an extensive outreach campaign to encourage the balance of providers that our retirees see to join the network and to educate out-of-network providers about the program. They give Medicare Advantage participants what they call a provider passport to help familiarize providers with how it works. They have a hotline for retirees and providers to call if they have any question about how to receive Medicare payments through Aetna. So Although providers always have the right to decide whether or not to accept a particular plan or a particular patient, there's no reason for a provider not to accept this plan. They're getting the same payment that they would get if they were in the network or out of the network. Now, Aetna's network providers actually match up directly with 85% of the doctors that our retirees currently see in senior care, and another 10% of the Aetna providers have indicated that they accept the Aetna Medicare Advantage plan, even though they're not in network. That's a 95% match, and through Aetna's outreach efforts, we expect that percentage to increase. It also includes agreements with both Memorial Sloan Kettering and the Hospital for Special Surgery, and every hospital in the downstate region is in network or accepts the Aetna plan. The Aetna plan will not require a referral to go to a specialist. Retirees can self-refer to any Medicare participating specialist. Now, we know that retirees have expressed serious concerns about the pre-authorization requirements in the new Medicare Advantage plan, including whether it causes delay, creates paperwork for them, and results in denials of care. Now, we understand the concerns about prior authorization, and we want to assure retirees that this is not an issue that they need to be concerned about.
All right, so I'm going to repeat the rules again. Please be respectful of the folks who are talking. I wouldn't want anyone bursting out laughing when you're speaking. Please be respectful. Let's be grown-ups. Thank you.
I hope you're going to listen with an open mind to this, because all of the city's insurance programs for employees have prior authorization requirements. So all of you were part of such a program when you were employees and pre-Medicare retirees. Now, to help with this, I'm also very happy to announce that the city and the MLC have been able to secure commitment from Aetna that they will not conduct pre-authorization for a number of services that usually require it, including high-tech radiology like MRIs and CAT scans. That would remove approximately 75% of the procedures that generally require prior authorization, including under the pre-Medicare plans that the city offers. After removing these categories, only about 1% of all claims will require prior authorization. For the remaining claims that do require prior authorization, there are extensive processes in place to ensure they are processed quickly and fairly. Pre-authorization reviews are conducted between the provider and Aetna, and there's no paperwork for the retiree. Standard reviews are normally completed within 3 to 5 days. In an emergency, the requirements are completely waived, and in urgent but non-emergency situations, the time frame is 24 to 72 hours. If there is a denial, there is an appeal to the insurer, and if that authorization is still denied, there's an appeal to an independent entity appointed by CMS, as well as an additional level of appeal to CMS itself. The final decision as to approval or denial will be made by CMS. To facilitate transition in care, Aetna has committed at minimum 150 dedicated clinicians who will support the City of New York retirees during the onboarding process. These clinicians will continue to be dedicated throughout the life of the contract to ensure they continue to support our retirees and to help manage their chronic conditions. Aetna will also be engaging in an extensive outreach effort to providers and retirees, including over 200 in-person forums and over 50 virtual and teleconference calls with retirees to educate them about the program. Additionally, Aetna will be maintaining a custom website for our retirees, which contains information pertaining to the plan design, explanations on how to access benefits, and the ability to conduct online provider searches and determine, find your doctor in network or find another doctor in network. Now, many of our retirees get their prescription drugs from their union welfare funds, and that remains unchanged under the Medicare Advantage program. For those retirees who do not have prescription drug coverage from their union welfare fund, a prescription drug rider will be made available to those retirees. The Aetna Medicare Part D prescription drug cost share remains the same as that of the Senior Care Prescription Drug Plan in all the Part D phases of the plan. Further, all Medicare-covered Part D drugs that members are taking are covered. There's no change in the formulary from the Senior Care rider to the Aetna rider. The only change is a positive one. The premium is actually being reduced in calendar year 2023 from $125 to $103 per person per month. The city and the MLC will also carefully monitor the Medicare Advantage program to ensure that the program meets all of its commitments to us and delivers the quality service we expect for our retirees. We're designing a reporting package for Aetna to report back to us on important aspects of the program, including customer service response times, payment turnaround time, complaints, pre-authorization information, and more. We will report publicly on the status of the program on an ongoing basis. We have confidence that the Medicare Advantage program can provide quality benefits and strong access for our retirees while permitting city employees and retirees to maintain premium-free coverage. We strongly urge the City Council members to amend the administrative code language to permit the city and the MLC to establish this plan as the new cost benchmark plan for retirees. The new plan will significantly reduce the city's costs with the help of federal funding while providing better benefits in comparison to the senior care plan on a continuing premium-free basis. Its customized features include many new and exciting programs to support retirees. The cost savings from this plan, in combination with the other joint efforts of the city and the MLC, will enable us to continue to provide a high-quality and premium-free healthcare program to employees and retirees. Above all, providing high-quality premium-free health insurance to retired city employees and their families has been our #1 priority throughout this process. We urge the City Council to adopt the language that will permit us to do so while allowing retirees to pay a monthly premium to keep their current plan if they so choose. Thank you again for inviting us to this important hearing. We'd be happy to take any questions now from the committee.
Thank you so much. I also want to recognize we've been joined by council members Ressler, Caban, Aviles, Joseph, Farias, Juan, and Krishnan. Madam Speaker.
Thank you, Madam Chair. Thank you for your testimony thus far. I know that my colleagues have a lot of questions, so I will be asking just a couple. It's going to be a long day for all of us, which we're not complaining about, actually. We're very happy to see this day. The Office of Labor Relations and Municipal Labor Committee have decided to make the Medicare Advantage plan they negotiated with Aetna the free plan offered to retirees. What is the authority for these parties to execute this change absent the requested change to the text of the administrative code?
Thank you for the question, Speaker Adams. If the court case that prohibited the city from requiring retirees to pay a premium to remain in senior care also explicitly said that the city doesn't have to offer senior care or any specific plan, so the parties could decide to choose to choose to offer only one plan or to choose to offer numerous plans but not senior care. So, we have the ability under that ruling to, and arbitrary assignment in fact ordered us, to eliminate senior care or any plan that would cost the city, charge the city a cost. So, pursuant to that, we would be offering only Medicare Advantage and possibly other plans that don't actually charge the city a cost.
Thank you. The switch to Medicare Advantage is expected to help achieve the agreement's required commitment to annual savings of $600 million a year. Can you explain how the switch to Medicare Advantage would generate these savings?
Sure. So I'm going to ask Deputy Commissioner Levitt to answer in more detail, but it's really based on the federal funding provided to Medicare Advantage plans.
As I mentioned before, the premium cost to the city for the plan will be zero. And right now, we're paying $600 million for the senior care and other plans that retirees select. So that full amount of $600 million is guaranteed savings to us for the next 5 years. And in the 5 years following that, there are caps in the amount that Aetna could charge us. So the full amount of what we're paying just for the senior care plan and for similar plans is saved. Now, the city would continue to pay retirees to reimburse them for the Medicare Part B premiums. That's another $440 million a year that the city will continue to cover so that it is free to retirees and their benefits, and their dependents, I'm sorry.
Thank you. We have heard from our retirees loud and clear. Thank you for over 10,000 emails. Our retirees have voiced concerns that Medicare Advantage plans have restricted provider networks that could result in the disruption of care. How would the Medicare Advantage plan with Aetna allow enrollees to retain coverage for their current medical providers and specialists? I think you touched on it, but if you could just go into that a little bit more, expound on that for us, please.
The Medicare Advantage plan that we're looking at is a PPO, a preferred provider organization type of plan, not an HMO plan. An HMO plan may have a limited network, but this plan does not. You can go to any Aetna provider, and there are 1.3 million of them in the country, and all the hospitals in our local area. But you can also go to an out-of-network provider and be covered. So that we don't have the kind of limitations that you would have in an HMO plan. 95% of the providers that our retirees already see are already accepting the Medicare Advantage plan. So there's only a gap of 5%, and Aetna has committed to reach out to all of those doctors to educate them about the plan and try to get them to accept the plan. And they provide information to retirees, what they call a provider passport, to take with them to the doctor. And provide the number of a hotline that they can call, so they will negotiate with the doctor on the spot when the retiree is in the doctor's office. So we think there will be very, very little disruption with this plan, if any.
There's a lot of distrust with the presentation of the plan. You just mentioned once again the provider passport. Is that the only safeguard that would exist to protect our retirees against the denial of care?
Well, there is no. Denials of care are something that could potentially happen through the prior authorization process, and that can happen through Medicare as well, although traditional Medicare reviews claims on a retrospective basis after they're incurred, not before they're incurred. So you could actually go for a procedure and not know if it's covered or not until after the fact. This actually helps people know what's covered before they go. We think there will be very, very few denials of care, and as I laid out, there's a very extensive appeals process for that, and that happens very quickly. We've gotten Aetna to agree to eliminate 75% of the types of reviews that they're doing in all of their other Medicare Advantage plans because of this concern that we've heard so strongly from our retirees. Only about 1% of claims are going to be subject to prior authorization, and we expect that most of those will be approved, and there are significant processes in place to help them through an appeal process if that's necessary. The city and the MLC have also committed to a process where we're going to oversee everything that Aetna is doing, particularly on prior authorization. We're going to be looking at reports on a monthly basis to see that anything that is denied is denied appropriately. There are procedures that are not medically necessary to be done in a hospital, and arrangements may be made for those to be done on an outpatient basis instead of in the hospital. That's what happens today with our Actives plan. You may be told by an insurer that you shouldn't be having your colonoscopy in the hospital, that it's a traditional outpatient procedure. And that's the type of review that will be done for prior authorization.
Thank you. I just have one more question, and then I'm going to turn it back into the hands of our chair and our colleagues. It has not been lost on any of us the December 15th, 2022 opinion of Martin Scheidman, which was referenced by the first deputy commissioner a while ago. And there has been a lot of speculation about that opinion, whether it is binding, whether it is not binding. Can any of you articulate to all of us what will occur if this council does not amend the code?
Sure, I'd be happy to. Thank you for the question, Speaker Adams. So the arbitrator, I'll just say the arbitrator has authority under prior agreements we've made with the Municipal Labor Committee regarding health savings to, if there's a dispute, to order the way forward to achieve those savings, and that's exactly what he did. He determined that the $600 million in savings must be achieved, and that if there is no amendment to the administrative code that allows retirees to buy up to stay in senior care, that the city must move forward by doing what the court indicated it could do, which is eliminate senior care or any other programs having a cost to the city. I'll say that he also further indicated that if we're not able to achieve these savings through the Medicare Advantage plan, that co-premiums for active employees and pre-Medicare retirees are inevitable.
I'll just piggyback off of this, and then I'll stop for now. What is your honest opinion? We just heard you lay out what, excuse us please, we're still in a hearing. Thank you for your respect. We just heard you lay out what the arbiter's opinion is. What are your honest thoughts about what will actually happen? Do you believe that this opinion will go forth? Do you believe that something else will happen? And then I will stop and let my colleagues continue.
Thank you, Speaker Adams. Yes, I believe this opinion will go forward. If we're not able to pass this amendment, we will move forward with eliminating senior care as an option. If for some reason that path doesn't work out, we will need to look at alternative ways to achieve those savings, and co-premiums are certainly one of those possibilities.
Thank you for your testimony. I will probably come back in another round or so. Thank you.
Thank you.
Thank you so much. I also want to recognize we've been joined by council members Krishnan and Hudson. Okay, so I have a question about the council's role. If the council were to adopt this proposal, would the city and the MLC commit to continuing to offer GHI senior care?
Thank you, Chair De La Rosa, for the question. Yes, the intention of the parties, of the city and the MLC, has always been to offer senior care as a buy-up plan. If this amendment is passed, that will allow us to do so. So that's our intention in asking for the amendment, and it's our intention of what we'll do if the amendment passes.
Why is it important for the city and the Municipal Labor Committee to preserve GHI senior care as a health insurance option, in your opinion, as a health insurance options for municipal retirees, given that there's that commitment?
So we believe that retirees should have a choice of plans. You know, we do believe the Medicare Advantage plan that we've designed is an excellent plan. It's going to provide very high quality care. As Deputy Commissioner Levitt laid out, it provides some important new benefits. But if retirees are willing to pay a premium to keep their senior care plan, and therefore there's no loss of cost savings to the city, we see no reason why they shouldn't be allowed to do so. You know, we understand people have a fear of change in their health plans, completely understandable, which is why that if we're able to, we would like to offer them the choice to keep their plan by paying a premium.
What are the existing options for paying for city employees and retiree health care at this point?
I'm sorry, can you clarify the question? You mean for employees and retirees to pay?
Yeah, what are the existing options you see on the table as of this moment?
So, you know, the city and the MLC are constantly exploring ways to deliver healthcare more efficiently and save money. As I mentioned, we are pursuing a procurement for a new active health plan, and our goal there is to save over $1 billion. So, you know, but unfortunately, even $1 billion doesn't kind of cover the costs that we need to cover, the savings. We need to achieve $1.6 billion in savings, and the $600 million in Medicare Advantage savings is really an essential part of that effort. If we don't, as I mentioned, we'll have to look at, you know, some very difficult choices of how to achieve those savings.
And how much does the city expect to pay monthly per person under the new Medicare Advantage plan?
So the cost for Medicare Advantage to the city is $0, and that's guaranteed for 5 years.
In fiscal year 2023, how much did the city, I guess this question might be for OMB, but whoever can answer. In fiscal 2023, how much did the city pay monthly per person for GHI senior care plan, including the Medigap coverage for Part B premium reimbursement? How much did the city pay monthly per person for the HIP HMO plan for that same year?
So the cost of the senior care plan is approximately $200 a month. I think it's $191. In addition to that, the city paid the Medicare Part B premium, which totaled about $465 million in 22.
400?
And $65 million in FY22.
Okay.
With regard to the HIP plan, the plan for Medicare retiree, Medicare eligible retirees, the HIP VIP plan has a premium of, I believe, $7.50 per month.
Okay. We've gotten a few questions about the stabilization fund. Information provided to the council by OMB shows that the Health Insurance Stabilization Fund owed approximately $1.8 billion to the city as of fiscal year 22. Can you break down that figure further and identify how much of it is a result of paying the cost of GHI in excess to the HIP HMO rate?
So I can start out by answering that and then turn it over to Mr. Godner. So, we could provide a full breakdown of all the component costs, but the excess cost of the GHI plan over the HIP HMO plan was $152 million in fiscal year 21, $414 million in fiscal year 22, and in fiscal year 23 is $536 million.
Okay. Do you have information about where the Healthcare Stabilization Fund stands today?
Yeah, the fund owes the city approximately $1.8 billion for prior year charges for which we are due reimbursement.
Any more information?
Sure. There are about $900 million owed for welfare fund reimbursements for payments that were made to the union-administered welfare funds for actives and retirees. There's approximately $900 million of funds owed for the FY22 health settlement. That's the relating to the difference between the HIP and the GHI plan, the CBP plan, I should say. And those are the major areas. In addition, there are prior year settlements for which, and prior year welfare fund reimbursements for which the city has owed money.
What are the risks to the city's budget if we can't realize the annual savings of $600 million?
While the savings owed from the, that are expected to be achieved through the Medicare Advantage will be paid to the Health Stabilization Fund, because that fund owes the city substantial amounts of money. This would open a $600 million a year hole in the city's budget.
Can you walk us through the implementation of this plan and what that looks like if and when Medicare Advantage is put in place?
We anticipate that we would implement this plan sometime in the summer of 2023. We want to have about 6 months to really educate and inform retirees about the program. Aetna has planned over 200 in-person forums where they will speak about the plan and also bring counselors that can meet individually with retirees to talk to them about any transition of care issues and any of their concerns about the program. We'll also have online meetings with retirees as well as, of course, mailings and providing communication materials to all the retirees. We expect to have a very robust implementation, and that's why we're not rushing to do it right away, despite the fact that the city is losing $50 million a month for every month that we delay.
Is there a plan for retirees who live outside of the state or in areas where end up outside of the state, pretty much?
We are working out plans with Aetna for retirees that live internationally. There's only a very small group of retirees, something like under 200 retirees that live outside the country. They do. And there will be a plan for those retirees.
And outside of the state, retirees, the same?
Outside of the state, this is a national plan.
Okay.
This is
And
a national
what about-
plan. It will be the same throughout the country, and they have an extensive network outside the country. In fact, one of the complaints we often hear about the senior care plan is that there's not a network outside of New York.
So even in situations where a retiree would need a particular specialty or special type of care, you all are expecting that Aetna's coverage is sufficient to fill those needs.
Absolutely. They have nationally, I think the number of specialists was something over 400,000 specialists around the country.
Okay. At this time, I'm going to pass over questions to our colleagues because there's an extensive list of colleagues who have questions. Reminding colleagues that we have 3 minutes for questions. Okay, I'm going to call Councilmember Lee, followed by Councilmember Shulman.
Hi, everyone. Sorry I can't be there in person. Can you hear me? Hopefully you guys can hear me.
Yes, we can hear you.
Okay, great. So thank you so much, Chair De La Rosa and Speaker Adams, for hosting this hearing. This is definitely something we've been following for a while. And just as a bit of background, myself, I was in the nonprofit sector and I'm a social worker and have worked extensively with a lot of seniors in the city. And so this is an issue we've been seeing coming down the pike for a while. And so I know that you're saying that there are an extensive list of current providers that the retirees will be able to access through this plan. But I guess I'm just wondering, do you have any more detailed data? For example, have you guys taken a look at who the current retirees are using in terms of providers and how many and which percentage of them would also be accepting the new plans? And then also in terms of a larger question, sorry, I'll just go through my questions for sake of time. But also in terms of the bigger picture, let's just say hypothetically we were to change the code. I mean, my fear with this is that what are we doing about the general overall hospital healthcare costs? Because what about the Northwells, right? I live on the border of Long Island in Queens, and have the conversations been had with how to have cost savings there? And with the code changes, it doesn't solve the issue that these healthcare costs are going to be increasing, right? So even if, let's just say, we were to change the code now, I don't think in a few years we would be necessarily in a better state cost-wise. And so what are some of the additional things that the MLC OLR are looking into in terms of cost savings? Because I do think that this is going to be an ongoing issue. And my fear, to be quite honest, is that the people who will lose out the most are the retirees that are the poorest, who cannot afford the additional costs if they have to switch over. And so just wanted to know if you could delve a little bit into that. And then my final sort of question is, how are you addressing this in terms of utilization? Because my understanding is that the way that the insurances work is that in order to offset a lot of the costs of people who utilize the healthcare system more, you need to have a lot of healthy people who are buying into the plan as well, right, to balance that out. And so just wanting to know, what does that look like in terms of the members who are active and how that would play into this whole equation of balancing the healthcare costs?
Thank you for the questions, Council Member. So to start with the first one, the percentage of providers, the number from our testimony, the 95%, that is based on the current providers that retirees see. So again, that's 85% are in the Aetna network. Another 10% already have in the past accepted an Aetna Medicare Advantage plan. So that's kind of the baseline. And beyond that, we expect that number to climb substantially because, as Deputy Commissioner Levitt testified to, there's no reason for a doctor not to accept this plan. They are paid the same rate as original Medicare. So, through our outreach efforts and Aetna's outreach and education efforts, we expect that number to rise. Regarding overall health costs, we agree that we need to be constantly looking for savings to address overall health costs. That's why we put out a procurement for a new active and pre-Medicare retiree plan, which we hope to find efficiencies to provide additional cost savings, seeking savings of over $1 billion. And in terms of this particular plan, it's important to know that the cost of $0 is guaranteed for 5 years. So no matter how much general healthcare costs rise, the $0 cost to the city here is guaranteed for 5 years. I'll turn it over to Deputy Commissioner Levitt to address the questions about utilization. And just one more note, I know you mentioned the concern for lower income retirees, which we completely agree with and understand. And I'll note that the Medicare Advantage plan is a particularly good plan for lower income retirees. It has a lower deductible, it has lower copays, it has additional benefits, including transportation, and we think these benefits will really help our lower income retirees.
I think you raise a very important point about the fact that hospital costs and healthcare costs are rising constantly. This has been going on for decades now, and it's very, very pronounced in New York City. We are concerned about that, and we are committed to maintaining premium-free coverage for both our actives and for our retirees. What we're doing right now on the actives plan is we have a procurement out for bid to try to save up to $1 billion in healthcare costs through a new plan. And we don't know yet what that plan would look like, but we are looking at multiple different ways that we can save money going forward. The opportunity with Medicare Advantage is so pronounced because, in a sense, we're getting the federal government to cover the costs of our retirees. So it gives us the ability to provide the same and better coverage without it costing the city the $600 million we pay right now.
Thank you. I'm going to call on Councilmember Schulman, followed by Councilmember Arreola.
Thank you. I want to thank the Speaker and the Chair, De La Rosa, for having this hearing today. So here's my question. You talked about senior care being sort of guaranteed for 5 years. What happens after that 5 years?
Just to clarify, Councilmember, the $0 cost for Aetna Medicare Advantage is guaranteed for 5 years.
So what happens after the 5 years then?
So there's a cap on the increases that Aetna can make to the rates. Claire, can you expand?
Right, there are caps that will be part of the contract after that, but under our agreement with the Municipal Labor Committee, whatever those costs are, if they are above zero at that point, they will not be passed on to our retirees. Our commitment remains to provide a premium-free coverage for our retirees.
So, I'm sitting here, I'm listening to the testimony, and I'm trying to wonder if Medicare Advantage is so great, then what do you need the council to do here? I mean, if you're going to do that anyway. That's an issue for me. And so, and the other thing, too, is that my understanding, and I don't know if OLR is the right, you guys are the right ones to ask, but if we vote to amend the administrative code, we're taking away the right of the seniors to continue to litigate this matter in court. Is that correct?
So, Councilmember, thank you for the questions. In terms of why it's important to pass this amendment, we believe choice of plans is very important, and the Municipal Labor Committee, I'm sure you'll hear from them, I believe thinks the same thing, that we provide, many employers provide a single plan, and that's it. And they say, this is the plan we provide, you're stuck with it, whatever it is. And that includes many employers who have transitioned to a Medicare Advantage plan. We, with our active plan and retiree plans, have historically provided the choice to employees, and it's important to us to continue to do so. So that's why we really want this amendment, to be able to provide this choice. In terms of this amendment, affecting the opportunity to litigate this further, I think the administrative code in its current form, as the court held, pretty clearly allows the city to pursue the alternative it would pursue if this amendment weren't passed, which is to eliminate senior care. The decision explicitly said we should do that. So I don't think, I think failure to pass this amendment would kind of have the same impact on the litigation because the city would proceed along that path.
So that's a long answer to the question, but I appreciate it very much. I also want to ask, have any other resolutions or ideas been considered? Because I can't believe that at this late stage, the only option we have is to put this on the back of the retirees or put this on somebody else's lap. So that's what I want to know. And also, in addition, as part of that, were the retirees consulted on any of this?
So I would say that we don't believe this is on the backs of retirees. As we had said, we believe this is a very strong plan. But I will say that we are constantly exploring every possible avenue for health savings. We have not left any stone unturned. We've been working together for, like I said, over 8 years on this. We have experts that we both consult with, both the city and the MLC, and we have been constantly engaging in trying to find every opportunity to achieve savings. As part of this process, we obviously worked with our partners at the Municipal Labor Committee who, represent the interests of their active members and their retirees. And we worked closely with them. I think the collaboration we've had with them throughout this process is really, remarkable in the labor relations world, and we want to continue to do so.
I just want to say one quick thing, Chair, if that's okay. So I just want to say I looked through the testimony that you gave, including the charts about senior care. And so in addition to the $191 a month, there's co-pays and other costs here. So that's really, to me, not an option to folks that have made very little money and are trying to get by on their Social Security and their pensions. Thank you very much, Chair. Appreciate it.
Thank you, Councilmember Arreola, followed by Brooks Powers.
Thank you, Chair. So throughout your testimony, you refer to the Martin Scheinman document as an order, when it is actually an opinion. Because in order for it to be an order, then there would have to have been a dispute, and there was no dispute. So I'd like to know, why do you keep referring it to an order when it is an opinion?
Thank you, Council Member. Respectfully, I would say there was a dispute. The dispute was that the city and the MLC had agreed to certain health savings in prior agreements, and those savings, largely as a result of the delay in implementation of Medicare Advantage, had not been realized. And the city requested a resolution to that failure to achieve those savings. So it was on the basis of that the arbitrator had the authority to resolve that dispute and tell us what the path forward was.
Mm-hmm. But on Martin Scheinman's actual order or recommendation, it says, it is my recommendation. Doesn't say order, it says recommendation. I just also want to go to, because I don't think it was clearly stated by you, and I know that you intend to do outreach if your measure passes, but what specific outreach did you have with the members and the retirees? Because to our knowledge, there was no initial outreach, and this came as much as a surprise to them as it did to this council.
So, referring to the Scheinman decision, I would just say that, the city did ask the arbitrator to resolve the dispute, and, that's what we believe happened.
No, I'm not talking about that anymore. What outreach did you do?
So I'll turn it over to Deputy Commissioner Levitt to talk about the outreach under the prior insurer. There was,
prior.
As we know, there was initially the provider was going to be the Alliance.
I'm sorry, just a minute more. That's not, there was no previous outreach. That's obvious in your roundabout answers. But I just want a yes or no to my colleague Lynn Schulman's question. If the administrative code is changed, does that negate the chance for our retirees to go to litigation? Yes or no?
No, they always have a right to litigate whatever they choose.
That is not true.
Thank you for your questions. Councilmember Brooks, Majority with Brooks Powers, and Councilmember Kagan.
Thank you. Thank you, Speaker Adams. Thank you, Chair De La Rosa, for your leadership on this very tough issue. We've all heard from thousands of retirees over the course of the last few months. And for me, and I'm sure many of my colleagues share this perspective, it's important for us to make sure that we are not leaving our retirees vulnerable in a challenging state. And so I just had a couple of questions in terms of looking for clarification, because obviously we've been getting a lot of incoming, so I'm just trying to know what's fact and what's not. So a couple of questions. Can you detail what happens if the council fails to pass this legislation? Because we've heard a couple of different things. I just want to understand what legal options will remain available to the retirees if we pass the legislation versus if we do not. I know it was asked before, but I was not really clear on that response. And what sorts of choices might the council have to make after litigation is pursued in order of like plugging whatever financial gap there is?
Thank you, Council Member. So in terms of how this would proceed if the amendment is not passed, if the amendment is not passed, the city will move forward with implementing the Medicare Advantage plan this summer. And as part of that, when that plan is implemented, senior care and any other plan that has a cost to the city will be eliminated.
Does that mean that their choice will be removed, essentially?
Yes.
There's been requests for a Blue Ribbon Commission. Can you talk about the feasibility of establishing a Blue Ribbon Commission to identify ways that the city can save on healthcare savings, and also why hasn't that been something used from the toolbox up until now?
So, you know, as we've said, we've been working with the Municipal Labor Committee, including, you know, the Tripartite Committee, many other committees, and including experts from, you know, renowned healthcare consultants to look at health savings over the last, you know, almost 10 years. We've been engaged in that effort on a constant basis. We certainly, you know, welcome input from anyone else, but this is not something that we've, you know, not looked at or ignored. We've been looking at this practically every day.
And you haven't seen the need for the Blue Commission? Like, why hasn't one been put together?
So, you know, I am not familiar with the, you know, proposal, so I can't speak to it, but, you know, we certainly look at any proposal.
Thank you.
Thank you. I also want to recognize we've been joined by Councilmember Velasquez, now going to Councilmember Kagan, followed by Palladino, followed by Barron.
Thank you very much. So I have questions about pharmaceutical coverage. If a Medicare-eligible retiree has their own standalone private pharmacy plan or their own supplementary private pharmacy plan, would they have to give up this plan to join the Medicare Advantage program?
If they have a private pharmacy plan that's an individual Part D plan that they've purchased from Medicare, they would have to purchase, they would not be able to keep that, they would have to purchase the Aetna plan. If they have coverage through a spouse or some other coverage that's not through a Medicare Advantage plan, they could keep that. There are also people who have limited welfare fund coverage and want to be able to purchase the rider on top of that limited welfare fund coverage, and we've made arrangements for that as well. But it's a Medicare rule that you can't have a Medicare Advantage plan and then an individual Part D drug program.
And another question, would you consider other savings besides what you're suggesting, like to lower exorbitant costs that private hospital charge, also like to audit fraud of insurance companies, to other measures that will find more than $600 million a year, I guarantee you? We have
been implementing changes to the plan since I came on board in 2014. We have had We've identified in the first round of healthcare savings, we negotiated with the MLC $3.4 billion in savings. And then in fiscal 19 through 21, another $1.1 billion in savings. We have looked at every possible way. We have done audits of our insurance carriers. We have done audits to make sure that dependents that are on the plan are eligible dependents. We used behavioral economic techniques to encourage people not to go to the emergency room by putting $150 copay on the emergency room unless you're admitted to the hospital, and $50 on urgent care to encourage people to go to primary care doctors instead of urgent care or the hospital. And we were successful in reducing the number of emergency room admissions and urgent care admissions. We have looked at everything. What's such a great opportunity for the city with this Medicare Advantage plan is that because the federal government is paying for it, we're able to not cut any benefits. We're able to give our retirees even better coverage than they have right now without the city paying for it. It's a unique opportunity, and it's an opportunity that's been pursued by most of the states around us, the state of New Jersey, the state of Connecticut, Pennsylvania, Ohio. They've all implemented, and when they implemented it, they implemented Medicare Advantage only with no choice.
I represent Southern Brooklyn. I do not represent Pennsylvania. I'm sorry.
Thank you. Thank you, Councilmember Kagan. Councilmember Palladino, followed by Councilmember Barron.
Good morning, everybody. I can't tell you, when I look around the gallery and the chambers, how it warms my heart to see all of you here today. You indeed brought your voices to City Hall, and that's why we represent you, the people. So it gives me great pride, as a senior citizen myself, to say welcome to City Hall. Your voices will be heard here today. I want to start first with saying Martin Scheinman's document is a transparent and futile attempt to make it seem like the city is being ordered to take away traditional Medicare from retirees. The document does not and cannot require the city or anyone else to do anything. And the city council should not be assisting him in this charade, amending section 12-126. Give the retirees the chance to fight and win in court. With the current version of section 12-126, which has existed for over half a century, if they lose, the city council can always amend the statute later. Now, here's a question. I'd like to know where the $600 million figure came from. Isn't the UFT and the MLC responsible for repaying the $1 billion that was used for the school teachers' wages?
Please remember this.
Right.
Thank you, so that we don't interrupt Councilmember Palladino's time. Thank you.
Okay. And why are we putting this on the retirees? If you take away 12-126 cap, how does this protect the senior care? If you take away the 12-126 cap, how does that protect actives? Why would you impose premiums on retirees on fixed income pensions of $191 a month for senior care, which pays for less than 20% of the retirees' health care costs, and not impose costs on the active employees whose insurance pays for all costs? Thank you.
just to start with, the first question about the $600 million. So the parties had agreed to pursue this plan, and any savings achieved from that plan would be redirected to the stabilization fund. The $600 million is based on the fact that the bids we got, that the insurers are willing to provide this program at zero cost. So $600 million is what we currently pay for senior care and other plans that have a cost. So that's where that comes from. It's completely unrelated to the $1 billion you referenced from the 2014 Health Savings Agreement. I want to go on to your question about why we're doing this with retirees. So, we have...
No, I'd like to know, why isn't the UFT responsible for repaying the $1 billion that we used for teachers' raises? What is the UFT doing?
Thank you, Councilmember Palladino. You asked your questions. Okay. Please let's allow them to respond. Thank you so much.
So I'm not going to answer for a union on something about what they did, but the $1 billion you referenced, that was pursuant to an agreement with the Municipal Labor Committee in 2014 to withdraw that money to support the labor agreements in that round of bargaining. And I'll also note that that $1 billion is a one-time $1 billion. What we're talking about here is $600 million per year, every year, for at least the next 5 years. And if it's not $600 million beyond that, it'll still be a substantial amount because of the caps on rate increases that we mentioned.
Thank you. You said another thing, yes. Can you go on the next round? Because we have about 14 other colleagues. It's okay. Second round, Palladino, we got you. Councilmember Barron, followed by Councilmember Nurse.
Thank you very much. It's interesting how facts can be so conflicting. It is interesting how when facts are presented, that the facts on one side, the facts on another side, what is a fact? It's very confusing. And there was no objective presentation to this council where they said, we will present the facts. But when we look at the facts, there's some refutable evidence of these facts. I want to start off with asking a question about Aetna, and then I'll ask other questions. And since I only have 3 minutes, I'll ask the question, say what I have to say, and then you can respond to the question. Is Aetna under investigation? And it's a parent company, CVS. Are they under investigation, number one? And number two, I would never, ever, and no black person in this audience, no person of goodwill in this audience should ever support Aetna getting a contract from the government, because this is the same company that provided insurance to slaveholders during the enslavement period, and when we took them to court, they admitted it and said, yeah, we did it, sorry, and that was it. So we should not be doing any business with a corporation, a company like Aetna that was engaged in the slave trade in the slave era. Having said that, I think that we're going to have problems with the priority authorization part. That's going to be a problem. I think that the healthcare system that the seniors, that the retirees have now, I think that we should honor and respect that. I think also we're talking $600 million out of a $104 billion city budget, and there's a $220 billion state budget. So I think $600 million out of $104 billion, and we have a reserve fund of $8.3 billion already, and you already gave the police $11 billion and cut the education by $400. Now we want our seniors, our retirees to pay, and some of them were making $40, I'll finish in a second, $30,000 and $40,000, $50,000, so now they have to take that, pay $191 a month, and if there's 2 or 3 of them in the house, that's 2, 3, 4. I want to unequivocally say we should vote no on this, and I unequivocally support our retired, our retirees.
Thank you. All right, the clapping, please. Every time we clap, it takes time away from answering the question or asking the question. There are over 100 people registered to testify today. And so please, let's be patient.
There's another reason. There's another reason why we refrain from applause in the gallery. It is so that the hearing impaired may participate, right? They cannot hear us when we do this. When we do this, it's participation for our hearing impaired as well.
Thank you.
Thank you, Madam Chair.
Yes.
Just the question, I believe, was about an investigation. You know, I'm not sure what that investigation would be, but we should look into it further.
Thank you. Councilmember Nurse, followed by Councilmember Bottcher.
Thank you, Chair. Thank you to everyone who's here today. I just have a few questions for more context information. So one of the things that was testified is that there has been the threat that co-premiums for active employees would increase. Can you give a concrete estimate of what that would be?
I think we would have to get back to you with details on that. I believe in the award, the arbitrator referenced, you know, approximately $1,200 per month, but I would have per year but I would have to get back to you with more concrete numbers.
Would love to get that follow-up.
Yep.
Councilmember Schulman had asked about the cap after 5 years. Can you give more details about this? Is there a percentage? Is there a number you can share with us about that's in your conversations?
I'll have to get back to you with the details on that. I don't have the contract draft with me, but there are specific caps in it, and they're pretty, it's pretty low. The premium would be.
But it's low, but you don't have a number or percentage to offer.
I think it was actually a dollar, a dollar amount.
Yeah, we can get back to you with details, Council Member, on what the caps are beyond the 5 years. I believe it was dollar amounts, and there may have been also certain restrictions based on what happens with Medicare reimbursement.
But you'll follow up with a more concrete,
yes, absolutely,
numerical data. Great. 2 more quick questions. The $15 copay to certain benefits in the senior care plan that you would have implemented, that was agreed upon between the MLC and the city, what savings would that have produced?
We did implement that.
Yeah, just to clarify, that was implemented in 2022, but you're looking for how much savings that produced?
Yes.
Just give us a moment to see if we have that.
No problem.
As we prepare for that answer, it will be Councilmember Bottcher, followed by Councilmember Brewer.
I think we'll have to get back to you with that as well.
No problem. Seems we need a lot of follow-up.
Yeah.
My last question, and it is the last one, Councilmember Chair De La Rosa had asked about, or somebody had asked about some of the pre-authorized things. In the testimony, you said only 1% of all claims would require pre-authorization. Could you give a little more specificity on what types of claims those would be?
Thank you. I can. We have a listing from Aetna of the types of procedures that would be subject to prior authorization.
Can you go a little closer to the mic and speak up a little bit louder? Thank you.
Sorry. We do have a list of things that would require prior authorization. And as I said, it eliminated a lot of the prior authorization for items like MRIs and PET scans and CAT scans. Inpatient stays would still require prior authorization. Certain types of surgeries would require prior authorization. Certain types of durable medical equipment would require prior authorization. Spinal procedures, reconstructive procedures, and certain medications.
Do you
But
think
the
you could follow up with just a list more
There
concretely
is,
so we
yes,
can have that?
I will send you the entire list
Yes.
of
Thank you.
services that require pre-authorization.
Thank you. Thank you, Chair.
Thank you. If you could submit that to the committee, we'd like to look at that. Councilmember Bottcher, followed by Councilmember Brewer.
Hi. What I'm not hearing a lot about today is what has gotten us into this situation, which is the private hospital systems that have been engaging in price gouging and overcharging for years and years, and who are continuing to do it. We all know about the $1,000 COVID test that city workers have been charged for. And what I'd like to know is what the Adams administration is doing to address price gouging. Councilmember Menon has a bill that many of us are co-sponsoring that would require hospitals to be transparent about their pricing. What are you doing about price gouging in hospitals?
To begin with, that affects our actives plan very significantly. It does not affect the retirees plan because in both Medicare and Medicare Advantage, the hospitals are paid at the Medicare allowable rates, which are much lower than the commercial rates that we pay for our actives. We have been very, very concerned about hospital pricing, and I'm sure you've seen some of the information about the difference between pricing at different hospitals. We have tried over the years to negotiate with some of the higher priced hospitals to see if we could get better discounts for the city, and we have been basically met with deaf ears by the hospitals. What we're looking at now is in our procurement, we're looking for different strategies to address the hospital pricing, whether it be changing our hospital network or setting fixed fees. We've gone out to all the local insurers and asked them for all of their concepts for us to consider on how to address pricing. And the largest part of that pricing is hospital. And I'm running a close second in terms of high pricing is prescription drugs. And in both those areas, we're looking for new strategies to address them. But it really isn't relevant to the retirees' coverage.
I understand that what we're talking about today is an effort to pass those costs along to the feds. But what we're not hearing about, what I'm not seeing, is any anger or passion about what's happening in our private hospitals. And I'd like to see a lot more effort put into stopping this overcharging and this price gouging.
Thank you, Councilmember.
I just want to comment that, I don't know you and you don't know me, but this is one of my passions. I've been exceptionally angry and exceptionally focused about the price gouging, especially by particular hospitals that have been, I think, have been outrageous in their pricing and have expressed no willingness to work with the city or anybody else to reduce those prices. And it is actually one of the passions that brought me to city government. I was fighting it on a much smaller scale with a smaller fund, with a smaller trust fund, where I was executive director of a trust fund. And it actually is one of my passions, and I would be glad to talk to you further about it.
Thank you.
Thank you. Councilmember Brewer, followed by Councilmember Krishnan.
Thank you very much, and thank you to the chair and the speaker. So I'm sure there are people who will testify today because they have told me that they have cancer and they have a particular prescription that they need, maybe for blood thinner or something else, and they're able to get it now. The doctors have told them that they would not be able to get it under managed care. So how do you handle that question? Now, maybe the doctors don't know what they're talking about. Maybe you have a different plan than what the doctors know, but that is the universal discussion that is going on today. So how do we answer that?
I can completely appreciate that fear that retirees would have, that their drugs would be discontinued. But what we know from Aetna and from the plan that we've negotiated is that the drug formulary that we have is the same as the drug formulary that they have under senior care, and that they will be able to get the same treatments that they were getting before.
Okay. I mean, I know you say that. I'm just letting you know nobody believes it. Whether
I hear the distrust. I hear the distrust in the room, and I think it's up to us in the administration and up to Aetna to address that distrust and address those fears. That's one of the reasons that Aetna plans to bring people to the in-person meetings to meet individually with retirees and talk to them about their specific situations.
Okay, how much did the city spend on GHI? This is a money issue because we're all trying to find money. How much did the city spend on GHI senior care and the other retiree Medicare plans in FY 19, 20, and 21 compared to the projected $600 million per year?
The $600 million is what we spent.
Each one of those years?
It was probably a little bit lower
It's been trending
prior years.
up, and
It's
I think we
been
mentioned
trending
that
up.
in the testimony, right, that back in 2000 we were spending about $200 million, so you can see where the trend has been.
And those were the numbers that you listed earlier.
Yeah, that was in the testimony.
Okay.
Right, I don't have those particular fiscal years.
Yeah, we can provide the specific fiscal years.
Okay, that would be,
numbers
I would
for you.
appreciate that, thank you. Second is, how much has the city saved, again, on the money issue, trying to find money, on providing new hires with HIP as the only option? What percentage of those new employees changed coverage to another plan after the one-year waiting period? And what are the additional savings accruing based on this factor?
I think we'll have to get back to you with the exact number and the savings. What I can tell you is that people do seem to be satisfied with the HIP HMO coverage when they've gone into it, and over 95% of the people that have the first-year city employees that have gone into HIP have stayed in the HIP program.
You say 95% have stayed in the HIP program?
Have stayed,
That's
yes.
what you're saying? Okay. And then finally, again, these are, why not continue to offer senior care premium-free while marketing these supposed advantages of Aetna's plan and encouraging retirees to join? That would generate some savings. $600 million isn't enough to solve the stabilization fund savings issues.
So any subsidy will reduce the amount we save, and we also fear that it would endanger the procurement, which was not set up to have a subsidized senior care option.
Okay, I mean, I think we're all trying to say is there is hopefully another way to get to what we're all trying to do. We understand on both sides of the coin, we have a $600 million gap that could be increasing, but we have, whether it's distrust, whether it is reality of not having the correct amount of senior support in terms of their medical, and it is, I have to say, it was a promise. It may not have been the best promise, but it was a promise, and that's why I am so concerned about this particular plan. But I appreciate the work that you're doing. I know you are caring about the same population as we do, but there is a lack of trust that whatever Aetna is going to offer is going to be what takes care of the people who are perhaps our most treasured former employees. Thank you.
Thank you, Councilmember. Councilmember Krishnan, followed by Councilmember Hudson.
Good morning, and thank you so much for your testimony today. I just have a few questions, and first I want to say thank you to Speaker Adams and Chair De La Rosa for hosting today's hearing. My first question is, health insurance, healthcare is a very complex field. There's a lot of statistics and terminology being used, but I want to keep it very simple and reduce it to just a couple basic issues. First is, as you're probably aware, there have been a number of reports and investigations about Medicare Advantage and the problems associated with it. There was a full New York Times expose. There was a report by the federal government, by the Department of Health and Human Services that I read about all of the issues with Medicare Advantage. And so knowing that, how do you respond to the problems and concerns raised by our own federal government and others about concerns from denial of care, having to seek numerous approvals that were denied about it? How would you respond to those charges and findings?
We've read the same New York Times articles, and I think it's true that practices of some Medicare Advantage plans have been appropriately questioned by the New York Times and by others. But we feel confident that the plan that we've developed with Aetna is not going to be subject to those issues. First of all, it's a PPO plan and not an HMO plan, so a retiree can see any Medicare provider. We also negotiated with Aetna to remove, more than 70% of the prior authorization requirements that were a discussion of most of these articles. We also intend to oversee this program with a great deal of attention. In the individual market Medicare Advantage plans, which really were the ones that were a subject of the New York Times article, don't have that kind of oversight. And we intend to be looking at reports, and we intend to be addressing any kinds of issues that come up. Our retirees will have not just the people at Aetna, but the people at OLR and the people at the Municipal Labor Committee to go to with any kinds of issues that come up. We have performance guarantees in our contract with significant financial penalties if they don't meet certain requirements. So we're not unaware of the issues that you raise, but we've taken steps to address those issues in our agreement.
And I just have two more questions too on these points. My second question is, this matter seems to me has not been fully litigated in the courts yet, or at least to the extent that it has, it was a judicial ruling that went the other way from the proposed change being sought. Can you specifically explain, with the proposed amendment that you all are seeking, how the impact on the litigation that the retirees who want their day in court are seeking, and not in terms of file a lawsuit, but specifically what claims, because I imagine we take legislative action, it will have an effect. So what claims will be precluded from that lawsuit, and what claims will survive it?
Thank you, Council Member. So I'll try to answer that. So I think, there are two paths forward. One, with this amendment, there would not be the opportunity, with this amendment, and we charge retirees a premium to remain in senior care, they would not have the opportunity to say the administrative code prevents it, because we've just amended it to allow that. If the code is not amended and we move forward with eliminating senior care, I think similarly, there's there's no route for them to litigate the, successfully based on the administrative code, because the court said that we could do that. The court already said we could eliminate senior care, that we don't have to offer a specific plan, and we could move forward on that basis. As to other claims the retirees may have, or retiree groups, if they're based on other statutes, they could continue to litigate those.
And so, thank you. And before I ask my last question, that's my
Please wrap,
concern.
because we have about 10 more members on this list, and then second round.
Thank you, Chair. Last question is just, that's my concern, is that the hard litigation would be removed if this goes forward. But given all of that, the investigations, the effect on the litigation, can you explain, as I said before, health insurance is very complicated. Can you explain in 10 seconds, because clearly I'm over time too, how this would be good for a senior on fixed income that can't afford to pay the $200 a month if the code is changed, has a number of health ailments? Can you explain in 10 seconds how this would be a good benefit for seniors?
I think actually this is a great benefit for seniors on a fixed income, that it has a lower deductible, it has lower copays, it provides additional benefits like the transportation benefits and the healthy meals benefit that they don't have right now. I actually think that this is a much better plan for retirees in general, but specifically for low-income retirees.
And I apologize, I know this is more than 10 seconds, but I'd also add the out-of-pocket maximum. The fact that there's no out-of-pocket maximum under the current senior care plan. The Medicare Advantage plan we're proposing would have a $1,500 out-of-pocket maximum. That's a degree of protection that would be very important for low-income retirees.
Thank you. I want to recognize that we've been joined by Deputy Speaker Ayala, Majority Leader Powers, and Councilmember Gutierrez. Up next is Councilmember Hudson, followed by Councilmember Ressler.
Thank you so much, Chair. Simply put, what can the city do right now to ensure that every retiree continues to receive senior care at no cost to them?
So I would say that if we're not able to achieve the only way to have senior care at no cost to retirees is for the city to pay that cost. And if we're not able to achieve the $600 million in savings through this effort, then we're going to have to look at other hard choices, including, as the arbitrator mentioned, co-premiums on active employees.
Okay, thank you. And then what was the opt-in rate for GHI senior care when the city offered retirees with the choice to maintain their current care for a $191 monthly fee?
So in July, at the time that the previous provider withdrew, I believe there were around 63,000 opt-outs out of 250,000 covered lives.
Okay, thank you.
But I would note that for a new plan, those opt-outs would need to be redone.
And do you have an understanding of how many current retirees can reasonably afford a $191 monthly charge? Do you have the breakdown of current city retirees disaggregated by annual income, rent burden status, and other indicators of economic health?
That's not information I believe we have.
Is it information that you could get?
We would be able to provide, breakout of retirees by what their pension amount is, but that doesn't certainly answer your questions. If they have another income, another pension, someone else in their family, and certainly we don't have information on what our retirees pay in rent.
Okay, so just for the record, you don't have a sense of how many retirees would actually be able to afford the $191 monthly charge?
I think it would be difficult, no matter what data we had, to answer that question.
What was that?
I said, no matter what data we have, I don't know exactly how we would be able to answer that question.
Okay. And then just lastly, can you walk through the various federal subsidies the city would receive by transitioning retirees to a Medicare Advantage plan, including how much the total would be, the length of the subsidy, and the amount of each?
Under the Medicare Advantage plan, the federal subsidy is supporting the entire $600 million current cost. That's why we're saving $600 million. As far as I know, Congress has no plans to stop offering Medicare Advantage plans. obviously we're all subject to whatever laws get passed. In terms of our arrangement with Aetna, we have this rate lock-in, irrespective of those factors, for the next 5 years, and afterwards there are capped increases after the 5 years.
Thank you.
Thank you, Councilmember Hudson. I have actually a follow-up question. At this point, do you all have data on opt-out options for Medicare Advantage? Like, has anyone opted out? Do you track?
We do. We have not yet offered the new plan, so we won't have statistics on how many people opt out until we offer it.
Okay. So there's no information right now of any retiree previously opting out of.
So there were 63,000 retirees who opted out when in 2022 when the plan was initially going to be offered. But we would have to, with the new plan being offered in 2023, we would have to redo that.
Okay, that was the number, 63. Thank you. Councilmember Ressler, followed by Councilmember Menon.
Thank you so much. I especially want to thank Chair De La Rosa and Speaker Adams for creating the space to have this conversation and to provide some significant oversight on this issue. And thank you, members of the administration, for appearing before us today. I will just express plainly that I am concerned that people spent their careers working for the city with an understanding of what their retirement benefits would be, and we're being asked to change that midstream. But I do want to ask you about what I think is the nightmare scenario of the administration unilaterally forcing everyone, all retirees, onto Medicare Advantage, the retirees going to court and losing. What would happen next? Does the administration commit that there would be an opportunity for optionality for retirees at that time, creating an opportunity for the council to re-engage, for the Aetna agreement to include optionality based on the scale of the number of retirees that would be a part of that plan? Is that a commitment that you can make to us today?
So I don't believe it's a commitment we can make today. I think that if we move forward if this amendment doesn't pass and we move forward with eliminating senior care and implementing Medicare Advantage, and whether or not there's litigation, if that moves forward and we've ceased our contract with senior care, I'm not sure about the ability to even reinstate that. That's something we'd have to get back to you on.
Why?
Well, there are certainly procurement rules for the city. I'm not sure once the contract is terminated if it can simply be, revived.
But isn't that the contract that's available to current actives as well? So it's not terminated altogether?
No,
it would be.
It's different, Councilmember.
So this would be terminated, and so but when would it be terminated in that scenario? Conceivably there'd be an injunction by the judge that would hold off on the termination from occurring, and at that time, if the judge were to rule in the administration's favor, you would have a choice. And I do think it's an important choice for us to consider together. Would you callously, heartlessly, vindictively force every retiree onto Medicare Advantage, or ensure that there's an opportunity for optionality at that juncture?
Well, first of all, I'd just like to say that we think this is an excellent plan. We don't think it's callous to put retirees on this plan. But I think it's honestly unpredictable how the future would go if we went down that path. We would have to proceed with eliminating senior care, and while we implement the Medicare Advantage plan, I don't believe you could suddenly, just out of nowhere, on a short time frame, have an opt-in process. I'm not sure about the ability to cancel the contract.
I want to be sensitive to the chair's management of the timing, but I do just want to say plainly, I think it's critically important that as you negotiate the Aetna plan, you protect that optionality, that you would anticipate a reality of the council not acting and you all deciding to force every senior onto Medicare Advantage, or a world in which there's optionality, so that's baked into the agreement that you have with Aetna, and however this plays out in the courts, if the council chooses not to act, that there will be an opportunity to ensure that seniors have choice. I haven't read the Aetna plan, we haven't seen it, so I can't tell you with any confidence what's in there. I do hope, when will we be able to see the Aetna plan?
So we provide some details of the plan in our
when will
testimony.
we be able to review it in writing, Dan?
We can provide in writing additional details of the plan. We're also, working hard to finalize the contract, and, at that point we can provide further details.
This week? Today, tomorrow? When are we going to be able to review the plan comprehensively? We can't vote on something if we don't know what the choice is. So it's impossible to ask us to take that action if we don't know what we're looking at. And I appreciate your testimony, but all right, I got to stop.
We can provide details of the plan. In our testimony, we've provided a table showing many of the details. We can provide more details this week as well. And, you know, we will provide those details as soon as possible. But I do want to say, you know, as we've discussed, this amendment isn't about the plan moving forward or not. It's about whether we can provide choice to retirees when this plan moves forward. That's our view of this amendment.
Thank you.
Thank you, Council Member. We've been joined by Council Member Lewis. We have up next Council Member Menon, followed by Council Member Velasquez.
Thank you so much. I first of all want to thank the chair and the speaker for holding this hearing. So currently we are spending 10% of the city budget, or $11 billion, on healthcare costs. As my colleague Councilmember Bottcher mentioned, I have a bill, as you know, to create a healthcare accountability office, which could potentially save up to $2 billion. So first of all, I know that's not the subject of this hearing, but I hope the administration is strongly going to testify in favor when we do have that hearing, because that bill is supported by 41 of my council colleagues. My question is, currently now, as Councilmember Bottcher mentioned, we have enormous price gouging at hospitals. For a woman who's giving birth at Montefiore, they're being charged $55,000 for childbirth. At another New York City hospital, it's $12,000. A routine colonoscopy is $10,000 at one hospital, $2,000 at another. So my question is, why hasn't the city issued an RFP in the past decade to renegotiate with the insurance carriers to drive down costs?
Thank you for the question. I'll say that that's exactly what we're doing right now. We have issued a procurement, a negotiated acquisition for a new health plan for active employees and pre-Medicare retirees, and part of our goal in that is to achieve savings, including through hospital costs. So that is exactly an effort we're engaged in right now, and our goal is to save over $1 billion through that effort.
So why right now does New York State have the highest per capita average of healthcare costs? What else can we be doing as a city to drive down these costs?
Well, we think that hospital costs are one of the most significant contributors to that, and we've specifically asked the insurers for their strategies for addressing hospital costs as part of this procurement. I think that we have to make some hard choices about how we're going to address the hospitals that are really intransigent about negotiating with us and are charging in some cases really exorbitant fees. The differences you're talking about are really significant hospital to hospital, and I think that we want to find ways to direct our employees to centers of excellence that provide top quality care but don't charge the top prices. And one of the things that we've learned in looking at this is that quality and cost are not necessarily related. I mean, people believe wrongly that the hospitals that charge the most are the best hospitals, and that's not borne out in the data.
Thank you. Council Member Velasquez, followed by Council Member Aviles.
Thank you, Chair De La Rosa. Thank you, Speaker, for holding today's hearing. It is very important for the retirees in my district to know that we are present today and we're listening, we're hearing. This is not an easy topic. It's very nuanced, and we are here to get to the bottom of it. I have a lot of retirees that are on fixed income, so $191 is a lot. I said, if we go back to what we are really looking at, I just want to go back to basics, right? One, what does this stabilization fund actually cover?
Sure, I can cover that, and I mean the answer is a lot. You know, it covers. It was originally established to cover the difference in cost between the HIP HMO plan for active employees and the GHI plan. So, you know, our employees have an option. There are two premium-free options. There's HIP HMO and there's GHI, which is provided currently by Emblem Health. previously by a predecessor company. And both of those are premium free. So the purpose of the stabilization fund was when the cost of GHI is higher than the cost of HIP, that the stabilization fund would bear that cost, since the city's obligation is only to pay the cost of HIP HMO. In addition, over the years, the MLC and the city have used the stabilization fund to cover a number of other incredibly important programs. One is for specialty drugs. Injectable and chemotherapy drugs are paid for by the stabilization fund. There's also numerous other benefits. I'll let my colleague Claire Levitt kind of go into detail of some of the other benefits that it pays for. It also pays for $165 per member per year, per employee and retiree per year, contributions to the union welfare funds, which go to drug benefits, dental, vision benefits, and those are payments we've had to suspend because of the fiscal situation of the stabilization fund. Claire, if you could expand on that.
I actually think Dan covered most of it. It includes the specialty drugs. Did you mention that? So I think you pretty much covered it.
And I know we've talked about this a couple of times, but I just want to get more clarity. That does voting on this amendment allow retirees to preserve their choice for health care?
Thank you, Councilmember.
And the answer is yes, and that's why we are supporting this amendment. We believe it's important to allow retirees to continue to have that choice. That's always been our intention, negotiating with the MLC, and we would like to be able to offer that option.
Thank you. Councilmember Aviles, followed by Councilmember Farias.
Good afternoon. Thank you, Chair, and thank you, Speaker, for this hearing. So as Chair of the Public Housing Committee, I know that privatization of a public good might lead to cost savings, and certainly is the argument for privatization often, but often results in confusion and diminishment of rights for residents. And let me be clear, healthcare is a human right. Time and time again, we see workers and residents in our city promised one thing but given another. In this hearing today, we have been told that we would see a draft of the Aetna contract. I just want to underscore, we want to see the full draft of the contracts, because we have not been given any documentation, any full documentation, either on the stabilization fund and how it was used, or on any of these draft plans. And we're expected to just trust tables of extraction. So we'd like to know, we'd like to see the full draft contracts. We'd like to see the full books for which this council is being asked to vote to change a 50-year-old law that protects our retirees without being given the full explanation and the full accounting of what has transpired in the stabilization fund. Can you tell us what the sustainable solution is here, other than kicking the can down the road for 5 years and putting our retirees at great risk and breaking a fundamental promise that was made to them?
So I just want to start by saying, we will provide additional details of what we expect the plan to be, but I'm not sure we are able to provide a draft of a contract that's not been finalized. We'll, certainly get back to you on whether or not we're able to.
Why is that, sir?
I'm not sure of the legal restrictions on whether or not we're able to do that. I would need to get back to you.
So you expect this council to vote on matters without having given them the full explanation and data?
We intend to give you all the data and details we're able to give you at this point, and we'll continue to provide more as we're able.
What is the sustainable solution that you've proposed here, sir?
So this is part of, I would say, Council Member, this is part of the sustainable solution. So what we're looking to do is to make changes to both our active and pre-Medicare plan and our retiree plan that provides substantial savings to put us on a course of sustainable premium-free health coverage. As we mentioned, other employers across the country, other municipalities, the state, have simply passed on the premiums to their employees and retirees and are providing no premium-free options. by utilizing the federal funding provided to a Medicare Advantage plan, we have this opportunity to create a plan that provides excellent benefits while not having a cost to the city. So we believe, and with caps beyond the 5 years. So we don't think this is kicking down the road. We think this is part of a sustainable solution. And the other part is the changes where it's pouring into our active and pre-Medicare plan with our procurement.
Who is making the decision that it's either A or B? It's either this or no coverage.
I don't believe that no coverage is an option. We are committed to providing premium-free
Or
coverage.
the lack of choice, rather.
So, we need to achieve the savings that have been set out. The court ruled that essentially the only way to do that, absent, an amendment to the administrative code, was to eliminate choice.
Thank you,
The court did not rule that, sir, for the record.
Okay. Thank you, council member. We have council member Farias, followed by council member Marte.
Hi, folks. I just want to get to questions. So, in terms of the cost savings, I've received a packet about a list of around 9 different cost savings from retirees that they have presented. How many of those have you folks entertained or looked into?
So, I'll turn this over to my colleague.
Sure.
Yeah, we've seen lists from the retirees about different approaches to health cost savings. We've looked into all of them.
Okay.
We've been at this for the past 8 years, turning over every rock we can. One of the things I saw that they suggested were audits, and we have done audits. We've audited both our major carriers, and we recovered some money through those audits. We've done dependent eligibility audits where we saved a great deal of money because it was never done before in the city before 2014. We are working at turning over every rock, and we appreciate input on that. But we really have been very assiduous at looking at every possible alternative. We've worked with the Municipal Labor Committee, and we've worked with consultants that are experts in the field that report to both the city and the Municipal Labor Committee. So we are very dedicated to finding different approaches.
Sure. And then in terms of choosing an option where retirees pay more versus current members take on a lift of a cost, have we evaluated that?
Have we evaluated?
Choosing to increase deductibles or increase fees for current membership versus retirees lifting a cost?
But we're not increasing the costs to current retirees. We're meeting our obligation to provide a premium-free plan for retirees permanently. And we don't intend in any way to reduce that commitment. The plan is a different plan. It's a Medicare Advantage plan, and it's funded by the federal government. But it is as rich a plan with additional benefits and some improvements in the benefits that I pointed out earlier.
Are you saying the $191 is non-existent for retirees? That's what I'm asking.
The $191 was the 2022 rate for buying up to the senior care plan. We believe the senior care plan is not as good a plan as the Medicare Advantage plan. The benefits in the Medicare Advantage
Please limit your comments.
The benefits in the Medicare Advantage plan are better benefits, and people can have that with no premium.
Okay. I feel like I don't want to beat a dead horse. I just have one last thing. In terms of the Aetna deductible being guaranteed for 5 years, do we have any guarantee that the percentage increase, that there will not be a percentage increase post 5 years? Like, are we dependent on a private corporation to say they will only increase by 1%, or are we trying to guarantee that in this draft contract that we cannot see?
If there were an increase, the increase would be borne by the city, not by the retirees.
Thank you. Go ahead.
No,
You can go
that's
ahead.
not what I asked.
Is that it?
Okay. Well,
Okay.
what I'm asking is are we guaranteed that the healthcare coverage itself, that the corporation itself, Aetna, will not increase by 10% versus 0.5%?
In other words, changing the benefit plan? I'm sorry, I'm not understanding the question you're asking.
We're guaranteeing the deductible of $150 for the next 5 years will not change
Yes,
over a year.
it will not change.
So, and then after the 5 years, how are we guaranteed that the percentage of increase itself won't be 0.2% versus 25%?
Thank you,
Is
Councilmember.
it written in a contract
It's
somewhere?
written in a contract.
So we know.
The amount, and I will get you the exact numbers, but they were relatively low increases. Those increases would be borne by the city, not by the retirees, and it would be for the same benefit plan.
Thank you.
Thank you so much. We've been joined by Councilmember Brennan, and I want to call on Councilmember Marte, followed by Councilmember Juan.
First of all, I want to thank Speaker Adams and Chair De La Rosa for hosting this committee hearing, and also for my colleagues for asking amazing questions so far. And most importantly, I want to thank the retirees for being here and for fighting for your right to have health care, and for fighting for other retirees who are bedridden, who live outside of the state, and who can't be here today. So thank you so much for doing that. My question is, you mentioned earlier that 95% of the retirees will be covered under Aetna. What about that 5%? That's thousands of people who have uncertainty of what's going to happen. Many of those people are extremely ill, and if they lose their coverage, it becomes a life and death decision. And so can you talk about those 5%, thousands of constituents who have emailed our office and are scared about the future of their livelihood?
The 95% refers to the number of doctors that are in the network. 100% of people will be covered by the Medicare Advantage plan. Nobody is losing coverage. If their doctor is not in the Medicare Advantage, not in the network, Aetna will be reaching out to that doctor to see if they can get them in the network or make other arrangements so that they can be covered. Because it's not a limited network plan, they can go to out-of-network doctors and still have no balance bill. And Aetna has assured us that they will be reaching out to people. They will work with everybody who's on a medication or currently being treated, and work out transition of care issues. So it's certainly not like 5% of people are going to be left uncovered.
But if it's 5% of the doctors, that's still possibly thousands of people with uncertainty. And how can we trust a private corporation who cares more about profit than people to do the outreach and make sure that people aren't paying much more than they're currently paying now, or even working to make sure that everyone is covered with the coverage that they have currently?
We understand the sense of distrust, and it's why we've built into the contract performance guarantees with financial penalties that I know that Aetna is not going to want to have to pay, and why we've built in oversight that the city and the Municipal Labor Committee will jointly monitor what Aetna is doing. I really think that we have a number of procedures in place to make sure that people are not left hanging.
And my last statement is that oversight of a corporation happens after the decisions are made. What confidence do we have that the procedures are going to be in place so when people need the care, they get it, and they don't wait until an oversight hearing that happens months after or years after?
Thank you, Councilmember.
So,
go ahead.
Apologize. So, again, as part of this program, we are working into the agreement that Aetna will be doing outreach to providers to make sure that 95% number goes up, and providing retirees with the opportunity to speak with speak with Aetna to connect their providers so that we can make sure that as many doctors as possible accept the plan. You know, they receive the same payment through this plan as they do through Medicare. There's no reason for them not to accept this plan, and we will do everything in our power, along with the Municipal Labor Committee, to make sure that education happens.
Thank you. Councilmember Vernikoff, followed by Councilmember Lewis. Oh, I'm sorry. I apologize. I'm already losing track. Councilmember Juan, followed by Councilmember Vernikoff, followed by Councilmember Lewis.
Thank you so much, Chair De La Rosa, and thank you so much for Speaker Adams for hosting this important hearing. And thank you so much to all the retirees who are here this morning. In our chambers, every single seat is filled, the committee room for overflow, and I know that there are many still outside waiting to enter. We see you and we hear you. Thank you for all of your outreach. I know that all of our colleagues have received thousands of emails. So as a city, we have an obligation to pay for health insurance, and you continue to compare. I've heard you multiple times now, comparing our city in comparison to other municipalities who have moved on to Medicare Advantage. I want to make it clear that we are a city that is held to a higher standard. We are in New York City, and many of us council members have come here to fight in favor of universal health care to make sure that no one who is ill feels that their city will put profit over people. And for the $600 million in savings, where we are looking to find on the backs of the retirees who we have made promises to, can you help me understand, because this should be really the last option that we provide. You continue to talk about alternatives and options. Can you help us understand what alternatives you have fully explored before coming to this option?
So I'll start by saying, you know, we've made the number of changes we've made to the health plan for actives and pre-Medicare retirees over the last, 8 years are, we'll provide full listing, but there are many, many changes. We've changed, co-pays to encourage, incentivize behavior to go to lower cost places, like not to the ER, but to a doctor instead. We've mandated employees into the HIP HMO plan. We've really taken countless number of actions, and, honestly, we believe there's a unique opportunity. There are not many places where you can provide savings without doing things like increasing copays or seriously affecting coverage. And even when you do, those savings aren't as large as this. This presents an opportunity to use federal funding to provide a plan that has the same benefits in many cases, better benefits in many cases in terms of copays, deductibles, out-of-pocket maximums, and even new benefits like transportation. That's just not an opportunity that really exists anywhere else in the healthcare world. So we have explored many other options. We have made changes to the active and pre-Medicare plan for 8 years now. We think this is the best way forward to achieve these savings while continuing to deliver high-quality, premium-free care. And we want to emphasize premium-free because something we do not want to do is pass premiums on to employees. That is, you said we're New York City, and one thing we've always done is provide premium-free care, unlike many other municipalities, unlike the state, and we'd like to continue to do that.
I just want to put on the record that many of us do not agree that savings should come at the cost of retirees who have no active incomes for the majority of them. I do not agree with what you just said. Thank you.
Thank you. Councilmember Vernikoff, followed by Councilmember Lewis.
Thank you, Madam Speaker, and thank you, Chair De La Rosa. And of course, thank you to all the retirees who are here today. I've definitely received hundreds of emails, and we are definitely listening and we hear you. Mr. Pollack, I just want to follow up to a question asked by my colleague, Councilmember Arriola, that I don't believe she received an honest answer to. You testified that there is, in fact, a dispute. I think the question here regarding whether or not it's been an order issued by the arbitrator, whether it's a recommendation, what is this actual document? And you testified that there is a dispute because we know that in order for this decision, for the document to be an actual order, there has to be a dispute. And so I just want to clarify for the public what actually happened here. There was an agreement between the MOC and the administration They tried to move forward with this agreement. They were sued by the retirees and they lost. Subsequently, they asked for a recommendation from the arbitrator. Therefore, there is no dispute. Do you disagree with me, Mr. Pollack?
Respectfully, council member, I do. The city asked the arbitrator to resolve the lost savings that were lost by this delay in implementation and to find a way forward for us to achieve those savings, and that's what he did.
Right, so the city asked for a recommendation from the arbitrator. Therefore, it is a recommendation, as it also states in the document. It's my recommendation, not an order. And I think it's important.
So, Councilmember, we petitioned the arbitrator to resolve the dispute. Under the 2018 Health Savings Agreement, he has the ability to order relief, and we believe that was what he intended to do with this decision.
So you're saying he has the authority?
Yes.
And don't you agree that this authority, the power, comes from a 2018 agreement that allowed him to make these recommendations? Is that correct?
Yes.
Okay, but the agreement said that he has to make these recommendations by June 30th, 2020. This document is dated December 15, 2022.
I'm not aware of that time limitation of his authority over the savings.
Please let them answer so we can have the answer on the record. Can you repeat that?
Yes, I'm not aware of any time limitation on the arbitrator's authority to enforce the terms of our agreement.
Thank you, Council Member.
One more question?
Sure, go ahead.
Thank you. Is Aetna the awardee of your proposed Medicare Advantage plan, or are you still bidding?
The bidding is closed. Bidding closed in, I believe, 2021. And we are currently negotiating with Aetna to finalize the contract.
Thank you.
Thank you, Council Member. Council Member Lewis, followed by Majority Leader Powers.
Thank you, Speaker Adams and Chair De La Rosa, for today's hearing. I also want to thank the retirees for being here physically and those that are virtual that could not be here. Thank you for using your voices in many different ways. I have 3 quick questions because a lot of my questions were already answered. So I'll ask them and you could respond after, and I'm sure one council member will highlight what you didn't answer. The first one is it correct that retirees alone were able to find $300 million healthcare potential savings that OMB did not provide? And if that is true, would you be willing to fast track an audit in order to provide more cost savings towards this issue? The second question is, if you could further break down the appeal process, because it was spoke about earlier in the hearing. I heard the appeal process would be appointed to CMS, and then a final decision will be made by CMS. But what happens if a retiree needs a particular service and they're denied by the final process? What accountability would be on your end if the retiree succumbs to that particular procedure that they needed that they did not get? And the third question is, physicians that don't agree to participate in Aetna's plan and have particular patients that need a particular service, what is the process moving forward to make sure that those patients are not in limbo and that we actually lose them during this transition? Thank you.
So I apologize. The first question, can you repeat the first question?
No problem. I wanted to ask.
Oh, the retiree savings, I apologize.
There you go.
So I believe, Deputy Commissioner Levitt mentioned earlier that we have looked at all the savings suggestions that we've seen. We have pursued many, if not all of those already. We've left no stone unturned in trying to seek savings. So we have seen that. Many of those are things we've already done. So, we have pursued those and we'll continue to pursue anything we can.
So let's say you fast track that today or tomorrow. How soon would you be able to get back to us on that?
To clarify, what do you mean? Which of those initiatives? Because many of them we've already done. If you talk about the
auditing.
The auditing. So we have audited our carriers. We've also conducted, in 2014, we conducted a full audit of dependent eligibility to ensure that only eligible dependents are on our health insurance. And since 2014, we've been regularly auditing to ensure that dependents are on our health plan. So that's...
But with all due respect, that's what led us to this today. The auditing process was wasn't favorable. So if another audit process can happen and can be fast-tracked, retirees alone were able to identify $300 million in savings. You should be able to do the same thing. The next question is, please provide the breakdown of the appeal process, the final process, if there's a particular service that a retiree needs and the final decision is nay, they cannot provide the authorization for it, what happens to that patient? Who is accountable moving forward?
Thank you, Councilmember.
I'll take that question. There are many levels to the appeal process, and typically, as we said before, only about 1% of the claims are subject to prior authorization. In most cases, the prior authorizations are approved, and only a small subset of that 1% would get an initial denial. That initial denial is issued by a physician in the same specialty as the physician who ordered the original procedure or hospitalization or whatever it is. If that happens and the retiree appeals, there's another review. That review is also subject to an expedited process and can be done very quickly. If it is not approved at that point, it goes to an independent review organization that is hired not by the city or the MLC or Aetna, but by Medicare, and represents Medicare in that process. At that point, very few of those claims would go to Medicare. Medicare can approve them or overturn them. There's even another level of appeal at Medicare beyond that. So in the end, very few situations are actually denied. More of these situations are situations where a recommendation is made to the provider that a particular procedure could be done on an outpatient basis, not an inpatient basis, or an alternative procedure could be used for a patient. Ultimately, I'm sure it's true that ultimately there are some procedures, particularly if they're experimental procedures or cosmetic procedures, that are ultimately denied. But that is a handful of claims.
Thank you. Councilmember, Majority Leader Powers, followed by Councilmember Gutierrez to close out round one.
Thank you. I'm going to try to be quick just because I know we have a lot of folks here that want to testify here today. I just had a couple questions. One is, I know you said 53,000 people had opted out of Medicare Advantage. What's the denominator on that out of?
It was 63,000, and that's out of 250,000.
Of 250,000, okay. And what's the cost savings on that if you take those 63,000 out who opted out and the rest stayed in?
So that didn't affect the cost savings because at the time that happened, that was under our initial plan to offer Medicare Advantage premium free with anyone who opted out paying the cost of that plan they opt into. So the savings would have been the same. You would have had 190,000 people on Medicare Advantage at zero cost to the city, and then you would have had, maybe 50,000 people on senior care paying the monthly premium, so there would be no cost to the city there either, and the full savings would be achieved.
Obviously, this is a conversation about choice of healthcare plans, and the folks that are here today in the audience are concerned about a unilateral change to their healthcare plan that they have yet to review. And I think it's fair, and I think many of them have concerns about not knowing what that plan is, and while we're asking them to accept that plan. And also, we have a bill here positioned to provide an option for those who can afford to keep their plan. What I'm concerned about is the folks who can't pay for that plan, the senior care, and bifurcating the folks who can and can't pay. So I guess that's my first question is, how do we address the folks, or has there been any discussion of addressing folks who just simply can't afford to pay for that plan as you move them over because there's different pensions and different compensation structures?
Yeah, thank you, Council Member. So I think we They would be in the Medicare Advantage plan, which if you can't afford to buy up to the senior care plan, you can be in the Medicare Advantage plan, which we think provides outstanding benefits. You know, like with our active plans where we have two premium-free choices, and then we have a number of plans that you can pay more for, which some people choose to, some people don't. But, you know, we want to provide comprehensive premium-free option, and then, you know, provide the choice for people to buy up if they can do so.
Just, I guess what I'm saying is I think we may look at the Aetna plan, and the Aetna plan may look much better than expected when it comes to what it offers, and I expect that it may provide a decent amount of coverage to folks who are going on that plan. But I think there is a bifurcation between some folks who can pay for the plan to go stay in the senior health care. And I think the whole question here is people have trepidation about moving over to a plan they've yet to see, and that they may impact their service. And I think that the difference between those who may be able to afford it should be addressed if we are ever going to talk about optionality, because I think some people may lose that optionality just based on the ability to afford it, and I think that's an important part of the conversation that we should be discussing. The second part, and I'll just end because I know we have a lot of questions, but Councilmember Ressler touched on this, and I think it's an important part, which is if this moves forward and the city is successful in court and everybody moves to Medicare Advantage, and then we are talking about the loss of optionality, which is the centerpiece of today's conversation. Why can't we come back and have that conversation at that point in time with Aetna and company about, for the folks who still want to keep their plan, to be able to then at that point go back into the senior health care for those, again, for those who can afford it?
Yeah, so I mean, I think it's an unpredictable path if we go down that road, in that, you know, a court could do any number of things. It could have a preliminary injunction, it could not issue an injunction, and, you know, if we have gone down that road and eliminated the senior care plan, you know, terminated that contract and no longer are offering it, I'm not sure that we're able to just immediately restore it. I'm not sure that's something that legally can be done. I'm not sure that, you know, consistent with city procurement and contracting rules. So, you know, I think there's a lot of uncertainty down that path, and, you know, not sure we can commit that that would be available, that option.
Okay, I think it would be helpful if we had some more definition to that answer.
Okay. We can try to provide that.
Because
yep.
I think it's an important question. I'll cede my time from there because I know we have a lot of folks that want to testify.
Thank you. Councilmember Gutierrez, followed by Councilmember Dinowitz to close off round one.
Thank you, Chair De La Rosa, and thank you, Speaker, for bringing us to the table today. And I'm a little late, so I apologize if you brought this up, but can you tell me how you all got to the determination of about $191 a month for those who opt out?
Sure. So that was the premium costs in 2022 of the senior care plan. That's how much the insurer would charge for that plan. Aetna charge is $0, so the difference is at $191 a month. The Medicare Advantage plan would charge $0, right. The senior care plan $191.
Right, and is that premium expected to change?
Yes, I believe that premium will increase for 2023, and, you know, as all premiums do, would increase in the future, unlike the Aetna Medicare Advantage premium, which is locked in at $0 for 5 years.
For 5 years, so even that's subject to change. And so the $191 premium, subject to change after 5 years, theoretically, does it go up with more retirees opting out? Yeah, opting out. So if more retirees choose Medicare Advantage, does that premium go up exponentially even within those 5 years?
So the premium would be based on what the emblem charges for senior care. So, you know, that is not locked in. That can change on an annual basis and does and has increased and will continue to increase.
Okay, and even for those retirees on Medicare Advantage after 5 years, what are they looking at?
So the retirees on Medicare Advantage would still be looking at paying $0. What we're doing here, what we're seeking to do here is establish that as a benchmark plan, which means that the city, if there's any costs, the city will pay it. You know, so if the rate increases, let's say to, you know, $10 a month per person, the city would pay that because that's then the premium-free benchmark. Under the administrative code, even after this amendment, there will be the obligation to provide a premium-free plan to retirees, and we're saying that's what the Medicare Advantage plan will be.
So the city is obligated to find coverage to find that increase, whatever it is, to ensure that seniors do not pay a premium. So,
Yes.
but what we're saying here today is that we can't do that right now, which is why we're here, which is why you're asking to amend this code.
What we're saying is we can guarantee that there will be a premium-free option, which will be Medicare Advantage, but without this code change, we're not allowed to have retirees choose to remain in a different plan that costs more, and we would have to eliminate that plan if we want to achieve the savings we need to achieve.
Okay, can I just have 30 more seconds? So a lot of the coverage, I think, has pointed to the obvious that we're in the midst of a healthcare crisis. Do you all agree that we are, in fact, in the midst of a healthcare crisis?
So I'll turn it over to my healthcare expert. I don't know what type of crisis you're
We're
referring to.
still in a pandemic. You do not think that we're in a healthcare
okay.
crisis?
So I wasn't sure if you're referring to affordability, costs. Yes.
I mean, I am, but
yes.
I was hoping that your response was yes, absolutely.
Yes.
As someone who is her mother's caretaker, she is 72 years old. I stand with all of my constituents in the belief that healthcare, especially at a specific age, is about prevention and it is about maintenance. And the role that we should be playing is preventing barriers to healthcare. And what we are proposing is creating barriers by saying your option is $191 if you don't rock with us. And that is where our failure is. And I implore you to continue to look at options. I implore you to also stick around and hear from some of these folks. I think that there's probably a lot of good ideas in the crowd today so that we can discuss that in an earnest way. Thank you, Chair. Thank you.
Thank you. Councilmember Dinowitz to close this first round.
Okay, Chair, thank you. That's also a lot of pressure closing out the round, but I'll thank you. And thank you
Don't
for
worry, there's another round.
Of all the things to be worried about, it's not closing this out. But I do want to take a moment to thank the Chair. This is obviously a very personal and difficult thing to talk about, but we're talking about it, and so I want to thank you for that. I first want to very quickly talk about Medicare Advantage and how you, just a few questions about Medicare Advantage. You said 1% of the claims are denied. How many claims would that be?
Just to clarify, it's not 1% are denied. 1% are subject to prior authorization.
Okay, cool. What percent is subject to prior authorization?
1% of all claims.
Sorry, how many is that?
I can't give that right now. I could provide you the number of claims from retirees we receive. We can provide that after the hearing.
We don't have the number of claims because we're not in that plan right now. That number was based on Aetna's book of business, and I think they told us that they had 8.5 million claims, something like that. So it's based on a lot of claims.
Well, yeah, 1% of 8 million?
Yeah, well, that wouldn't be for our group. That's their entire big book of business.
It's like 80,000 claims.
That's their national business,
That's
not
full,
zero
that's
New York City.
National business.
Okay. So 1% of, so
1%
you don't know
is
how
subject
many.
to prior authorization.
Okay. But you don't have for us how many claims total there would be. They just gave you a percentage. Is that correct?
What they did was they looked at you remember they're a very big player in this business. So they looked at they don't currently provide this in New York City, right? So they looked at their current book of business and said, what percentage of our total claims are subject to pre-authorization under this set of rules?
So I guess I'm starting to interrupt because
1%.
time's limited. Tons of people want to testify. I want to be respectful of everyone. They have the number of claims. That was it. The number of claims made in New York City, but you don't?
No.
Is that?
They have the number of claims made by all the people who currently have their Medicare Advantage plan, right, all over the country. And based on that, they said about 1% of all those claims are subject to pre-authorization.
Okay, so the answer is we don't really know how many claims would be subject to pre-authorization. I understand a percent, but we don't know how many, right? Okay, can I have?
Because we don't know what
It's a projection.
We would have.
I think is the answer.
No, I understand. Okay, the second part of that is the physicians that determine the appeals, right? If I have to get prior authorization, the physicians that determine that are in the same specialty and they are employees of, I'm asking them.
The initial
No, seriously.
determination
Let's take this back.
and the first level appeal is made by physicians who are employees of Aetna. That's correct.
Okay.
Thank you, council member.
Thank you.
Thank you.
Wait for
If
second
you
round.
want
Thank you.
second round, we can do that. So I have some follow-up questions myself. So each year, the Center for Medicare and Medicaid Services rates on a 5-year star scale the Medicare Advantage plans provided by insurance companies. The rating measures quality of health care and drug services provided to enrollees. To encourage competition based on quality, plans are rewarded with a bonus if they receive a minimum rating of 4 stars. For the calendar year 2022 and 2023, Aetna received a rating of 3.5 stars. Has the administration looked into why Aetna received a rating that is below 4 stars? And given that rating, should we be concerned about the quality of care under Aetna?
Thank you for the question, Chair De La Rosa. We've had extensive discussions with Aetna about the star ratings. The plan that New York City retirees are expected to be placed in is actually a 4+ star plan. So, Aetna has a plan that's they have numerous plans, and the plan that we're expected to be placed in is a 4+ star plan. And they have many plans to maintain that rating and to increase the rating of their plan that dropped to 3.5 stars. We're going to be monitoring their efforts on this. Our contract will have performance guarantees about quality, about satisfaction, and if they don't meet those levels of quality and customer service that drive the star ratings, we have financial penalties for them. So, we expect them to put every effort to maintain and improve their star ratings and all the factors that drive them. It has an issue with huge financial implications for the insurer. They lose money if they drop their star rating, and in addition, they would have financial penalties under our contract if they don't meet certain measures of quality.
Are you able to share on the record with us today what those financial penalties look like?
I would have to, I believe it's a contract currently under negotiation. I'm not sure that we're able to share that. I would have to get back to you.
If you're able to at any point, it would be great to share that with the committee as we go forward. I'm going to call on Councilmember Palladino. I don't think she's here. She signed up for a second round. Councilmember Bottcher, followed by Councilmember Velasquez for a second round.
Hi, would the addition of $500 million into the stabilization fund, would that assist with the funding issue for the next 5 years?
$500 million would represent about 1/6 of what we would expect to save over the next 5 years.
Another question. Are there any implications for active employees in modifying the code? Beyond giving this option for retirees, what would other possible implications be of, if any?
So I think the code change, what it does is it empowers collective bargaining and allows us to, negotiate with the MLC to determine the benchmark plans. So, that is the result we're seeking, and it would allow us to, negotiate as needed with the MLC.
Thank you.
Thank you. Councilmember Velasquez, followed by Councilmember Shulman.
Hey again. So for the record, retirees have real concerns over Medicare Advantage. We have doctors on the record saying that they don't want to participate in the Medicare Advantage plan because of the additional layers of paperwork that will be required out of them. We also have that these plans meet shareholder profit goals by denial of services. And lastly, we have these plans that the decisions regarding care comes with a financial lens. So how are we, going back to what you said, you had mentioned oversight, how do you envision the admin providing the additional layer of oversight to make sure that we give our retirees the proper authorization that they deserve for the services that they already get?
So we plan on working with our MLC colleagues to monitor the performance, to make sure they're meeting every promise they've made the insurer. This is something that we do on a regular basis with our active plan as well. We monitor to make sure that our employees and our retirees are getting the best care they can, and it's as much in the interest of our unions as anyone else to make sure that their members, active and retired, are getting high quality care, and it's also in the city's interest. So, we are going to be reviewing, we have robust reporting requirements in the contract. We are going to be reviewing those. We are going to be speaking with the insurer on a very frequent basis to make sure this plan is going smoothly, and we plan to do everything in our power to make sure that it does and that it delivers the care our retirees do deserve.
And I hear you, but as someone who's gone through serious medical conditions, I have had denial upon denial upon denial, and I'm active. Retirees don't have time to waste. Retirees don't have time for litigation. We need to make sure that before we implement anything, that they are protected and they don't have to go through endless authorizations, that they are granted what they deserve. So how can we protect them, and how can we assure them that they are going to be protected? That's what we need to know.
Thank you, Councilmember.
I will say that, as we said today, we have managed to remove working, negotiating with Aetna about 75% of the procedures that would have been subject to prior authorization. So, we think that's a significant change that should address many of the concerns. You're not going to have prior authorization for an MRI or a CAT scan under this plan.
Thank you, Councilmember. Councilmember Schulman, and then Councilmember Powers to close.
Thank you. I just want to say that I agree with the chair previously when she said that health care is a human right, but it's not a human right if you cannot afford it and you don't get the care that you require. So I want to ask a question of you. We as a body, I believe I'm sharing this as part of the body, want to resolve this issue and make sure our retirees are protected. How do you expect us to do that if you won't share the draft contract with us? You're essentially asking us to consider this bill in the dark.
We will provide details of the plan, of what the plan is going to look like. We will get back to you on the ability to share when we may be able to share, more details. But we'll provide you with as much information as we can. But I want to be clear that this amendment isn't about whether or not the Medicare Advantage plan proceeds. We are planning on moving forward with that plan, and we think that this amendment is necessary to allow us to provide the choice for retirees.
Okay.
All right, please, no comments from the gallery. You will have your opportunity when it's your turn to testify. We have over 200 people testifying tonight, so we will be having dinner here together. Please.
So I just want to say that I hear what you're saying, but you're asking us to vote on this sooner than we'll be able to see any information on it. And with that, I'm going to conclude my questioning. Thank you.
Thank you, Councilmember Schulman. Councilmember Powers?
I think I'm closing out. So I just want to, before you guys leave, just to help us lay out where we go from here. So the options based on whether the city wins a lawsuit or whether the retirees win the lawsuit, and what are the sort of options on the table. I know we've done this, but I just want to kind of get this sort of out here now to where we're going, because we've heard things about the Actives, we've heard things about Aetna. So just, can you lay out, based on where we are today, where we might be headed or where we are headed when it comes to respect to this?
Sure. So, if this amendment is passed, we will proceed with implementing Medicare Advantage while allowing retirees to remain in the senior care plan for a monthly premium. If it's not passed, we will proceed with implementing Medicare Advantage and eliminating senior care and any other plan that has a cost to the city. We know there may be litigation about on either of those paths, and that litigation there are always the possibility of court orders that direct us to do certain things, but we will, as long as we're able to, be proceeding with implementing this plan in the summer.
Okay, then one last question is just on the timing here again. We've heard a lot about January being the date. I think there's a little bit of questions I've heard from folks about whether that date is a real deadline or something that is sort of manifested itself. So what is the, can you talk about the timeline right now?
Sure. So, we talked about earlier the 6-month implementation timeline we have for this plan, and we need to provide people with notice. If whether there's going to be an option to keep senior care or not, we need to provide people with the notice. We need to provide them, they need to know what their options are. There's a process for opt-outs that I believe is governed by CMS regulations. So there's a long lead-up time. So, we need to be able to have this finality to know what the plan we're going to be offering is. Is there going to be this option or not? And if we don't have it, then, that would delay the timeline. And every month we delay, we lose $50 million.
Okay, thank you.
Councilmember Dinowitz.
Thank you. First, it's disappointing that you don't have an answer to things like the 1% and a lot of numbers that have been asked. I imagine that 1% of claims that require pre-authorization, to use the proper terminology, are the highest need cases, the most vulnerable people. That would be my guess, because those would be the most expensive procedures. And if you could possibly share with us what those claims would be, because I see you shaking your head, but it also seems like there are a lot of questions to which we don't have answers. I do have a question about the healthcare costs. I understand and appreciate, I think we all do, that healthcare costs are rising astronomically. How much of those increase of costs are due to specifically the early days and months of the pandemic, where hospitalizations were, people were hospitalized, the beds were filled, people had to be tested in order to go to work. Those tests were and are very expensive. And how much do you attribute to more long-term cost increases?
Actually, the pandemic period resulted in a short-term decrease in our healthcare costs because people postponed going for elective care. So despite the high costs of COVID and the costs of COVID testing, we actually saw a temporary decrease and then an increase in costs for people going back to get all of the elective care that they didn't get during the COVID period.
All right, I'm glad you've all been sworn in, because I've heard different information from other officials who have said, the cost of requiring people to get tested to go to work, not that that was a bad policy, but that significantly increased the costs. And I think this speaks to the cost of healthcare, which I think speaks to the lack of information or the misinformation that we've been receiving. The last thing is, and this will be my last question, is I've heard today and throughout this process a lot of trust us. We don't have the contract. We can't see the contract. Sort of trust us that this is better. This is what I'm hearing, right? It may not be what you're saying, but it's what I'm hearing. There are things that are guaranteed, but the healthcare, I'm including myself in this, because I was a teacher, and I was guaranteed the same healthcare that so many retirees here were guaranteed. I trusted the city to give me that healthcare in retirement. Now you're saying trust us on these, on what's going on with what you'll be provided, but also that it's only a 5-year guarantee. And so I guess a two-part question is, how can we in the City Council and New York City residents, one, trust you about guarantees that we thought were had, and also, like, why the hell, we have a staffing shortage. Like, why the hell should someone work for the city if we're not sure those things that we were told we would get, despite what you say the law is, we were told that we were going to get in retirement, and now are being changed and essentially taken away from us.
Thank you, Councilmember. Please wrap up.
No, that's it. That was my question.
So I would say that what the city has committed to its retirees and employees is premium, high-quality, premium-free coverage. And every effort we've made is to meet that goal. like I've said, many other municipalities, many other private employers, public employers all over the country have started charging their employees premiums. So, the reason we're doing this is to meet our commitment to provide high-quality premium-free coverage. If we just don't make any changes to our health plans ever, we are going to be eaten alive by our healthcare costs. We need to be able to make modifications to seek efficiency and really when there are opportunities to provide a plan with the kind of benefits we're talking about now, we need to take those opportunities. And, that is why we are going along this path.
Thank you. We have Councilwoman Gutierrez and then Councilmember Ressler.
Thank you, Chair. I'm asking these questions on behalf of my colleague, Councilmember Linda Lee, who is on virtually, but we have lost a quorum. So direct these answers to her. Do you all have a sense, based on this legislation that we're hearing today, if the council has the capacity, or let me reread this, sorry. What is the likelihood that we would partially reject this amendment? Do you all have a sense? I mean, I know this is part of step one, but do you all have you all been having conversations, doing your due diligence with other members? Where do you think we are at before the end of the month deadline?
I'm sorry, you're asking about what conversations we've had with the council members?
Yes.
So, I haven't directly had conversations. I know that, certainly the city's legislative affairs team has.
Okay. Is there a way for council and retirees to weigh in on a plan if it changes from what is being proposed today?
Change in what way? I apologize. Not sure I understand.
Is there a space or is there an opportunity for, so you've said before in your responses that you are all prepared to move forward with Medicare Advantage. Mm-hmm. Sorry, she's texting me. Is there another opportunity, would there be another opportunity for retirees and council members to weigh in on Medicare Advantage, I guess, once it gets instituted, if we're not able to successfully pass this amendment?
Well, certainly the council has, the authority to hold hearings and request information from the administration. And, retirees have, many forms to provide their input as well, including to their unions, as well as to the administration directly.
I'm sorry, I couldn't really hear. Can you repeat that?
Sure. I would say that the council has the authority to have hearings, request information from the administration. We do plan to report on the progress of this plan. In addition, I would say retirees have the opportunity to voice concerns publicly to the administration and to their unions.
The last thing's not really a question. She just wanted me to emphasize, and she's right, that we're being asked to move ahead with a lot of unknowns, with a lot of information. We're being asked to move in this relationship with a lot of trust that we don't have. So, thank you.
Thank you. Councilmember Ressler.
Thank you again, Chair De La Rosa, for your leadership and for creating the space for us to have this conversation today. And I want to thank all the retirees for being here and our union leaders and members for being here as well. I had just a couple questions. First comment, I just want to beseech you again to maintain optionality through this process. As you're looking at the steps, this is obviously very fluid. The goals that you're articulating today are for Medicare Advantage to be one choice and for holding on to current options to be another choice. And as things unfold, I really hope that you think ahead to the various litigation options as Majority Leader Powers laid out, and both of he and I have, I think, underscored this in our questioning. We have to continue to maintain optionality. So in the deal that you strike with Aetna and however things unfold with current senior care, that is critically important. Secondly, wanted to ask, in that spirit, many of our retirees have pensions of $30,000, $40,000, $50,000 a year, very moderate income. Do you think they have an option of not going to Medicare Advantage in the proposals you've laid out to pay the $191 a month?
So, I certainly can't speak to the circumstances or choices of individual retirees. Right now there are retiree plans even that require a buy-up. Some take them, some don't.
I hear you. Yeah, I know you're not going to say more than that, but look, if somebody's got $35,000 a year pension, they can't pay $191 a month. They can't afford it. It's impossible. And so The thing that I wonder, have you thought about tiering or subsidies for low-income, moderate-income retirees based on household income, based on the size of their pension, to think about could we offer greater subsidies to maintain optionality for low-income retirees?
So the issue with subsidizing the cost of senior care beyond just the lost savings is also it could jeopardize the procurement, which was based on the fact that retirees would be paying the difference in price between the senior care plan and the Medicare Advantage plan.
I'd hope, my understanding is CSEA has done some interesting things here at the state level. I'd hope that we could explore different solutions along those lines as well. Lastly, and then I promised Chair De La Rosa to shut up, when was the last time that the city audited senior care and the appropriateness of the rate emblem charges, and can that audit be shared with the council?
I don't know when senior care was audited, but the rate is based on the claims that are paid. This is not an insured rate. It's based on the actual claims that are paid. We review the claims that are paid. We could certainly go back and audit, but I don't think we're going to see any significant balance from anything that we would audit on senior care.
Okay, that's helpful.
I mean, Medicare pays the claim first. We just pay the balances. So there's not really anything there to audit.
Okay, that is helpful. Thank you. Thank you, Claire.
Thank you so much. So we are officially done with this round of questioning. We thank the administration for coming in and answering our questions, and we hope to hear from you on the follow-up questions that the committee has asked today. So I'm going to go over some of our administrative rules, if I can find them in this pile of papers, while we call on the next panel, who will be Michael Mulgrew, Henry Garrido, Gloria Middleton, and Harry Nespoli. If you all can start transitioning. And before we turn to their testimony, I want to remind folks about the rules of this chamber. First, we lead with respect. Second, if you're expected to testify in person and virtually, please register to testify. Please listen for your name to be called. At times, witnesses' name will be called in groups to facilitate council member questioning. Additionally, if you are testifying virtually via Zoom, council staff will unmute you when it is your turn to speak. This may take a moment as we expect large virtual participation. Please be patient if not immediately unmuted, and please accept the request to be unmuted when you receive it. Every witness that is registered to testify today will be limited to 2 minutes. Please stop your testimony when the Sergeant at Arms calls time. So we want to thank this panel for being here today, and we will begin with Mr. Mulgrew virtually when there is a moment. If he is on.
Thank you very much.
Time starts now.
We ready?
Thank you. Time starts now. Go ahead.
Okay. Well, I want to first thank the Speaker and the Chair for holding these hearings. I've heard all of the questioning that has just gone on, and I'm here to say that first and foremost, this hearing is really about preserving some sort of choice for our retirees. The Medicare Advantage plan that we are trying to negotiate at this moment is not done yet. And we will never agree to a plan unless we have all the guarantees that we need to assure our retirees that they are getting all the service that they have worked for and earned. So that question is a separate question. But for us, the issue is that the court case took away our collective bargaining authority. There for years, we were allowed to negotiate additional plans known as pay-up plans. We no longer have that. And I know right now, like Aetna does not want this amendment to pass because they'd rather everyone just go into Medicare Advantage. So that is what we are asking for the council to do, is preserve our rights to give choice to our members. And as we move forward, the questioning was pretty clear. If you don't take up this amendment, we're going to, one day or another, maybe with Aetna, maybe with another company, but we will design a Medicare Advantage plan and implement it, and it'll be the only one like it in the entire country, and it'll be the best one in the country. But we're going to do that because this is really about the fight for healthcare costs, which we have been doing for years now. And we had to fight through a mayor for 12 years who tried to put premiums on us as workers, and we stopped that. But now what we're dealing with is hospitals, insurance companies, medical groups. Everyone now in the healthcare industry is just making more and more money. And it's New York City is battling to make sure that we keep all of our workers premium free. There are no guarantees. So that's what we're trying to do here. And I appreciate you taking this time to have this hearing.
Thank you, Mr. Mogu. The panel may begin when ready, the in-person panel.
Thank you. And I'd like to thank the speaker
and introduce yourselves for the record.
Okay.
Thank you.
I'd like to thank the speaker and the chair and everybody else that's still here, just to hear both sides of the story. And that's the most important thing. I'm Harry Nispoli, chair of the MLC. I represent 500,000 active and retiree city employees. And I'm also the president of the Sanitation Union, City of New York. We're here today seeking passage of legislation that will help maintain for our retirees two long-standing goals at the MLC. That's the provision of high-quality health care, and also the choice, a plan that will standing goals of the MLC and provision and high quality of health care and the ability to choose a plan that most meets their health care needs. Let me be perfectly clear. This is not legislation for mandate Medicare Advantage. This bill will provide the retirees with the ability to choose what they want to use. Senior care and Medicare Advantage plan was this is the common goal of the city of New York and the unions. I would like to make an observation before the other labor traders leaders join the discussion. There has been enormous amount of false and misleading information provided by others on this issue. The leader of one organization wrote in a letter to you, "Don't mess with a retiree. We have time on our hands." This is not a game. This isn't something to joke at. This is something to get together and try to resolve it. The policy of the MLC has always been turning around and having choice. That's our way. Choose which you would want to go rather than be mandated. The passage of this bill will help us meeting that goal. That's all I can say. All I can say is that thank you for listening to everyone here, and turn around and we'll try to get the city to make sure that you get more information pertaining to Aetna on some of the questions here.
Thank you. I failed to recognize Mr. Floyd. Thank you for joining the panel, and also Councilmember Brennan. Thank you for being here.
Good afternoon. I am Henry Garrido. I'm the Executive Director of District Council 37 ASME. I'm here to testify before you on behalf of the city's largest municipal union, which represents 150,000 members and 89,000 retirees across the city of New York. Thank you, Chairman De La Rosa, Chairwoman, and the members of the Civil Service Committee. I also want to thank the Speaker for her leadership and her courage to make sure that we have this hearing and that we ask all the right questions. I'm here to speak in favor of amending Administrative Code 12-126, which would allow us to protect and preserve health care for more than 300,000 New Yorkers. In the past few months, there have been a lot of misinformation about the motives behind the proposal to amend the Administrative Code. We have allowed fear of the unknown to truly become the perfect enemy of the good. To be clear, my priority is to provide actives and retirees, New York City municipal workers, the best healthcare coverage possible while making sure we have the funds to sustain it long term. Amending the Administrative Code has always been and will always remain about choice. Updating the code will protect our union's ability to negotiate healthcare options, as we have done for over 40 years. Without this amendment, the security of life savings programs like the PICA programs are at stake. Through the MLC, we have negotiated of self-injectables and chemotherapy medication for all actors and pre-Medicare retirees. When I'll tell you this is very personal to me, it is, because both my grandparents died of cancer, and they did not have a power of a union to fight for the programs like PICA to help with their cancer treatment at the end of their lives. And our fund, our stabilization fund, has exhausted all these resources and continues to go under every month. We now have to take responsible actions. They may not be popular, but they're responsible actions. And unless this city council is willing to fund $1.8 billion for the next 3 years and $600 billion annually going forward to keep the status quo in place, my members and DC 30s and retirees and the dependents will have to face the prospect of paying premiums, or retirees will no longer have an option for the health care plan. Hundreds of people who have been relying on you to do the right thing, not the popular thing. And so do what needs to be done. Do what is necessary. And if we don't amend this code, it will not prevent the city from implementing Medicare Advantage. A judge may. But Judge Frank's decision, the appeals of the court's decision, the arbitrator's rule have all indicated that the city is not legally required to provide retirees with an array of health care or pay for that choice. Read that court decision again, because what is being touted, as a victory for retirees has also had the poison pill of very specific language that says the city doesn't have to provide a choice, nor does it have to pay for it. We know that retirees deserve and want choice. And that's what we're here to fight for today. We're fighting to prevent choice, and we're asking the council to protect the choice by voting to amendment. I will conclude with this quote from Dr. King, who said, "In the end, we will remember."
Order. Please let him finish testifying. You will have your moment to testify. If you do not comply, you will be removed from this chamber. Thank you.
Well, if you can boo Dr. King, that's something else. But in the end, we will be remembered not for the words of our enemies, but for the silence of our friends. We could do this, and you can vote this down. That's within your power, certainly. But there has to be an explanation for those, if that vote goes down, who are relying on you to the leadership, to rely on medication, many of both retirees who are not here, who have been bamboozled into believing that this is the only way. Thank you.
Thank you.
Good afternoon, Committee Chair De La Rosa, Councilmember Ayala, and Madam Speaker, committee members, and all City Council members. My name is Gloria Middleton. I am President of Communications Workers of America, Local 1180. We represent almost 9,000 active city administrative workers and close to 7,000 retirees, which is why I'm here today speaking out in favor of legislation that allows Administrative Code 12-126 to be amended. As you know, the Municipal Labor Committee has a long history of bargaining on behalf of all unions regarding health care issues for active and retired city workers in order to fulfill our duty to ensure the city's health care plans meet the needs of both our members and our retirees. The MLC has been working with the city nonstop since 2014 to reach savings that keep the stabilization fund afloat. To generate savings, the MLC negotiated the Medicare Advantage Plus plan for retirees that provides for equal or better benefits and qualifies for federal subsidies needed to reduce the current $600 million health care deficit that is rising daily. The proposed Medicare Advantage plan will replace both traditional Medicare and the Medicare Supplement plan with one unified program at no premium cost to retirees or to the city. This plan would provide all the health care services previously covered by original Medicare and those supplemented by the senior care program, while also adding important new benefits not covered by the current senior care plan. The proposed Medicare Advantage plan is not a limited network or HMO type plan, but rather an extended service area plan. This means our retirees can utilize any doctor nationally that accepts payment from Aetna at the Medicare allowable rate, even if they are not in Aetna's network. The arbitrator dealing with disputes regarding the health savings agreement has ruled that the city must move forward with a Medicare Advantage plan to achieve savings. In its decision, the court ruled that the city is not required to offer senior care or any other similar plan. That means the Medicare Advantage plan will be the only plan available for retirees and eliminates all options. This is not what we want. We want to make sure our retirees have options, but we cannot do that without your support. Unless this city council acts now to pass the legislation that will allow for amending Administrative Code 12-126 and supports the MLC in negotiating health care benefits for retirees, they will lose their freedom of choice in selecting a health plan. Let me repeat, all options will be eliminated. It is imperative for this city council to act responsibly and allow labor leaders to engage in negotiations that ensure our retirees have the freedom to choose a plan that best works for them. Local 1180 and CWA District 1 wholeheartedly support Intro 0874-2023 to amend the administrative code, and we are asking for you to do the same.
Good afternoon. My name is Gregory Floyd. I'm President of Local 237 Teamsters. First, I'd like to thank Chairwoman Carmen De La Rosa, Speaker Adams for holding this hearing. I agree with my colleagues. I didn't write a speech because I knew they would cover everything, and by this point, everything would have been said. But I wanted to come here and give my support because the easiest thing would have been not to show up, not to speak out, and not to fight for the choice. That's the easiest thing. Could have sat back and just let it happen. But we believe seniors should have a choice, and that's why we're here. Had we done nothing, Medicare Advantage would have been implemented with no choice, and we wouldn't be fighting over the $191 a month. We understand that there should be choice, and that's why we're here, for choice.
Thank you so much. Now we'll go to member questions for this panel. I'm going to start by asking, if the council were to adopt the proposed legislation, would the MLC commit to continuing to offer GHI senior care?
It's up to us, yes. Yes.
Yes.
Yes.
Okay, thank you. Why is it important to the city and the Municipal Labor Committee to preserve GHI senior care as a health care insurance option. These are some repeated questions. We're just trying to get everyone's position clear on the record.
Look, it's another choice. It's like Gregory said. That's the way it's been. It's been choice. You just don't jam it down your throat. Yeah,
I'll jump in on this moment. So when we were negotiating the initial Medicare Advantage, this choice, when we were negotiating this choice was not there. Retirees did reach out to us. They said, we understand what you're trying to do, but we'd rather have the ability to say, let's wait and see that the Medicare Advantage that you're putting together is actually doing everything that you say it's going to do. And we were very comfortable with that. We said, we know you'll be extremely happy that it will do everything it's supposed to do, because we won't agree to it unless that is the case. So the original choice was for people to have the ability to stay in senior care with a payer. But when the code was changed, when the judge said that we couldn't do what we've been doing for almost 50 years, which is why we still have 6 other payer plans that are all going to be eliminated. That took away our collective bargaining rights. So it's a combination of 2 things here. One, I'm saying this on the record to you all, the Medicare Advantage plan that we go forward with, it may be Aetna, it may not, because we're not done with negotiations, and there's things that are really difficult, because we're looking for stuff that no Medicare Advantage plan in the country has. So we don't know if they will be that. I know everybody thinks it. We're not sure yet. But whether or not, we want our collective bargaining rights to go back, because we don't know what's coming in the future. And if we let it stand that there's only one plan, and one plan only, unless we or the city comes up with the payment for it, that could really lead to less creative ways to deal with the healthcare crisis that we're currently in.
Thank you. Prior to the city and the Municipal Labor Committee's agreement to implement Medicare Advantage Plan in 2021, what steps did the city and the MLC take to mitigate escalating healthcare costs?
I'll take that. Madam Chair, there have been 2 rounds of collective savings. There was the first one in 2014 that you heard the city testified about that collectively saved $3.4 billion. It was the second round in 2018 that had $2.2 billion. And the reference to Councilwoman Julie Menin previously, there were targets with those. Unfortunately, the hospitalization costs and the rise of prescription drugs, and I maintain, Councilmember Boucher, that still the rise of cost of COVID and having to be tested was a significant factor. In fact, our information is that it increased the premiums and increased the bills associated with healthcare. DC 37, for instance, also opted to take half of the raise that was otherwise would have been given to your constituencies, people in your districts, school aides, crossing guards, people of the lowest paid city workers, took half of the last raise, that was a 3% raise, in order to cover the retirees and their dependents. I want to be very clear, because something hasn't been said about how we haven't sacrificed enough. That was not an easy call. We, as a union, made that choice, and we convinced those who are active in-service employees to give up half of the last raise of a collectively bargained contract in order to cover that cost that we mentioned before. And what's being asked here is, in a sense, well, we got to keep covering the retiree health care through some sort of collective bargaining if we don't have the alternative of, the choice that I mentioned before. And the savings that we've done include copay increases for actives and pre-Medicare retirees, includes tiering laboratory work, includes steering people, increasing copays in some areas, decreasing copays in order to change behavior to disencourage people to using emergency rooms, but what should be ambulatory care. There were changes into best practices for Sloan Kettering Cancer Center, for Hospital for Special Surgeries. There have been a myriad of changes that were done, and yet the cost of healthcare continues to outpace the cost of revenue. And that revenue is set by the language that we're talking about here. Because the fortunate situation is this has become somehow a referendum on health care for the retirees. But in fact, that language that is in that section simply says the city has to pay up to the HIP HMO rate. There are 200,000 lives in the HIP HMO rate, projecting the coverage for 1.2 million people. There's absolutely no justification for a language that says a HIP rate. A lot of those lives are not even city workers to protect and set the standard for 1.3 million people. There is absolutely no logic to it. And those who want to defend and say this is a standard, this has been the standard for 40 years, I ask the question, why are 200,000 lives, many of which are not even city workers, setting a standard rate for 1.3 million people, including retirees? And lastly, I will say this. DC 37 chooses to cover the retirees and the benefit until they die. That is the choice that we make as a union. A large portion of that money that comes from the stabilization fund is no longer available, and it was stopped. That $165 that comes per member per retiree goes to cover programs like SilverScript, which is a retiree healthcare prescription drug that Councilwoman Gail Brewer mentioned before. That is the choice that we continue to make. So in answer to your questions about how many things that we've done in the last 8 years to get to this point, the answer is a lot, and we can go in detail on some of them. But the cost continues to outpace the revenue, and even with the savings, that's why we're in a deficit.
One of the things that has, go ahead, Michael.
I want to follow up with Henry. The amount of changes that we've made, we're constantly looking at different things we need to do or opportunities to save money. We've been very aggressive. We did not do what the rest of the country did, which is basically just pass those costs on. That's why we're huge supporters as we continue this fight. This hearing, and whether this bill passes or not, doesn't stop that we're in this fight. That's why we're huge supporters of what Councilmember Menon, her bill on transparency, and all the co-sponsors of it, because the state would not take up that bill because of the lobbyists in Albany. And now, at least in the city, we can say we're going to do this. Hopefully, we all get behind that. But we constantly make change. Just imagine if we saved $3.4 billion and we still landed up losing ground. And New York State is the highest inflation on healthcare, and something needs to be done about it. But Henry is correct about behavior. Just recently, we did a round of co-pays on our in-service, but we based them on things that we're seeing that are problematic. Urgent care centers are now the #1 healthcare provider for the people of New York City, the workers of New York City. Well, some of them are not so nice. They might look nice outside, very shiny and everything else. Some of them aren't so nice. So they were all told very simply, like, you are gouging us, and we're going to put massive co-pay for someone to walk into your facility because we don't want them walking into your facility because you're ripping us off. And we've done, that's the type of really smart, aggressive policies we've been pursuing at all times. And Henry is correct about the HIP rate. This is an archaic system that we all inherited from 1982, and something needs to change on all of that. But I'm very proud of what we've done. And the savings we've been able to continue to produce. But let's be clear, we are all in a healthcare crisis, and that's why it is important that we keep our eye on that ball. And in terms of Medicare Advantage is a government program. It's a government program. We said we're going to take a program and to design it in a way that has not happened anywhere else, with greater protections, better benefits, and all the things that we want for our retirees in it. And that's what we're endeavoring to do right now. But we will, and that will also help in savings. And that's part of what we're doing right now until we can get a real federal intervention in terms of health care.
Thank you.
And by the way, the two pieces that I forgot to mention, which is 2 rounds of legislative proposals by the MLC at the state level. The most recent one, the HELAC, the Hospital Equity and Accountability Law, that was modified and passed, signed by the governor, but it was so watered down that we couldn't go and set the rate straight. And a rebidding of the PICA program, which completely changed the formulary for those who are receiving the chemotherapy and injectable drugs that saved $200 million. We have done everything that in our power, everything that we had to try to save money in prescription drugs, in hospitals, in changing behavior, in urgent care, as Michael said, we still have hospitals that the council member mentioned charging us over $1,000 for a COVID test just because they can. That's not just for actives, that's for retirees. That's the system we're in. That's the system that is outlined in this HIP rate, that the hospitals and the providers know very well and have saw it as an open-ended credit card to charge. So when you're answering the questions about it, for the sake of the retirees who are concerned and fearful, and we understand the fear, we also have to ask the question for the actives and the pre-Medicare retirees who are also beholden to a system that has absolutely no checks and balances. And we tried as we might to try to create some of those checks and balances, only to be thwarted one way or another. We try to change one behavior, and then the hospitals readjust and not bill on the other side. So we need to change this.
Just to go on, Henry, if I may. The council member over there touched on a very good issue as far as the outcosting of what these hospitals actually change. This executive board of the MLC met with executive boards of hospitals. We worked out a plans to cut that, not just for city workers, not just for retirees, for the public. We met with them because every time we sat with them, we moved them here. But around the back, eventually, they charged over here. So, look, I could just say this MLC has worked for everybody, and we're always going to keep on working for everybody for the best way we possibly can do. Thank you.
Thank you. One of the questions that we've been posed with here in different iterations is if the council doesn't act or if the council fails to pass this legislation, in your estimation, would there be another bite of the apple down the line? So what happens after January 29th, which is the deadline that has been floated around to council members? What happens? Tell us what that scenario looks like for the city.
Well, I'm not an attorney, but I think one of the problems we have is the terms of the contract that is being now negotiated, that we have an obligation on the arbitrator, right, has to be set as to how many lives is covered, right? So unless there's opt-out language under the current Aetna contract that allows for a later revision of the code or some other form of option, that's the number one problem, right? Will the company consider this a breach of contract, as they have expressed it, or depends on the number of lives covered, right? The issue of cost, it's only a part of it. The issue of choice is a key part of it. So if the council decides not to do this, and they have within the right, the problem you have is you have a 5-year executed contract that will come in front that already have, as I said, 2 court decisions and an arbitrator that the city will execute with no choice. Now, does that mean the contract gets invalidated if the council changes the law? I don't know, I'm not a lawyer. But I think that's something that you should ask the attorneys here because we don't have an answer for that.
Thank you. The other thing that has been brought to us is this idea of alternatives. One of the alternatives that has been presented is a proposal by the PSC CUNY. What is your position on using the retiree reserve as proposed by PSC CUNY as an alternate solution?
Well, let me just say this. We've talked to PSC CUNYs. They're our colleagues. They sit on the board of the MLC. We've talked about it. The question is, what is the end game, right? If we're going to take part of the retiree reserve to put in, and there's a question whether you can take $600 million or what was originally legislated to be benefit only for retirees and transfer that money to the stabilization fund, which covers everyone, both actives and retirees. There's a legal question whether that can be done. But let's just assume that we get past the legal threshold and that can be done. What is the end result 3 years from now with their proposal? What's going to change, right? The hospital behavior certainly is not. Prescription drug coverage is not going to change. As you heard by testimony, the premiums are only increasing. So what's the difference between what we're doing now versus what we're doing 3 years from now. My colleagues, in fairness to them, said, well, we can rebid senior care, we can do a number of things. Is there an expectation rebidding senior care will save $600 million or 600 plus, whatever that money would be at the end? There's no answer. So in many respects, this is only kicking the can down the road to a problem that needs solution for both actors and retirees, right? Everybody wants to preserve choice. Everybody wants to preserve their health care. How do we pay for it? That's the question here. If we're not going to receive the federal subsidy to Medicare, how do we pay for it? Is the council in a position right now to say, we're going to put up the $600 million to do this? Well, that's part of the question. Is it a matter of the unions and the city coming back and trying to find a way to do it? That's part of the question. We've tried to be responsible in putting forward one of the proposals that was presented to us, right, as part of the negotiations. And by the way, Medicare Advantage has been on the table since the 2014 deal. We are in 2022. We've managed to avoid this 8 years. There's a difference, though, in 2014, 2022, and that is you have a stabilization fund at a negative for the first time. And so we feel responsible to have to pay those things that are covered. By the way, that cover for the stabilization fund is not just for actives. Retirees are also getting a large amount of money coming to the unions from that fund that is now living out of the reserves. When those reserves run out, what answers do we have to actives and retirees to say we no longer have the fund to cover the things that you so value right now?
So, Madam Speaker has a question, but I just want to follow up on something. The proposal for some type of subsidy has come up several times here, and we know that there is a rejection of creating two classes of workers in our city, but the idea of covering the cost of the premium through a subsidy has been brought up. Do you all have a position on that?
Well, you know, we're always open to ideas, but one of the concerns is that depending on the contract lives cover, Aetna may actually not do the contract if not enough lives are covered. So God is in the details, and so is the devil, right? As the saying goes, depends on the subsidy. We would have to know what the substance of it is before we can say we're for or against. You know, it's clear, like there's a lot of, and the other thing it's clear that one of the things that has been said is either senior care or Medicare Advantage or both. Let's not remember, we also have 20,000 lives in HIF-BIP that will not be touched to this change. That remains a plan that is viable, that has no cost to the city, that would also remain in place. So the question is, for those who are the $191, it's too onerous, will the reimbursement be 100%? Would it be 80%? Because if everybody gets reimbursed for everything, right, obviously, what incentives would they have to remain or to go into a new program, and then you lose the subsidy for it? But we are open for ideas, Chairwoman.
Thank you. I just have one question. All of you have said in your opening statements pretty much that if this council does not act, then our retirees will not have a change option. There will be no option to change. If that is the case, it seems very basic to me. And I'd just like to hear from all of you the response to this, because Henry, you've done a lot of the answering, but I would like to hear from all of you, since everybody, the panel pretty much agrees that if we do not amend, then our retirees will no longer have a change when it comes to care. If that is the case, why do you think, independently, why do you think there is so much resistance to the amendment of this code?
I could start. I could start because from the very beginning, when the questions came up, we wanted to put something forward to tell everyone exactly what was going on. And it was the last administration, the de Blasio administration, who thought that they could just push this through and not talk about it. So they didn't agree, and they wouldn't allow us to go out and explain what exactly was going on from the beginning. So once you lose the narrative and all of the other factors come in and everybody gets their own ideas and people dig in, it's difficult, if not impossible, to refute everything that's gotten into everybody's head and what their understanding of what's going on. And we never caught up. We're not caught up now. And that was the problem. Before this council came in, this new council was elected. And we're still dealing with the ghosts of the past. But we're here because we have this opportunity to try to move forward. And this was before the court case, because we didn't have to get the court case. If everyone understood exactly what this program was, what we were doing, and who was paying for it, it would be far less resistance.
Please allow for the panel to respond without calling out. In your 3 minutes, you will be able to express yourself. Please allow the panel to respond.
As our colleagues have expressed, in these negotiations since 2014, they tried not to do Medicare Advantage. When it did come up in the MLC with the steering committee, we talked about it, we discussed it. 85% of the MLC approved the Medicare Advantage program, should know that. And then we had a plan where we would have options in it, but then the court case came. And the court case, and we can argue about what the judge says, black and white shows what black and white is. The court case came and said that Medicare Advantage Plus could happen, and there were other nuances that went along with that. There was an appeal. The appeal said that Medicare Advantage could happen, but you could not charge for senior care. Then as we go to the arbitrator says you can have Medicare Advantage, but no other program. So this is where we are. That's why we need the code change so the MLC can continue to negotiate for the retirees so that they have choice. We're not the bad guys here, despite what some people think, okay? For 40 years, the MLC have negotiated non-premium benefits for actives and retirees. Why all of a sudden would we do something that's different to hurt our retirees, that we are gonna be future retirees ourselves? I don't understand why we can't communicate that this MLC is trying to work with the city to help negotiate the best plan possible under the circumstances. We went through COVID. Yes, there is a healthcare crisis. I don't know why the city didn't say that. There was a healthcare crisis. People in hospitals on ventilators. The cost of that was phenomenal. So we are here today to make sure that our retirees can have choice. That's what we are here for specifically.
Please.
I think Greg really touched on the answer to that, was the fact that it was rolled out wrong. It really was. And the fact that of a change, we've always talked about retirees at our meetings, and we always tried not to affect the retirees on a regular basis. But right now, we got our backs to the wall, and a change has to be made. And the change is this amendment. Nobody likes change, but sometimes you're put in a seat that you have to make that decision to keep the city going, to keep on going. Nobody likes to charge retirees a dime. None. 124 unions. Excuse me. I refuse not to come here today. That's why I get this cough. I just feel as if it was turned around, rolled out the wrong way, and it turned around and it just exploded to the fact that we had to come for this council to make this amendment. This is a change.
So when it was, we spoke about, I mean, when I talk about my union, we spoke about there was an RFP on senior, on the retiree health care. But we also have to understand that our hands are tied during an RFP process. There's a confidentiality clause tied into it. The minute we were through with that, we went out and started speaking about it, but it had already started. What had started was the beginning of the cottage industry of how to stop Medicare Advantage, is what I like to call it. And that has really been turned into basically a bucket of misinformation and blatant lies about what has gone on in the past and what we're trying to do right now. And that's what you are all seeing in terms of the opposition to it. When you did say you needed to hear from other folks, we were having our members were contacting you, and you asked us to please stop that. So we did. But the fact is that we never looked at Medicare Advantage because we did the same research that was done recently by the folks who were opposing this. We looked at it, we said, no, we don't want any of that. What turned around for us was when when a lot of the technical people and consultants we work with, we started asking them questions like, well, can't we design our own? Since we don't have to just pick one of the plans. There's nothing in the law. In fact, the law actually, says they want people to be designing Medicare Advantage plans. And when we realized we could do one that would only be for our folks, and it would be different than any other one in the country, we moved forward with that. And that is always our intention. So yeah, some of us are frustrated about our motivations have been questioned at all times. I've heard some really crazy conspiracies. And you chuckle, but at the same time, you think it's sad, because you do understand that if we don't continue to have the ability to engage on this fight on healthcare costs, people are going to get hurt. But we will never allow our retirees to be hurt. And that's the sad part about this chapter in the city's history, is that about the amount of misinformation and lies is off the chart. But I guess that's the stake of, that's really tells a lot about where politics is in this day and age.
Well, what I will say from a stance when it comes to this council, and I've said it, to my members, is that as a council, we should never be in a position that we are in right now. Win, lose, or draw, this council is in a lose-lose position, which we should never be placed in to begin with. However, we have to hear everyone. We have to hear both sides, because this is such a critical issue. And we respect the fact that everyone has input on this issue. Everybody that appeared here today, from every single panel to every single retiree, you have the right to be heard, and that is our obligation to you and to the people of the city of New York, and I thank you for your testimony.
Thank you. Now we'll hear from our colleagues. Reminding colleagues to please try to stay at 2 minutes. Council members Brennan, followed by Ressler, followed by Dinowitz.
Thank you, Chair. Just want to echo what the speaker said. This is the hearing today, and the introduction of this bill is the only mechanism that this council has to hear out this issue. So I thank the chair for giving us this opportunity to have this public hearing on this issue, for which we could not have done it without her putting this forward. And that's why we're all here today. I think, like everyone in this room, I believe very strongly in the sacred covenant between the city and its workers, especially retirees. The promise that the city of New York pays the entire cost of health insurance coverage for city employees and city retirees and their dependents is not a promise that can be broken. I think we all agree on that. I do want to understand, though, this has been very enlightening for a lot of us today, hearing all the questions, and we look forward to hearing from the retirees as well, of course. I just want to understand, right now, the established subsidy is basically tied to the whim of Emblem Health. And can you explain why that is and how changing this code would change that reality?
I'm sorry, Councilman, I don't know what you mean by being tied to Emblem Health. Are you talking about the HIP rate?
Yeah, sorry, yeah.
Well, that's what the administrative code says. It says that the city shall pay not to exceed 100% of the full cost of the HIP HMO rate on a categorical basis. That's what we're trying to change here. That's what's in the code right now. So right now, there's an RFP process going through the actives. If there's no HIP rate, guess what? We're gonna have to amend the administrative code for entirely different reasons. Now, this was put in at the time. I can speak about this because my union was at the center of it, because HIP was cheaper. There were HIP centers. You didn't need a referral. When I became a city worker, some years ago, right, I was told, well, if you don't want to pay co-pays, you take HIP. You can go to a HIP center because it was cheaper for the city. Somewhere along the way, that has changed. It changed, right? The HIP rate with Obamacare, that HIP rate went up and more money was going into the fund. There was more money in the stabilization fund than it ever was going back in 2010-12. So, but somehow this code never changed. So HIP, the rate, which is a regional rate, which has lives that are not city workers, set the rate for everybody else. That is what is in this code. Now, no one has been able to provide for me why there are thousands of lives outside of HIP of city workers that are part of the HIP rate that are still setting the rate for the city. Private sector lives, but that's what's in this code. And there's nothing other than what's in this code. That's what I meant when, while this has become a referendum on coverage for retirees, the insanity of keeping a language that sets the rate for HIP, where thousands of non-city workers or even city residents are setting the rate because they're regional, they're people in Westchester and that are not city workers, that are part of this rate right now. And the fact that this remains the language that we're protecting, that is to me insane.
Okay. Thank you.
Thank you, Councilmember Ressler, followed by Councilmember Dinowitz.
Thank you again, Chair De La Rosa, for holding this hearing today and for your leadership. And I really do want to thank each of our labor leaders for being here today and for the testimony. I have to say the speaker, I think, asked the question of the day that I think we're all struggling with here. I believe everybody's coming from a good place, that you're concerned about everybody who has been through your union in an earnest and heartfelt way, and all of the retirees who are here are truly fearful about what this means for their health care. And so our inability to communicate to them on why this is not as devastating as they are all convinced that it is the crux of the challenge that we're facing. And so I really want to kind of echo the speaker's sentiment, and appreciated your responses, but I think the next question is, well, how do we move forward? How do we actually try to forge some compromise between the work that you all have put in the MLC on this plan with the concerns that the retirees have raised? How do we work together on a path forward? And, Henry in particular, you're as thoughtful about these issues as anyone I know. I know you put an enormous amount of effort, and each of you put an enormous amount of effort into this. Would welcome your thoughts on how do we try to get folks around the table to work constructively to forge the compromises that are necessary for us to move forward.
I can tell you that was within our control. We've tried very hard to push back enough on the contract to have checks and balances, performance guaranteed. We push on the pre-authorization, as you heard today. 76% of the pre-authorizations have been removed. We push on the Part D drugs being extended. We push on the network to allow for PPO to get more doctors into it. To the extent that things were under our control, as authorized by the arbitrator, we've done that. There are things that are not under our control, right? The Judge Frank's decision was not under our control. We made the case, or the city makes the case, and he failed in doing so. There are things in the decision there that are very positive in saying you can't charge more for the retirees, but also don't provide an answer for saying, oh, but you don't have to, or you don't have to provide a choice. So we can keep litigating until whatever, but the fund is not there. The funds are not there So at some point, the answer is going to have to come to say, once the reserves are out, once the 15,000 litigations are in, then what? Where do we get to the point where we have an honest conversation about alternatives, as the chairwoman said, right? So in this case, we have been presented and have been going through this for at least 8 years. And I know Michael touched on it, Harry touched on it, and the others here. We've gone through a myriad of different things that we've tried. Some have worked, some have not as worked as well. And the cost keeps coming out. 10 years, the cost was $4 billion, is now $12.9 billion today, right? It keeps going up. And the hospitals keeps charging, and the prescription keeps going up in spite of our best effort. So at what point do you sit down and say, well, this doesn't make any sense, right? We need to change this, and you need to change alternatives. And I get the fear that a lot of retirees feels that this is about cutting corners to save money on their backs. And they were promised, even though it's not constitutional guarantee, health care, right? I get that. And I've spoken to many of them who are part of us, who have supported me for the years, and are asking me, Henry, what are you doing this now? And I'm saying to them what I'm saying to you. There is no funds available anymore on this structure that we have, under this construct. So if you're not going to provide a change that an alternative can be negotiated, then where's the funding going to come from other than active workers, right? Or the collective bargaining agreement, or are you going to ask workers to give up a raise for the next 3 years to cover for the cost for everybody? That's an unreasonable thing to do, because no collective bargaining would ever be ratified under those circumstances. As I mentioned before, we did that in the last round, where I took half of a raise, that quietly done, right? That was really hard, right? To cover for the retirees and their spouses. And we did that because it was a responsible thing to do. But I don't know that we can keep doing that. So in the absence of this, and on the presence of a rising cost, there has to be a way that we can either control costs and then find a different way to pay for it. Medicare Advantage was one of those ways. And if people say no, then what's the reason? Because I've heard somebody talk about $300 million in savings. We've looked at some of those ideas. We don't quite think that it raises to that. But even if you were to stipulate the $300 million, we have a $1.8 billion deficit. So then what happens to the 1.5? And what happens to the 600 and rising every year thereafter? That's the question we still have in front of us in the absence of the amendment to Administrative Code.
In terms of, the only way, the original contract that had the option to pay up for senior care was part of what I was asked to do by my retirees. Because they wanted to, as I testified before, it was, all right, we believe that you're really trying to do what you are saying, that you're designing something that doesn't exist, that would be the best one in the country and all the rest of it. But we want to see it for a little while before we may or may not go in. We might go in, but we might like the option to come out if we're not comfortable with it, or if it's not doing what you say. And I get that fear. Believe me, I get that fear. The elder care that I'm supplying to my own family, plus the fact that, I could retire right now. So I know what we're doing is the right thing, and the plan will do what we say it does, or unless we will get out of it, or the company will be so costly to whatever company we're dealing with. We're going to the place where we're not saying if there's a breach of contract on the company side, we're going to court. We're taking it out of that because we don't want to spend years in court trying to get something fixed. We need immediate fixes to any sort of issue that you see at any time. And that's how serious we are about our Medicare Advantage program. But until people are actually inside of it and seeing it working, how do you alleviate the fear is your question. And we were hoping, we knew at this point to keep senior care is not something the original insurance companies who did get into a contract wanted to do. They did not want to pay up option. And we know that the one we're trying to negotiate with now does not want to pay up option. Why? Because they get more people inside of their plan. So that was what we were trying to do when we originally put the choice piece in. That's why we're here at the council, to put the choice piece back in. Because if we don't do that, one day we're moving forward with Medicare Advantage because we have determined, we've made this decision that since we have so much control over the negotiations, over what goes inside of it and how to put checks and balances in it, to have our own independent people looking at it constantly, we know that this is a smart way to deal with healthcare because those subsidies are very good. And at the same time, we can deliver the service that we know every one of our retirees need. But how do we get to that point is really, that's why we're here. We were hoping, once again, to have our collective bargaining rights to do a pay-up plan. And I know 191 is a significant amount for a lot of for retirees who are on smaller pensions. I understand that. But unless the city wants to take up some of these costs, but then at the same time, remember, these are recurring costs. These are not one-time owners. And we've seen a lot of the ideas. We've done most of we're in the middle of auditing again. We're constantly auditing everything inside of all of our healthcare, because we look at healthcare as everyone. We don't, especially, we don't think of healthcare as retiree or in service. We try to say all city workers, those who have worked and those who are retired, and how do we make sure we keep achieving that goal of giving them that high quality premium free, and also giving them choices where if they choose to pay up, they can. So really, it's about that, and that's why we're here today, is to get our collective bargaining rights back and to have the ability to offer choice that would give some people the chance to say, all right, maybe I'll go in, but if I want to get out, I can get out.
Thank you. Councilmember Dinowitz, followed by Councilmember Brewer. And I want to recognize we've been joined by Councilmember Mealy.
Thank you. Thank you, Chair, and thank you, Speaker, for asking your question before. I first want to thank all of our labor leaders for your work, the people you represent, both in-service workers and retirees, and recognize that despite disagreements and strong feelings about Medicare Advantage, that it does appear and seem like you are negotiating the best Medicare Advantage plan within that framework. And so should that go forward, I do want to thank you for that, because I think it is important to recognize, and also thank Mr. Mulgrew. I have been asking for over a year, including in this committee, the previous administration in October of 21, why, if Medicare Advantage is so great, why we didn't do it earlier. And I think, Mr. Mulgrew, you're the first person to ever answer that, so I want to thank you for that, and why it's so important that we're having this committee hearing, and thank again Chair De La Rosa. I have two questions. Some of the outreach I'm getting from constituents is it feels like this is a quick and easy way to save money, and that the unions haven't really done the work to save money. That's what I'm hearing. And you alluded to things like steering people away from hospitals and urgent care and toward I guess, primary care. So I'm going to ask both questions in a row, and just would love to hear you all expound upon them. So the first question is, can you just more concisely say some of the steps that have been taken to save on healthcare costs before moving to Medicare Advantage? And the second question is about specifically senior care, and about, it's clear you're negotiating for what you're saying is the best Medicare Advantage plan, one that's tailored to city workers and mirror city workers. Is there a parallel track or a committee assigned to negotiate senior care? And how does a change or lack thereof, change in administrative code, impact the ability to currently negotiate or renegotiate the pay-up cost of senior care?
Okay, let's just start with the two very large things driving most of your increases. It's hospitalization and drugs. Yeah. We did an RFP on our entire PICA fund that's saving us over $100 million a year. And that's continuing. And that's for all of our workers, because the PICA fund to us is something that is sacred at all times, because that is for families who are really in medical crisis and distress. And the last thing we want happening to them is them not, or having to pay out of pocket for some very, very expensive drugs. So that was that's a very large thing that we've done. Then the other piece is, and this is where the creativity comes in, when we looking at hospitals, I think the public might be shocked to know that, we look at what it costs for every type of different procedure. in all of the different hospitals. And then we look at to see who actually has the best outcomes. And the public might be shocked to find out some of the places that are most expensive have some really bad outcomes. So then what we tried to do at that point was we said, all right, what are two of the biggest issues that we have, sadly, as a workforce or retirees? And it was cancer and any sort of orthopedic work. We do quite a bit of it. So then we went and found the hospitals that do those better than everyone else and actually are nowhere near the most expensive. And then we went and negotiated exclusivity basically with them, made them designated hospitals of excellence for all city workers and retirees. And that has saved us quite a bit of money on hospital costs. And that was with Memorial Sloan Kettering and Hospital for Special Surgery, which is why we won't enter into any Medicare Advantage contract unless those two institutions are inside of it. But every time we've done that with an insurance company, because of our own relationships with those hospitals, they have gone inside of it. So those are two of the things that deal with major cost problems, which is hospitalizations, and then inside of that you have the orthopedics and cancer, and then on the drugs itself. So that's just like the easy stuff we can explain, but we're constantly looking at areas, as I said, to drive costs down. Recently, we did just put a major copay on one of the urgent care centers, the only one who did not respond and renegotiate their prices with us. The only one who did not now has a massive copay on because we just don't want people going in there, period. Because, you know, if you're sick or you're a worker or you're not feeling well and you're a retiree, you go into a place, you have no idea that this place is charging you 100% more than the other place down the street. You have no clue that that's happening. Nor should, you know, that's not what people talk about. It's not like you go into an urgent care center and it's McDonald's with a menu with the prices. That's not reality. It's the bills come later. In terms of a senior care, if the administrative code change does not happen, there's no reason for us to go to senior care at this moment. We are having conversations, but at this moment, there's trying to be a determination whether senior care will even exist anymore. Because if the administrative code does not change, does not happen, then there probably will never be senior care again. And that's why this is so important to us.
Thank you, Council Member. Council Member Brewer.
Thank you very much. And I do obviously have a lot of respect for the unions. This has been a lot of effort on your part. So people ask me, I think the challenge is we don't really know what this Medicare plan is. And that's what, you know, it's an unknown. And the funding is unknown. So people ask me this, federal funding from Medicare Advantage, people feel will be far less than the $600 million a year or the 191 if the retirees choose to pay that. So how much will the feds be paying per year and per patient per month? And considering that we understand, again, I don't know if this is true, they say, considering that Medicare Advantage administration costs could be 30% of the total costs, apparently they far exceed what the government operated, obviously senior care, Medicare admin costs around 6%. So then we worry because we figure less money means less health care. That's how it comes across to those of us who are concerned about this issue.
Let me just say, this is part of it. You've heard a lot, and people saying we're in New York City, we're not in Medicare in Ohio or somewhere else. We're here in New York City, right? So why are we saying that and then comparing those things in those states and then applying it to a program that basically hasn't even come out yet? So this is part of the information. Every contract has its rate. The reimbursement by the federal government is based on patient satisfaction. If your satisfaction goes down, your rate, your star rating, as you heard the chairwoman, goes down, and therefore your subsidy goes down. So there's an incentive to keep people reasonably happy, right? The biggest concern I've heard from the retirees is we don't want reasonable things that are needed to be denied. We don't want folks cutting corners. We don't want things for the sake of savings to be denied things that we think we ought to have, that doctors are telling us that we ought to have, right? So that goes to the issue of the prior authorization that we talked about, right? Lab work. I don't want to be referred to a nutritionist when I need a CAT scan, which, in some parts of the country, quite frankly, has happened. So we worked really hard to remove the prior authorization as much as we can, and we've been able to achieve that. So you can't compare what has happened in other parts of the country to the program that we are negotiating here, because we truly believe we're negotiating a contract so far that has unprecedented things, precisely to address the fear, the concerns of the folks. But let's be honest, even if you get everything that you think you would address, there are people who still are going to be fearful and skeptical and say, well, no, they're lying. Okay, so that's where the choice comes on. People need a choice. In the absence of an administrative code, I cannot say this enough, the speaker said it. In the absence of a change, there will be no choice. For the very same people that are fearful, the very same people that want an option, the very same people that want an alternative, there will be none. Because unfortunately, the way that the judge decision is written, they don't have to pay for it, and the city's insisting there will be no money for it, right? And given the state of the stabilization fund, it's not gonna go anywhere. So we have to be mindful that we can address those concerns that happen in places across the country, but it won't be an apples to apples comparison, because this is a unique contract where we've been able to negotiate things that do not exist anywhere else in the country.
I mean, I hear you. I think the best, as others have said, is put you and the city and the retirees in one room and try to work this out. Thank you.
Which retirees?
Okay.
And I just want to throw one thing in there. Remember, this is a 5-year contract if we finalize this one. And I don't know why the city was answering the questions the way it did this morning, but we could just bid it out again. I mean, this is, if we're still if we don't get some sort of federal intervention, we would just be just as aggressive as we've continued to be. And if we can show that we can actually, our plan, when we do show that our plan does everything we say it can do, it's not like a company's not going to make money. They're going to make money just on the managing of it. But see, that's what our goal is here in New York City. Since we're so large, our goal with these companies is, look, we don't care about your quarterly profits or anything else. You should make a management fee for processing our plan. That's it. That's all. And we don't care about anything else for you because we're so large and there's so many of us inside of the plans. That's our buying power. And that has been continually at the heart of all of our negotiations. But this is a 5-year contract. I had a lot of questions about what were the caps after the 5th year. Who says we're even going to be here with them after 5 years? We're going to continue to maintain high pressure aggressiveness on every entity inside of the healthcare industry.
Thank you. Councilmember Ariola, followed by Councilmember Bacha.
Thank you, Chair. I just really have one question because I really want to start to get to the retirees and hear their testimony. But Henry, earlier you mentioned that about for your members there was an eliminating the benchmark hip rate, and you were concerned about that. So if it was so important, why wouldn't this be done in a way that brings everyone to the table, other than without simply eliminating it, which would really not be a very good practice?
Just to be clear, the bill doesn't eliminate the language that exists on the HIP HMO rate as a bench. It merely adds language that provides for an alternative to be negotiated. So that alternative doesn't wipe the existing language. It simply says that we have the right to negotiate alternatives, as you mentioned before. Just to clarify, right? So there's nothing in the bill that wipes that out. I keep insisting, right, that this system was set back in whenever, right?
1982.
82, 83, whenever the language is, and doesn't make any sense anymore, quite frankly, right? And I want to take this point because there's 250,000 lives and contracts on the HIP HMO. Right now, it's regionally based. If you ask how many of them are city workers, it's less than 200,000. So then that means that would imply there's a number of private lives, private sector, that we are now subsidizing into this program. And yet we don't even get to question it because it's been in there since time immemorial, right? And I think Councilmember Brennan talked about this. That makes no sense. Irrespective of the retiree issue, just that in itself doesn't make any sense, but we're still beholden to it. And then secondly, if we're going to talk about an alternative to the cost that doesn't shift the cost to retirees, That would be a place to start, right? If we're subsidizing private insurance. But we can't even do that because, unfortunately, we have a decision that basically says they don't have to pay for anything other than whatever has to pay outside. So I'm open to ideas, I'm open to discussion, but it's hard to do that when you have a language that is so locked into, right? I don't know if you wanted to add.
Thank you.
Thank you. Councilmember Bottcher.
So hospitals in New York State are primarily regulated by the state legislature. Could you give us a snapshot of your efforts at the state level to stop price gouging and overcharging by private hospitals? What have your efforts been with the state legislature, and what have the outcomes of those efforts been?
I'll start with the first one. One of the efforts is to, and I want to thank you because I know you're one of the co-sponsors on it, is to do the very bill that the city council has done, which is on complete transparency of hospitals. But we have not been able to get that through in Albany. Why? Because we know we have the Hospital Association, and they're very strong lobbyists who have continued to use the process of the state control of how hospitals can do pricing, have used that to their advantage greatly over the last couple of years, which is why New York State has the highest health cost inflation. We did the surprise billing, which is came directly out of the MLC. We got that legislation passed so that if someone is, God forbid, in a different area of the state of New York and they have an emergency and they're in an emergency room, that all the crazy bills that we used to see, crazy costs would be added into it, that now we have a right, the companies that we work with have a right to audit in terms of surprise billing. And now that nationally is now something people have realized they need to do. But every year, I mean, there's constant little changes in regulations and policies that sound very simple, but people don't understand that it equals millions and millions of dollars more that hospitals can charge. Now, I want to be clear here. Hospitals are a very important part of all of our communities, and there's some really good hospital networks who try to do the right thing. It's a very complicated world and it's difficult. But when you tell everyone you're a non-for-profit, and I have nurses, I represent a couple of different hospitals where the nurses belong to the United Federation of Teachers, and their CEOs are getting millions and millions of dollars in bonuses on a yearly basis. Yet when you're at the negotiating table, they tell you you're broke and everything else. They spend more money on billing and coding to make it more complicated, just so they can charge more. But those are some of the things we've done at the state level. But again, I can't thank you all enough for the bill on the hospital transparency, because that is literally a bill we've been trying to get introduced in Albany for a couple of years. And then Henry could talk about the Health Act and the other things that we've been working on. The HEAL Act, I'm sorry.
Yeah, and I'm sorry. Harry, Michael, myself went to Long Island some time ago to convince Long Island legislators to pass an amendment to the law that would allow to ask for a simple question about the ability to audit hospital claims. We're in a contract with Emblem Health, with Empire. The fact that we can't even audit the claims for a particular hospital seems absolutely ridiculous to me.
Yep.
I mean, the fact that they can charge us what they want. I mentioned that hospital that's charging us over $1,000 for a claim, and I said, this makes no sense. Everybody else is charging you 60, 100, 150. HAC has, even Mount Sinai, you can't even make the case that this is because it's Manhattan and real estate, same hospitals in the area, and you say, why are you charging $400? So the bill, the HEAL Act, the Hospital Equity and Accountability, was supposed to be transparent and do what the Councilmember Menin's bill is trying to do. That's the system that we have now, a system without any checks and balances. When the city and the MLC ask for those hospitals to come down and basically be responsive and say, why are you doing this? Why are you charging 400%? We met with Northwell, we met with NYU, we met with Mount Sinai, we met with HAC. There were two hospitals who said, we're not meeting with you. The answer is why? Because we don't have to. Guess who those hospitals were? The two largest hospital systems that are charging us 400% over Medicare, the Medicare rate. That's the system that we have now. Now, whether you think that this argument should be about retirees or not, that's the system that we have. There's a complete monopoly, and the bill was supposed to provide transparency, not to change it because we can, but to at least provide some level of transparency where people know what they're being charged for what services. And as Michael said, the hospital, aligned with some unions, went into Albany and watered down this bill to the point that it was like it's there. We're appreciative of the legislator for passing it. We think it's a path in the right direction. It's progress, but it's certainly not anywhere near what we wanted to do by way of transparency. This is the second round. When we did the DIR bill, it was the same concept. And the MLC officers went and lobbied the legislature, met with the city, with the state folks, met with the council, with the Senate leader and the House Majority Leader several times, and had to convince a group to do it. And yet, the hospital industry was great. You know, the Greater Hospital Association was in the budget process changed and watered down and took away, and continues to allow the same things that we're seeing right now in our system.
Thank you.
Thank you. I do have a question. One of the things that was asked of us is, you know, how will this plan that you're negotiating with Aetna compare to senior care currently? And the city went into large detail about what the city's perspective is on the negotiation that's at the table right now. Can you provide us a time frame of what those negotiations look like? And also, if there's any details that the city might have left off that you think the committee should consider, please give us that information.
Henry, you want to start that one?
Yeah, I mean, we are under the timeline set by the arbitrator, so we believe January 29th is the deadline that we're going to have to. I think there's been significant progress towards getting to addressing some of the concerns that were raised. As Michael said, we're not there. We don't have a contract yet. That contract will determine how many lives cover, right? What the savings, what the subsidy, what everything will be in that point. And I think we provided a cost comparison, a chart, a side-by-side chart of what it is and what is so far, and what senior care versus the Aetna Medicare Advantage. And still, as I said, we can do that, and before this is over, we should finish that process. But I want to be very clear, if you don't amend the code, for those who are still remain skeptical and still don't want to do this, still want to say, no, this isn't right, this is just selling a bill of goods, there will be no choice other than that. And that would be a travesty, because so many of our people would want a choice about what's happening, and whether we find a way to pay for it, for that choice or not, still the choice needs, and we believe, and that's what we're here to do today, needs to be provided, a choice.
And in terms, look, our negotiations are moving forward, but we're not there yet. You know, if we had to vote, if there was a vote today, I would be voting no. But we are making progress to achieving our goals. The benefits will be more than what we currently have in senior care. The city was right in that, in what they testified to. But to us, we have the same fear and skeptical nature as everybody in this room does about insurance companies and healthcare. So it's really what we're looking for is really ironclad checks and balances and watching everything, you know, reports. We're not going to go begging. So the things we just complained about the hospitals, you know, we deal with that with insurance companies too. So now we're just putting this, it has to be part of our contracts that we get the records of everything, all the procedures. Of course, we comply with HIPAA and everything else, all the procedures, everything going in, prior loss, any sort of denials, everything. We will be getting those on a monthly basis. And we're going to have our own committees working through this with assistance from technical experts that we hire. But we're not there yet. And one of the things is that if we finalize a contract, right now, we can't offer senior care as a payout because of the judge's order. We can't do it. We cannot put it in the contract.
Okay.
So when people talk to me about, you know, the Medicare Advantage, and I have no issues with discussing everything people want to do about the Medicare Advantage program when we finally get it done, but this hearing is not about Medicare Advantage. This is about whether we can include in any contracts as we move forward options for our retirees. Because that judge's ruling that said what we've been doing for 50 years we no longer can do, that was the most damaging part of the judge's ruling. Remember, the original court case was about the RFP process was done wrong. No, RFP process was done perfect, no problems. The rollout of the plan, and that I will agree with with Greg, the previous administration really mishandled a lot of this. But we want, if we finalize a contract, we want to be able to offer the option. And right now, we cannot finalize a contract with an option for senior care.
Great, thank you. There's a question about other unions. Do you know of any other unions that have done a similar negotiation on behalf of their retirees?
Well, part of our due diligence as officers, we met with other unions who are having similar problems. 1199 had their issue, implemented Medicare Advantage, a lot of resistance, a lot of fight, and then they were able to get through 2 years difficult. 32BJ, we met with CWA on the Verizon contract, and I think Gloria can speak to that.
Yes, on the CWA, the National District 1 negotiated contract for Medicare Advantage. I don't have the details as to what that contract entailed, and I can certainly ask the district to share it with you guys, but I know the members are very happy with the plan. They do it, it's specific to the Verizon workers. It's not the plan that you see on TV. It's a specific plan, and that's exactly what we're trying to do a specific plan for the retirees, for the city workers. But it has worked, and CWA members are happy with it.
I spoke to different unions, both here in the state of New York and across transition, and they said always about implementation is the roughest part, hands down across the board. Implementing a new plan is always difficult. Some of them have renegotiated out with different companies because they didn't like their first provider, but no one was going into the details that we have gone into here in New York City in terms of our negotiations. People have to understand that whatever company gets this bid, they can't use their existing infrastructures. They have to set up a whole separate thing because the plan is so different than anything that's currently out on the market. So that is one of the big things that we've done, is really reached out to other folks. I was shocked to find out that the amount of retirees who are in Medicare Advantage plans, both here in the state of New York, state workers, my state unions has a lot of retirees in Medicare Advantage plans. But I didn't understand the scope of the amount of people, retirees who are public sector workers that were inside of Medicare Advantage plans.
Thank you. Before we dismiss this panel, any other questions on the committee? No? Well, thank you so much for coming here today and answering our questions. Up next, as we transition, we will go to Marianne Pizzola, Wendell Potter, and Michelle Robbins. Please, please. The rules still apply so that we can hear everyone. Thank you so much. All right, we're gonna ask everyone to settle down so we can begin with this panel. And panel, you may begin when you're ready. And identify yourselves for the record. Thank you.
Is this on? Good afternoon. My name is Mary Ann Pizzatola. I'm going to read my abridged testimony, as my full testimony was enclosed for the record, as for the sake of time, but it was also give you time to ask us questions. Good afternoon, Chair De La Rosa, Speaker Adams, council members, and members of the Civil Service and Labor Committee. I come to you before you today with a wide range of emotions. My name is Mary Ann Pizzatola, and I am president of the New York City Organization of Public Service Retirees and the FDNY EMS Retirees Association. As a retiree, I left the job, and I would never have thought I would have had to fight to retain something that I already earned and paid for. I should not have had to form a corporation, organize over 100,000 retirees, fundraise, hire lawyers, government liaisons, and sue the city and fight my own union, DC 37, to protect my health benefits from labor relations and OMB. As you listened to today's testimony, it was clear that there were 3 takeaways. 1, Medicare Advantage is not a good health care plan, even by the federal reporting by Health and Human Services, Office of the Inspector General, and the government accountability reports have all agreed. This is one of the main core reasons why the retirees do not want this bill. And paying for premium coverage is impossible for many of our low-income retirees. Number 2, there is no deadline, especially not this month, to make this change that you're being asked to make. The threats by the United Federation of Teachers, DC 37, and the city that an arbitrator gave a deadline are lies to shove this down our throats. And this isn't about change or fear of change. This has nothing to do with that. This has to do that we materially investigated the differences between Medicare Advantage and traditional Medicare with a supplement. We should take our time to get this right, because rushing is what got us here in the first place. For example, health insurance companies will profit massively, while our people will get hurt if this goes through. Let's all combine our strength and fight and bargain with the insurance companies. Number 3, if this passes, the lives of some of the most vulnerable New Yorkers, those people who many of you got elected to protect, will be harmed by making it tougher to get proper health care. Please understand that the unions are trying to get you to change a law that has been around for over 55 years. Mayor LaGuardia wanted to give people health care and dignity in retirement, and that's what this did, because it protected us all equally, to the same benchmark. Not where the city is lying and saying that my plan for me, because I'm on Medicare, is worth $7.50 or a $0 premium, but theirs is worth over $900. And according to the actuary reports today, Mr. Godner was not so truthful. The plan wasn't $7.50, and that was even in the actuary report that didn't exist. What they did was they took a plan that had a rate of $888 and change, and overnight dropped it to $7.50. And then because Emblem wanted to keep their HIP VIP plan competitive, they dropped their rate to $7.50 too. So I want to talk about market manipulation. That's a pretty good example. The union's contracts are expired, and that's why they want this. There's no emergency, and the city isn't going bankrupt. And if it was going bankrupt, why would you take health care away from retirees while still in a pandemic to fix it? Not even in the fiscal crisis of the 70s did the city take away retiree health care. And when you change the administrative code, the city will have the leverage to change the active workers' plans, and this includes you. And when this happens, the unions will blame you. When the active workers realize that it was the city council that allowed the city to screw them, they will not forget that you gave them the ability to do that by changing the administrative code. The new benchmark will be lowered for them too, and Mayor Adams and the union will smile, and you will be blamed. As for the City Council of Record, we urge you to just say no to Intro Bill 874. You have the power and the voice to protect us because you are all we have. Under the law, our unions no longer represent us. And over the decades when other mayors tried to take away benefits under Abraham Beam, under Mayor Koch and Giuliani, it was this body right here in this room that protected us every single time. If what the unions and the city say will happen, you can always intervene. But if you do this now to fix something that hasn't even happened yet, you will never be able to undo it, and we will never get it back. I'm happy to answer any questions that you may have, and thank you for having us here today to be heard.
Push. Okay. There we go. Sorry. Good day, council members. This is an abridged version. I'll take up my 2 minutes. I just handed in 20 copies for you guys. Sorry. My name is Michelle L. Robbins, and a retired FDNY EMS lieutenant, former New York City resident. I wanted to work for the city and got caught in the hiring freeze of the 90s. I worked as an EMT in the private sector until 1993 when I was called by HHC to work for the greatest city in the world. I jumped on it. I made more money in that private sector, but having a small child, a single parent, I needed a pension, good health benefits during my tenure. I knew after I retired, I would be entitled to good health benefits for life. During my 20 years of service, I was a rescue paramedic, a first responder at the worst terror attack to affect the city. I spent 9 months in the pit. I still have flashbacks that I don't care to speak about. A few years before retirement, I was injured on the job and forced to retire with a disability pension. Went on Medicare, had to move upstate, have medical conditions undiagnosed, most likely 9/11 related. I suffer from severe back pain, joint pain. I've had 14 surgeries, job related. I see doctors at least 4 times a month, travel 4 hours one way to get good medical care in this great city. A MAP plan will destroy me. My docs are dropping these MAP plans just as the city of New York is dropping them. There are signs all over every day. Retirees are not represented by the unions. We have no rights. We don't get PICA. Why should our retiree benefits be sold off to pay for misused stabilization fund money? This is disgusting. Who does this to people? The MLC and the city are. The MLC and the city are trying to circumvent Judge Frank's decision because they lost. In law, the word dicta means opinion. So one plan on the table they claim means just that, just like Scheinman's letter, a opinion. I saved lives in this city. Now I'm trying to save my life and that of hundreds of thousands of others. Please vote no on Intro 874. I am grateful for your undivided attention, and thank you.
Chair De La Rosa and members of the committee, thank you for this opportunity. If you don't remember anything else I say today, please remember this. Medicare Advantage is neither Medicare, nor is it an advantage for millions of Americans. And I should know, I'm a former healthcare executive who used to come up with the PR and marketing schemes to sell these private plans. And I'm also the son of a woman who would have died 10 years before she did had I not been able to move her out of a Medicare Advantage plan. And I can explain that if you'd like to know more in the Q&A. My name is Wendell Potter, and I'm a former Cigna vice president. My name was on all of Cigna's quarterly earnings reports for 10 years. I had to know how the company made money and what it did with that money. My team and I also wrote talking points for our lobbyists. I walked away from my career because I could not, in good conscience, keep lending my name to press releases and studies that all too often were biased, and to even engage in the practice of twisting the meaning of words like the word choice. 3 years ago, the New York Times published an op-ed that I wrote under this headline, How the Health Insurance Industry and I Invented the Choice Talking Point. To this day, the industry churns out studies that omit or obscure facts and data. The insurance industry does not want us to know about Medicare Advantage plans and other policies with sky-high deductibles. As a consequence, millions of middle-class families are now buried under a mountain of medical debt while insurance companies are posting record profits. And they did, especially during the pandemic. All of the big for-profit companies reported record profits. Medicare Advantage has become a big reason for those profits. It is an enormous cash cow for insurance companies, in large part because they engage in a scheme to make enrollees seem sicker than they really are to get more of their tax dollars. The federal government estimated just a few weeks ago that because of the way insurers have rigged the system, it overpaid Medicare Advantage plans by more than $11 billion last year alone. To be blunt, they are stealing our tax dollars to enrich their shareholders. I was astonished a few minutes ago to hear that Aetna was told that they don't care about quarterly profits. Folks, that is absolutely what you have to be paying attention to. In my written testimony, I will provide ample evidence of how Medicare Advantage plans have bamboozled employers, unions, lawmakers, and the public for years for no reason other than to maximize profits to keep Wall Street happy. And in fact, just a handful of Wall Street financial analysts. I hope you'll find time to read it before you vote. Medicare Advantage, folks, is a money-making scam. And I should know. I helped to sell it. So I implore you not to vote in favor of hurting the city's retirees in the Medicare Advantage plans. Doing so will not make retirees healthier, but it will make the bottom line of big insurance companies much healthier with the hard-earned tax dollars of the people of this city. Thank you very much.
Thank you so much. I just want to clarify for the record, this committee has not scheduled a vote on this legislation. This is the first hearing on this legislation. So I just want to clarify because we have been getting a lot of emails saying vote no. We are not at that point yet, although we appreciate your advice and your opinions. We are not there yet. I want to make sure that we're calming people's expectations on that. And I want to thank this panel for coming and testifying. I do have a few questions myself, and then some of them are repeats. We just want to get people's opinions for the record. In his December 15th, 2022 opinion, Arbiter Martin Scheinman prohibited the city from continuing to offer GHI senior care unless the council amended the code within 45 days to authorize the city to charge retirees for the cost of GHI senior care. If the council does not act within that time frame and senior care is eliminated, what options will be available to retirees in your opinion?
Well, I think in our opinion, and you've heard from our legal team, that the city does not have to listen to the arbitrator's report. It is his opinion. The deadline that's being forced down your throat to say you have to do this by this point, it scared the bejesus out of all of these people. Because we were looking at it not understanding why you felt that you had to live up to a deadline, rush something through that no one's heard about yet, there's no plan on the table, that he was allowed to mitigate issues between the two parties. We are not a party. They are not a party. The two parties involved in that agreement was the MLC and the City of New York, and there were no issues with them. They were equally aligned to do this to us. The only issue that they had was with us and the court, which then they've also, throughout this entire morning, in their testimony, misrepresented the judge's decision and misrepresented the importance of the Scheinman report. Even in the Aetna case, when Aetna sued the city right before we did over the negotiated acquisition process, came of issue was who was Mr. Scheinman and what was his role. The city argued in that case that he wasn't an arbitrator, but he was a consultant. Is he all of a sudden not a consultant? He's time barred in his agreement. According to the agreement, he is only allowed to mitigate issues between the two parties in paragraphs 1 to 4. Medicare Advantage comes up in Article 5, number 5. And he was time barred from that too, and according to June 30th of 2020, was the last time that he was allowed to be involved in that. If you look at the 2021 OLR letter to Mayor de Blasio, OLR writes, Ms. Levitt wrote that all of the benchmarks to their savings agreements were met in their 2018 MLC agreement. How did Medicare Advantage come in? It wasn't even counted towards the savings tally that they needed. They decided to use Medicare Advantage as a way to subsidize the stabilization fund, which doesn't really serve a Medicare eligible retiree. The stabilization fund was meant for two things. primarily for stable, it was a cache of money. It was supposed to be a pot of cash, which the equalization agreement was put money into it in order to provide active workers and non-Medicare retirees with an option of free health care plans. When the money became plentiful, they started to put other things in there. But according to the Independent Budget Office and the Comptroller, this fund has been misused. And as early as 2014, as most recent as 2014, under the UFT contract, they allowed $1 billion to come out of the health fund to fund that year's collective bargaining because it was in a provision in the teacher's contract. They also had to agree to health care savings. So we're looking at selling off retiree health care to fund a stabilization fund that doesn't really even benefit these people. The only benefit that Medicare-eligible retiree gets out of the stabilization fund is a prescription, vision, and dental plan, whatever their welfare fund benefits are, and that's if they have a welfare fund, if they have a union. Because we have retirees that are commissioners or managers that don't have unions or welfare funds. So why are we selling off their health care to subsidize something that they're not going to really benefit from?
Thank you for walking us through that. Let me ask a question. There is disagreement across the board from both sides on the arbiter and his role here. Regardless of that one point, which we're trying to clarify as a committee, would you agree that the MLC and the city have the unilateral ability to still move people into Medicare Advantage at this time?
Healthcare is supposed to be a citywide agreement. It was one of the things that's supposed to be negotiated between the MLC and the city. But in this case, it's being used as a weapon to take away from one group. I would say a retiree under the Taylor Law. Unions are not supposed to represent us. In Harry Nespoli's testimony in our case, he filed an amicus taking the side of the city, which was an absolute tragedy that a union came out against their own union members or retired union members to take the position of the city that they could do this because he represents us. But then in the same report that you're talking about, Mr. Scheinman, he says we're disassociated. So if I'm disassociated and I'm not part of your group, then maybe you should just grandfather us in and do your own thing. But what gives you the right to negotiate something for me when you've never done that really before? They may have made incidental little changes, add a minor little copay here, but what you're basically saying is that the MLC structure is what makes this even more scary, Chair. It really does, because you have 100-something unions in the MLC. I can't even find out who they are because OLR refuses to tell me under FOIL.
I understand that, and I share some of the concerns that you're citing here.
But then it leaves Michael and Henry to make a decision for you and for me.
But what I'm asking, going back to my question is, theoretically, if this council says we're not going to amend the administrative code of the city of New York, does the mayor and the MLC, they can wake up tomorrow and say, everyone is moved to Medicare Advantage?
Well, if they did that, I'm sure we'd see them in court pretty quickly.
I get that, and you have and maintain that right.
Well,
we need order so that we can follow the conversation.
I would only have that right. It would be an easier path for me if you didn't change the code. If you change the code, you make my path to litigation and advocating for all of these people that much more difficult. Because the code sets the standard.
We understand that completely. But what I'm trying to get at here is the council, the job that the council's been asked to do up until this point is to change the code in order to allow for the option of senior care. Please explain to us your disagreement with that statement, if there is a disagreement.
So under the 1992 MLC agreement, the city and the MLC already have the ability to negotiate health care. They already do. They've had it the entire time. There's nothing that shouldn't change. That agreement requires them to do that. And Mr. Nespoli knows this because he sued the Bloomberg administration in 2013, when the city went to initiate an RFP process without negotiating with them first.
But it goes back to the same question. If the MLC and the mayor have the ability to negotiate and they're saying they're unwilling to negotiate for senior care to remain the city offering plan, then what is the choice, in your view, that this council then would have as an alternative?
To take away our senior care? Is that what you're asking?
As an alternative to that reality that I just stated, that the MLC and the city have the right to do. Anyone on the panel can respond.
I'm going to ask if our legal counsel can understand that, because I'm not sure I really understand what question you're asking. This is Jake Gardner.
Let me repeat the question. If the MLC and the city, according to you, have the ability to negotiate and renegotiate senior care, but they are saying that at this time, because of the cost of senior care, they are unwilling, they're taking that option off the table for us to consider as a council, then what is the viable alternative that we have other than giving them, through local law, the alternative to actually keep that offering?
You don't have to do what they're telling you to do. And I think the ruse is that the senior care is what's bankrupting the city. Our senior care doesn't come out of the stabilization fund. You're being asked to do something that you don't need to do. Senior care has went from $88 and change from 1997 to $191 in 2022. That's a 5% increase a year, versus the active workers plan, which has increased over 21% a year. How are our cost was like $439 million in last year's CAFRA reports. How is our cost bankrupting the city? It is 0.6% of the entire city budget. This makes absolutely no sense that you're even asking this.
I retain the right to ask the question.
I respect that.
As the committee has put them forth to us as a council, and I am stating these questions not with a position, but with the intent to get answers from you all who have been working on this alternative. So I'm asking about the alternatives. But I will move on, since there does not seem to be an answer to that question. My question is, you stated also in your statement that at this moment there is no crisis. I want you to understand from the point of view of myself, I guess as the chair of this committee, that expired contracts for current city workers for years, no wage increases since before the pandemic hit, and basically the financial health of this city is a crisis, and it is a crisis that this council has to contend with. So my question to you is, do you consider that to be a crisis that we as a council must deliberate and deal with?
That is your crisis, correct? I'm not going to say it's a crisis. That is a concern that you have to take up. You're absolutely correct. Labor works very hard in this city. Many of our labor is underappreciated and underpaid. We, Michelle and I, are EMS workers. I think our EMS workers are harshly underpaid. And we have fought for higher wages forever. We don't ever really seem to move anywhere. But our positions as retirees, we are on fixed incomes. Our incomes don't rise like your wages do or your increases. A retiree, after so many years, after like the first 5 years, will get a cost of living adjustment called a COLA. That's between 1% and 3% of the consumer price index. This year was the highest that I've seen in a very long time, was 3% of $18,000. A couple $100s in today with an inflation rate of over 8% doesn't really get us that far. We have retirees that retired in 1979 that were cops and firefighters. Their top paid then was $15,000. Mr. Stromer, one of our retirees, is in his early 90s. His pension today is $26,000, and that's with his variable supplement. That man cannot afford to pay a starting $200 premium in order to keep choice of senior care. But what you have to remember too is when we retired with a promise of something that we would have. And in our summary plan books, the terminology literally stated something like this, that the benefits that you have in employment will continue in your retirement until your death. Now, if you take that away from me today, I don't have the means to be able to pay up to something that Mr. Mulgrew or Mr. Garrido or Ms. Middleton or Mr. Floyd think I should be able to pay as an option. I don't make a $100,000 pension. And I shouldn't be asked to do this for the sake of choice, because for me, for most of them, that's not a choice. So choice would be for them to have realistically looked at other things. One of the things that we have said, and this would affect Michelle sitting right next to me, is that the city has not done its due diligence. In the course of this situation, this entire mess, we have found that there were retirees that were deceased for over 5 years. Why? That's a fiduciary failure, that your agency had no one tell you that there were no claims going through these people's accounts for over 5 years. My water company calls me after a week to say I have a slow trickle going through my meter. We have identified, as Michelle, for example, has a situation where the city is has her spouse on a plan that he should not be on, charging her for it in taxation, not by premium. We have addressed this with OLR, we get nowhere. They don't even answer us back anymore. But because of these fiduciary failures, that should not be a burden to ask for a retiree. We shouldn't have to be here to fight for something that no other retiree at this point has had to fight back to give back, to say we're going to give you one free plan. And the other thing that Mr. Potter can show you is that in Medicare Advantage plans, the reason why other municipalities are doing this is because of a rule change in 2000 that allowed any municipality or a union with an EGWIP plan, an employer group waiver plan, to auto-enroll their persons into this Medicare Advantage. That was not like that before. And it was only because they were taking advantage of a subsidy can they auto-enroll you. We're labor. We never believed in privatization of a Medicare or health care. Yet I'm in the situation where I've got to worry about them arguing, not them, our former unions, upset because they want something that has a federal subsidy to it in order to fund their raises today. I shouldn't be in that position because that's treating me like cattle. That, never. In our time, we gave up raises. We gave up increases. We took 2 years of 0 zeros under Giuliani, and that was a whole nother DC 37 debacle. I don't want to be in a situation to say to you, well, I'm just going to go into that really horrible Medicare Advantage plan, because that's the only choice, and it helps the unions because they misused a fund, which that fund has run into difficult times financially in 03, 05, 11, 14. If we keep throwing good money after bad, when does it end? There's no oversight over that stabilization fund. We've been begging for someone to look at it. If there was a better way of being able to do this, we've given suggestions. No, I'm sorry for Ms. Levitt. Ms. Levitt did not say she turned over every rock, because we gave a bunch of rocks to Mr. Godner at our meeting. And his comment was, well, I know of some of them, but I don't know of the others. Well, before you try to take away from people who earned this, maybe you really should turn over all of those rocks, because there's other ways to be able to do this rather than take away people's health insurance under the guise of giving them choice.
Thank you for answering those questions. I do want to recognize that we've been joined by Councilmember Narcisse, and I want to turn it over to Councilmember Arreola for questions.
Thank you, Chair. And I want to thank you, Marianne, for the outreach and for your dedication and for your vast knowledge and for all the retirees that have been sitting here so patiently, because you really are the main event. You're really who we want to speak to and hear from. So what I'd like to first ask, and it's piggybacking on what Chair De La Rosa asked. So you're fighting very hard to convince this body not to change the administrative code. You're fully aware that that could force you into Medicare Advantage. However, by us not changing the code, I'm going to flip the question, what do you gain?
The ability to still be able to fight that. You heard Mr. Mulgrew on the TV say that you're going into Medicare Advantage whether you like it or not. Medicare Advantage plans have been here since 1996. And they're still offered today. 94% of retirees and employees like the PPO plan. For retirees, even though we've had the choice of HIP VIP or the Empire plan or any couple of the other Medicare Advantage plans, we do not choose those plans. You have an option today. Retirees have 14 options, employees have 11. You have choice, and there were reasons also for choice. You have regional coverage, like where, and this is another place where Ms. Levitt was mistaken. She said people are complaining in the senior care because they don't have access to their physicians or dropping out of the plan. That is in the GHI comprehensive benefit plan for under 65. And that is only because the city absolutely refuses to pay the regional coverage like in Florida or even in Puerto Rico. However, in the senior care plan, 96% of doctors in America take Medicare, and because Medicare is accepted, senior care has to be accepted. We don't have denials of our physicians taking our health care. It's only for those who are on GHI CBP. What do I get? I still get a plan where almost all my doctors take my plan. If they take Medicare, which 96% of them do, I have my GHI supplement, my GHI Medicare Medigap plan.
Okay, so we've heard from the administration, from the MLC, and from our union. So just to do it quickly, I'd like you just a quick, succinct, could be true or false. Is there a terrible funding problem with the Health Insurance Stabilization Fund?
There is a funding problem because it's been misused. Like I said, most recently, 2014 UFT contract.
Okay. Did the judge say that the city has to offer one plan, and did the judge take away choice?
Absolutely not. The judge said quite a few things. He said that the city has health insurance up to the full HIP HMO rate for every employee, retiree, and their dependent on a category basis, which is an individual and family. And he said this is not to say that you have to have a choice, and that was because he said that because that was not a question before him. But if the city does offer a choice and those prices are under the HIP HMO rate, then the city has to pay the cost of that. Okay. This was even a question asked before my attorney in the appellate court, and my attorney correctly said to the justice, sorry, Your Honor, that's not a question before you.
My final question, did the judge take away the union's collective bargaining rights?
Absolutely not. When they put that out, I contacted OCB, Office of Collective Bargaining, and I said, can you please tell me if any union lost any collective bargaining rights due to, I don't know, in any time in the last 12 months or because of my judge's decision? And they said, no. I posted that, and they seemed to quiet down until today.
I guess this is really my last question. Would you be willing to go back to the table with the unions to find different ways to find funding streams to narrow the gap that they're looking to narrow?
Well, heck, that's really funny because I'm retired, and they haven't wanted me at the table since I retired almost 20 years ago. But you know what? If they want to sit in the room and talk to me, I've been asking the mayor to talk to me, labor relations talking to me, OCB to talk to me. We've come up with ideas because you know what? Our retirees are attorneys, retired OLR, retired OCB. I mean, we ran this city.
Thank you so much, Councilmember.
Thank you. You deserve the proper health care, and we will fight for you. Thank you.
Thank you. Thank you. I do have a follow-up question about the misuse of the stabilization fund in your opinion. So are you saying that because teacher raises were taken out of the stabilization fund, that constitutes a misuse? Is that your opinion on the matter?
The Health Insurance Stabilization Fund was negotiated for one purpose. It was negotiated to offset, to be able to create two plans premium-free, offset the HIP and GHI rate. In the days when there were a lot of money in the fund, like in 2000, when they created PICA, which is another benefit that these people don't benefit from, it was allowed to be used to initiate new healthcare issues, not for raises, not for collective bargaining.
I understand that, but do you understand that when you say a misuse of funds, it sounds like someone went on vacation with the money? Like funding raises for teachers, excuse me, I'm not asking the room for opinions, I'm talking to Marianne. When money is used to give teachers raises, although that is not the proposed purpose of the fund, it's used for a city purpose.
That's not the purpose of this Health Insurance Stabilization Fund. It's called Health Insurance Stabilization.
So besides the use of teacher raises, are there any other issues that the committee should know about with the stabilization fund?
So there's a lot in the stabilization fund. I think some of that needs to come out. We talked about PICA coming back out, either going back into major medical or going back into the welfare funds. If you have to, maybe consider putting a small little premium on it. You're getting thousands of dollars worth of drugs for, basically nothing. you're putting too much in there. The burden on this fund cannot sustain what it was supposed to sustain. If you were to look at all the things in there, there's a Weight Watcher program in there, there's a Teladoc program in there. I don't understand why we're paying for Teladoc. The major medicals should be picking that up as well. That's covered under Medicare. As a Medicare retiree, we can use Teladoc through Medicare. Our doctors can see us virtually. Why are you paying for that? Some of all of these extra benefits, these added benefits, became an issue. So yes, I think we need to look at how the stabilization, what is in it, what can we take out of it, how we can refund those things. And we still have to remember the bottom line is the city is supposed to pay the full cost of health insurance up to the HIP HMO rate for every employee, retiree, and their dependent, and not try to skirt it by sticking it into other things and trying to get the unions to pay for it. The unions don't make money. It's funded by the city collective bargaining to put $35 million every year into that fund, as well as the offset of the HIP HMO rate and the GHI rate. However, with Emblem Health owning both HIP and GHI, how is it possible that that's even an honest entity of a differential of rate? Emblem will always know what the HIP rate is. They're owned by GHI will always know what the HIP rate is because they're owned by Emblem.
Got it. Thank you so much. Councilmember Bacha?
Hi. At the end of your testimony, you say, if what the unions and the city say happens, you can always intervene. Could you elaborate on what you meant by that and how that would look in your opinion?
They're asking you to do something to fix something that hasn't yet happened. Our position is that the Scheinman report is just a report, it's his opinion. You don't have to do something. If you take an action preemptively, and they're already telling you you're gonna go into Medicare Advantage anyway, either no matter which way you do it, but what they're requiring you to do is to be able to give them the ability to lower the benchmark of which they pay to me. And as Mr. Potter can tell you, according to federal subsidies change all the time. You allow them to change the benchmark for me. If the subsidy ever changes, while I appreciate what Ms. Levitt had said earlier, that they would pick up the premium, that wasn't in the contract. We were given a copy of the EOC when the alliance came out, which is the full contract with all the dirty details. So knowing that they would, what they did in the EOC, the details that were there, for example, as part of the addendum process, they had said for the inpatient hospitalization was a $300 copay, maximum $750. What should I do with it for 2021 and what should I do with it for 2022? Well, the city wrote back and said to Aetna, the Alliance, actually no, that was the Aetna case. Do this, rescind it for 21 just to facilitate transition into the Medicare Advantage plan, and then install it back in 2022. Which means you're gonna make your plan look better to me initially, so I go, and then you're gonna hit me with the imposition of copays and increased costs, later on. These plans are also subsidized by the federal government. In 2017, that subsidy dropped. And how we know that was because through the city records, HIP went back to the city and said, what's gonna happen now that the feds dropped the rate? You have to make up the premium. The city said no. Pass it to the retirees, the city said no. So what did HIP VIP do? They cut out the drug program that was in HIP VIP. They added copays where they didn't exist and doubled them where they all did. In the Alliance contract, in the EOC, that provision was in there. If the federal subsidy is ever reduced and the city doesn't make up for the difference, they reserve the right to cut the service.
Thank you for answering those questions. I'm going to move on to Councilmember Ressler, followed by Councilmember Brewer.
Thank you so much, Chair De La Rosa and Speaker Adams. Appreciate, again, you holding this hearing. So thank you for your all's testimony and for, really galvanizing seniors, and the organizing has been strong and impressive. I do want to go back to a line of questioning that Chair De La Rosa was asking about a moment ago. The mayor's office and the unions, the parties to this arbitration, and the arbitrator have all said that if we do not modify the code, they're going to force all retirees into Medicare Advantage, which I think is the worst outcome. To be clear, the worst outcome is that every retiree in the city of New York has no choice, no optionality, has to go on to Medicare Advantage. You're insistent that you're going to win in court. And I appreciate your optimism. You're not a lawyer, and neither am I. But your lawyers tell you one thing. Lawyers we've talked to have said the opposite. We'll see, right? That's what happens. We can all bet and play the game, play the odds. But there's people's lives that are at risk here, and this is really important. And so, should you go to court? Should this happen, as the mayor's team and the MLC and everybody are saying is going to? They're going to force everyone onto Medicare Advantage. You go to court, you sue, you lose. What next? You lose again. You appeal and you lose. You lose.
So I'm going to tell you that the City of New York and the MLC didn't want you to know this. And you heard Mr. Mulgrew say it today. Medicare Advantage is happening to you either way. Change the code, don't change the code, it's going to happen. The city and the MLC in 2020, when they put that RFP out to do this plan initially with the Alliance, they cut all choice then. When we were looking to, last year when this was happening, this rollout was happening, we had no choices. They told us that as current retirees, we can go towards Medicare Advantage or senior care. The only other option you would have is to keep the plan that you had, but you could no longer go into another plan. If you were in United Healthcare and I was in GHI, I couldn't go into United Healthcare. Now, for a future retiree, you had no choices. Your choice was Medicare Advantage
I appreciate
altogether.
your question, but you're not answering my question. You're explicitly not answering the question. And so we have to think about this in the real world with 2 feet on the ground. If you all lose in court and lose on appeal, what happens? And we need to think through what are the, because this is a game of chicken that you all are playing that is dangerous. It is dangerous.
And they're asking you to play chicken because we have a path to litigation as to our benefits not being diminished. We were promised a vested health benefit. We were not told that we would have to have one health plan, forced into one plan, forced into managed medical care. Because if that's the case, there's also another issue. You have the teachers, active teachers and retired teachers who are covered by the Moratorium Act. You take an active teacher and you don't diminish their health benefit equally as to the way it's diminished for a retiree, that becomes another litigation.
I do not want to see all retirees forced onto Medicare Advantage.
No, me neither.
And I appreciate that if we were to act now, we would weaken your hand in court, and that's why you're taking the position you have. But I think we all, should the council not act at this time, which I'm not expecting that we will, should the council not act at this time, we need to think through what are the implications of that and how do we protect optionality for retirees permanently. And I think that we need to start to wrestle with that in a much more serious way than it seems like we're at right now, because that is a very real possibility. And I want to make sure that every retiree in this room and every retiree across the city, and certainly in the 33rd Council District, is not forced onto Medicare Advantage. So thank you very much, Chair.
Thank you, Lincoln. Councilmember Brewer.
Thank you. I just want to go the other way, which is that if you win in court in the appeal, then what exactly are you getting? Because I do have full confidence, as you do in your attorneys, but you never know. But what would you be getting at the end of that procedure, according to you?
I'm sorry, could you re-ask that?
After litigation.
You at the end of litigation, if you win, as opposed to the opposite scenario that Councilmember Ressler was stating, that you go to court and you win on the appeal or any aspect of the court, what exactly will you be getting at the end of that effort? Obviously, one scenario is, as we heard earlier, everybody has to go to managed care because that's how you lose at every scenario. But if you win at every scenario, exactly what are you getting? Are you getting what you think you're going to get, which is the senior care, and then we, understandably, would have to find the $600 million, or there would have to be some discussion about that? I'm just trying to understand what you win, according to you, if you're successful in the courts.
That we would have the option to keep the senior care. You have 94% of your retirees currently on senior care, traditional Medicare, federal Medicare with your Medigap. We would like to keep that as our choice without this pay-up issue. Right. And because we have identified a lot of opportunities for savings, or also identified fiduciary failures, that we should be addressing those things before taking away a benefit from somebody else and privatizing it.
I understand what you want. So what you're stating is that if you win in the courts, you feel that you would be able to keep the senior care.
Absolutely, because it would not be diminishing our benefit. We would have that choice. You have people that live in other areas of the country who regionally would not be covered. You have Cigna in Arizona, for example, because GHI does not cover under 65s in that area alone either.
All right, thank you.
Thank you. Councilmember Narcisse.
Good afternoon. Thank you for being here. And I'm sorry, I apologize. I'm a little late because I was with the nurses NYSNA. I don't know if, yes, I don't know if this question was asked before. I heard you for the little short period of time that I've been here. What are you suggesting for us to do? If you have any suggestion, one line, what would you recommend now?
Well, I think the line would be is to protect our choices as they currently stand, as protected under Administrative Code 12-126, because the benchmark is equal across the board for each and every one of us. By you protecting the code, you give me choice.
Okay. With all this, have the union reached out to your group, because you're a great advocate? Have you been reached by anyone from the beginning? Because one of the things that I find, most retirees that call flooded my office with email, mail, and talk to me directly. It seems like there is no kind of like discussion between you and the union.
So we are retired. We don't have any legal connection to our unions. Some retirees in different agencies don't even have a retiree group. We would never have any reason to speak to our unions or to speak to OLR or anything ever. When this happened, we found out by accident because of a newspaper article of a union president that leaked it in the newspaper in spring of 21. When this thing started, of course I reached out to Henry. Henry didn't want to talk to me. I had to go to the International to get Henry to talk to me. Harry doesn't want to talk to me. At first he flirted on the phone with me when I called because he thought I had a pretty voice. But then when he realized who I was, he didn't want to talk to me at all and told me I had to talk to Alan Klinger.
All right, okay, excuse me. We need order so that we can move. There are over 200 people signed up to speak today. Please go on.
Then I was told to speak to Alan Klinger, the MLC's attorney, because he felt he was a party to the lawsuit. No, you weren't a party to a lawsuit. You took an amicus in the city's case for the side of the city. Now Harry won't talk to me. The only one that left was Mr. Mulgrew. Mr. Mulgrew doesn't return my phone calls, my emails, nothing. I had to corner him in Somos in order to get him to talk to me. And that was only while he was, I guess, in his shorts and T-shirts having coffee and had no clue he'd be talking to me at 8 in the morning.
Okay, we're not gonna assign accusations on the record at the City Council. Please answer factually.
Those are facts, ma'am, and I'm sorry, but he would not talk to me, and he still won't talk to me. He made a promise to both myself and Randy Weingarten that he would speak to me, and he hasn't done it.
You can say what the conversation was. You don't have to talk about what he was wearing, the same way they won't talk about what you were wearing.
I
just
apologize.
keep it to the, above board, please.
Thank you.
Yeah. I hope you understand why, because the person is not here to advocate for themselves or anything.
I would love to have a
So we're going to
debate.
leave it to specifically that you cannot be connected to them or
No,
they're not
ma'am.
answering.
Right.
All right. So do you understand our job? Is not, we are eventually, myself personally, getting close to retiring too soon. So therefore, we have an interest to do the right thing. And it is a difficult time, very challenging time. But at the same time, we have to do the right thing. And there is money involved that we don't have. We have to look for it. It's not easy. So we know we have to protect you. I heard that, but I'm not answering to that. It's difficult right now. We have to make difficult decisions. And for me personally and all our team, we understand what's at stake because the retiree is very important to us, important to me. So I thank you for the work you're doing. We're gonna continue looking, but you have a friend because, like I said, I'm very close. So therefore, it is our responsibility to understand and do the right thing. So thank you for your work.
Thank you, Councilmember. Thank you. We have Councilmember Dinowitz and then Majority Leader Powers. Okay, please We're not booing, we're not sighing, we're not making noise, we're listening to everyone. And so if we're here at 2 o'clock in the morning, we will listen to you, and we will not boo you, and we will not sigh. So we ask for the same respect for our members. Thank you very much.
Thank you.
Mr. Dinowitz, who, by the way, is a retired teacher or a former teacher.
Well, I hope one day to get to the age of
Former
retirement.
teacher, but there you go.
Yeah, former teacher, yes. So I think the point of the chair mentioning that is I'm in the same boat as a lot of you. Many of us up here are in the same boat as a lot of you. And we're trying to get clarity. The chair asked this question. Councilmember Ressler asked this question. Councilmember Brewer asked this question. And it's been really hard for me to get an answer. And this is, I guess, I'm going to try to ask it in a yes or no way, so it's as simple as possible. Intro 874, at the request of a mayor, was introduced. Let's pretend we do nothing or vote it down. If the administrative code stays as it is, do you keep senior care, in your opinion? And I'll just say, as you're consulting the attorney, I don't think there's much disagreement on the Medicare Advantage, the quality of it. You know, a lot of this is about the value, profits, things of that nature. I'm simply talking about, do you keep senior care if the administrative code does not change?
I think in the short answer is if you want to protect retiree choice, then pass a code that would protect our choices, rather than capitulating to something that's going to take away my choice, allow two leading unions and the city to reduce a benchmark for me. That's not giving us choice. I can't tell you what the city's going to do, what the mayor's going to do, but I think, honestly, if the mayor could have done this, he would have done it without you.
Respectfully, I think we do know what they're going to do because they told us very clearly what they want to do. My question is, you know, in your opinion, the best way to protect our retirees. And what we've been hearing is don't change the administrative code, but now I'm hearing, yeah, change it, but in a different way. And so we're trying really hard. I think everyone up here wants the best for our retirees. We are all future retirees, but it's been very hard to get a clear answer because what we've been hearing from retirees is don't change the administrative code, and that'll protect senior care. That's what we've been hearing. But now I'm hearing something different from you, and I'm looking forward to.
No,
I'm hearing
it's
something
not
different from you. It is because. And I'll end with this because I know time, but I just heard from you, change it to something different.
Well, that would be, you're looking for something alternative to what I'm saying to maintain it. Our position has always been the same. By this code has protected every employee retiring their dependent equally across the board for 55 years. We all had the same benchmark. See, but the difference is your plan today is costing $900 and more. Mine cost $191. I'm not bankrupting the city. I already told you that my plans have risen from 1997 until today about average of 5% a year, where the active workers plans have risen over 21. They're family plans. You're younger, you have kids, you have spouses. Most of us, we're on Medicare. Our plans are inherently less expensive. So if you don't like the choice, my telling you, leave the code the way it is because it's protected us equally across the board for this whole entire time without any issue, then I make a proposal, is make another bill then. We have a bill that we've drafted that would basically say you would not change or diminish a retiree's health benefits, a vested health benefit. Similar to like Article 5, Section 7 of the state constitution, this would protect a vested retiree health care. Retirees shouldn't have to come and do this and sit here all day and not eat and have to keep going to the bathroom and stand outside for hours in the cold to fight for something we already negotiated and to support. So I'm just going to say, I don't know how you would like me to explain this in any other way. I'm giving you two choices. Protect the code the way it is, and if you fear that something bad's going to happen, I've got a legal team behind me that will help me challenge that, because I think if the mayor could have done this without you, he would have. That decision came down from the appellate court in November. This was just trying to force you to do something that they don't want their hands on. They want to be able to reduce a benchmark, which MLC can sit in a room with the city and say, well, for people that live outside the city, we're going to give them that plan. The benchmark will be $10. Those Medicare retirees, their plan's going to be free, but we'll give them these other choices, but if they want them, they're going to have to pay up for them. For employees that are in the Uniform Coalition, we'll give them this plan. For the civilians, we'll give them that. We moved away from that, and we were in equality. Otherwise, in the start of all of healthcare in the late 40s and early 60s, you had uniform coalitions with one set of benefit and the civilians with the other. This gave everybody equality. That's what I'm asking you to preserve. The ability for me to have the same thing as you. My plans will never cost what yours do. Never. Because right now, with all the co-pays that they've saddled on me, my plan pays less than 20%. Yours pays a full 100%. Protect me, because right now they're selling off my value to privatize my health care, to put it in the hands of the federal government, which right now things are a disaster there with the star ratings dropping, with the subsidy reduces. Then what happened? Because in the bill that they've proposed to you, there are no protections. It allows 2 people within the union and the OLR to choose what my benchmark is and what plan they want to peg for me. Right now, I have that choice. You change that code, I lost that. That means the MLC and OLR choose my plan. And if I don't have the money to be able to pay up, I don't have a choice. This keeps my choice. And then your second alternative is pass a bill that we have drafted that says you don't reduce a retiree's health benefit, vested retiree health benefit, in the likeness of Article 5, Section 7 of the state constitution. That's what I could offer you. Unless you want me to bring my attorney up here and have him talk to you.
It's okay. Thank you.
Thank you so much.
Thank you
very much. Thank you, Chair.
Thank you. Majority Leader Powers.
Thank you. I think I'm last. I'll try to be brief, but thank you for your testimony. I want to come back up and get a chance to ask questions. And I think what Councilmember Ressler said sort of reflects what I was going to ask, but I want to ask a follow-up to it, which is that I think a lot of us have concerns about unilaterally moving anybody to one plan, and that's why you're here, and that's why we're having this hearing today. I think the question is what happens in court, and I understand and recognize that you're not changing admin code preserves your options to be able to fight this fight another day. I think the question, though, is that what happens if you guys are unsuccessful in court, which is there's a likelihood, not likelihood, there's a percentage chance. Whatever that percentage is, lawyers will disagree on or agree on. But there is a possibility of that. And at that moment, then we run into this question for our constituents about whether then even to change the admin code to offer that option back to them if they do not want Medicare Advantage. I think that's the crux of what the questions were being asked earlier is, so I guess my question is, if you are unsuccessful in court, is that a moment where you would support us to change something to give flexibility back to those who might have lost it because of the unsuccessful lawsuit?
Well, why don't we cross that bridge when it actually happens? Because in my opinion, we've been successful twice. And I think the only reason that they're trying to do this is because we've been successful twice. The judge affirmed in his decision, which I'm just trying to get to the right language of.
I just wanted, just because I have limited time, I think it's like the most important question, though, that we're facing here today is whether to amend this, and if so, when is the moment to intervene? Because I think what a lot of folks here are asking for is don't step in now and take something away from us. Let us be able to fight that in court. However, for a lot of us, we are concerned that a Medicare Advantage, as folks are saying, is not providing everything to people that they might want in terms of a health care plan. They still have the option. And I'm concerned about the ability for people to pay for that and other things like that. But I do think it is kind of like the central question is, if you guys are unsuccessful, this is the question that colleagues ask often, is that a moment where we would want to then go in post-litigation to amend and offer flexibility back versus doing it now? And I think it's important we have a kind of understanding of whether that's something you guys believe is a good idea or bad idea. And I think that does seem answerable now, even before we go to court.
I joke around, and I have a magic 8 ball. And I wish, I could pick lotto numbers for it, okay? But
me too.
I know, right? Yes, post if we were to lose, and I hate to even say that language, okay? We do have, there's plans, okay? And if we have to have you guys step in post, we know the city, no matter what, is going to strip to get their way, okay? Because they said it today. You don't do this, we're gonna take it away. You do that, then we're just gonna do that, okay? So we heard it, everybody heard it, we get that. But again, we have vested benefits. We worked for those benefits, and they're being sold off left and right, okay? You know, I'm just going to put this one piece in. When I got hurt in between contracts, okay? I was a lieutenant. I was 3 years without a contract. I was the first, and I was under DC 37, under EMS. I lost out of 3 years worth of retro pay to pay for raises for the actives. I lost out pay. That's a lot of money. Okay?
Yeah, traditionally, when you retired under an expired contract, they would give you your retro pay. It was during this period that they didn't. Her class was the first, her retiring class was the first time that didn't
Did I
happen.
pick it outside? Did I complain? No, I didn't. I just said, all right, whatever, it is what it is. That's what the city does to you. You know, have a nice day. All right, whatever. And now my benefits are being, benefited off.
It sets another precedent, too, because if you come back and change this now and reduce our benefits today, then by changing this code, allowing them to peg a lower benchmark to us, what do they come back for next time you're in some other fiscal crisis? Because given the pattern of the stabilization fund, which doesn't benefit us anyway, but you need to use our benefit to fund something, then Medicare B is on the table. Then our spousal health care is on the table. That's why you never took a benefit away from a retired person. And they're using the judge's decision to say you have to do this. The judge only said you had to have one free plan. The judge did not, absolutely did not say that. He wanted to say that in the top part of the decision of the dicta, which is how he got to his decision. He said that this wasn't to say that the city had to offer more than one plan, but if the city did, and the cost was under the benchmark, the city had to pay for it, period. He also disputed the fact of the city's argument that the city only had to offer one plan. The judge said, no, that's not the interpretation. And that also wasn't a question before him either. Because of the 92 agreement, they have to offer all of these other options. They have to be able to negotiate.
Thank you, Councilmember, and thank you for your responses. I just want to say, the Administrative Code 12-126 does not explicitly protect senior care. It protects the benchmark being at the HIP HMO rate.
Correct.
So if we don't pass this bill, we don't amend the code, nothing happens, what we're saying is that we would be subject to not having the option of senior care existing on the market for someone to buy or purchase or pay up to or even go into, opt into. So I have one additional question about that fact. When is your senior care contract's expiration date?
I have no idea. That would be a question for, actually, due to advice from counsel, because we are currently dealing with this issue right now in court, I can't answer that question.
Okay, thank you. But I will say that that is an important question for us as a committee to know, even if you don't want to answer it on the record, because that talks to the time frame as to when a contract that you are currently in and hoping to stay in is expiring or still active. And so thank you so much for taking the time, for the organizational efforts here, for taking the time to talk to us individually, calling our offices. You know, we appreciate the opportunity to ask you these questions. And as we heard leadership say here today many, many times, we're setting this table for a conversation where we hope to draw solutions. And your voices are certainly part of that solution, and we want you to understand that. So thank you so much for coming. We're gonna go into the next panel. I will say for the next 200 people that are going to be speaking today, we are going to adhere to the 2-minute clock, because if not, we will be here until next Christmas. And we also want to make sure that everyone has the opportunity to speak. Please come up as we call your names. Remember to identify yourself for the record. And if you're virtual, please listen in for us calling your name. Thank you so much, and we'll call the next panel, which is James Davis, Barbara Caress, Zhu Yin, Jen Gabri, and George Farinacci. Thank you. We are ready when you are. Please identify yourself for the record so that we can cross-check our list, and you may begin.
Hi, how do you do? My name is George Farinacci. I'm here today on behalf of the UFOA and our President James McCarthy and all of our 8,000 members. I want to especially thank Speaker Adams and the Chair of Labor, Carmen De La Rosa, for holding this important meeting. The Administrative Code 12126, as currently written, is not stopping this administration from implementing Medicare Advantage program. This bill is seeking to change the Administrative Code and allow a pay-for option of health care. The very same Administrative Code language that prohibits this pay-for option provides essential and vital protection to prevent further erosion of future health care benefits. We have serious concerns about language in the Administrative Code that may make the health care options different for classes identified in future agreements, and we are against the removal of the benchmark that facilitates the ability to measure the benefits of each health care program to ensure that the level of health care is maintained. Our members are fully aware of the significance of keeping the Administrative Code language intact, as demonstrated by the thousands of communications we have all been receiving. Changing health care has been the most critical erosion of benefits our members have experienced. I remind this council, this is your health care too. There is nothing to be gained by the council inserting themselves in this decision. Do not support a change to Administrative Code 12126. Thank you.
Thank you.
Good afternoon. Thank you, council members and Chair De La Rosa, for the opportunity to speak today. I'm James Davis. I'm the president of the Professional Staff Congress, a 30,000 member union, and I'm here to ask you to reject the proposed change to the city administrative code. There are practical concerns that my colleagues will raise, but most importantly, we urge you to seek alternatives. It's true healthcare costs are skyrocketing. It's true the MLC cannot maintain its commitments under the current stabilization fund. But it's not true that Medicare Advantage is the only path to achieving savings for the city, or that premiums must be charged to retirees who remain enrolled in senior care or for active employee health insurance. The PSC has opposed the change to the administrative code because it would open the door to lesser plans being negotiated for classes or subgroups of employees. Retiree access to traditional Medicare and senior care should continue and remain premium-free. The city can, of course, implement the Medicare Advantage program, but healthcare savings should be found elsewhere. We're told we are in a box, and now you're being placed in the box, but you don't have to accept those terms if you have the political will and the imagination to do otherwise. What kind of choice are we preserving if a retiree is charged $200 a month to keep senior care? For low-income retirees and their dependents, it's not a real choice. You heard if you fail to change the administrative code, retirees will be forced into Medicare Advantage, but many will be forced to enroll if the administrative code is changed. That's not legislating boldly, that's accepting a tiered system that regulates access by income and race. Another solution is possible. It could be accomplished in 3 phases. First, the city should provide short-term relief to the stabilization fund by allocating $500 million less per year to the Retiree Health Benefits Trust, contributing the equivalent to the stabilization fund. The RHBT has sufficient reserves for at least 2, if not 3 years, to be able to afford this. In that time, a stakeholders commission should be formed. It should be charged with identifying a path to control healthcare spending and should focus on hospital pricing, the main culprit. Lastly, a sustainable funding method for city health insurance should emerge from this process during that time frame, restructuring the stabilization fund and reaffirming the MLC's right to bargain with the city over public employee health insurance. Nothing is solved by forcing the MLC unions to deliver $600 million unless the stabilization fund is restructured. Tying future wage increases to this $600 million in savings is unfair and fiscally unnecessary. We talk about tearing off the Band-Aid to deal with healthcare savings, but the proposed change just applies a new Band-Aid while inflicting fresh wounds. So we urge you to take a bolder and more thoughtful approach than a change to the administrative code. Thank you.
Sorry. Hi, I'm Barbara Caress, and I teach healthcare policy at Baruch, and I am a proud member of the PSC. I want to talk about two things in my 2 minutes. One is to distinguish their traditional Medicare and Medicare Advantage are not the same, number one. And number two, despite what we've been told repeatedly today, there is no subsidy from the feds for Medicare Advantage. And I'm going to talk mostly about the second point because everybody has repeated what seems to me to be a basic untruth. Let me quickly deal with the first. The first is very simple. Medicare controls costs by setting prices. Almost every doctor, 97% of doctors and almost all the hospitals accept that price as payment in full, no balance billing. It's a pretty uncomplicated system. Medicare Advantage plans are commercial insurance, and they control costs by limiting access to doctors, hospitals, procedures, tests. They negotiate, as they do for non-Medicare beneficiaries, prices with networks. And so basically the price you pay for being in Medicare Advantage, and I'm going to talk about it in a second, is that you have more limited choices. For most of the people, most of the time, that limitation has no impact. But for a small number of people, it can be catastrophic. No access to the doctor or treatment that might save their life. And, you know, this morning they dismissed the 5% as inconsequential. That is every single retiree's nightmare, that they will be one of those 5% who the Medicare Advantage plan doesn't cover. Now let me talk to the second point. I have no time. Let me just say there is no secret sauce.
Can you
There
get
is
closer
no
to
subsidy.
the mic? Closer to the mic. You can go ahead. You can continue, but just closer to the mic.
Okay, thank you.
Quickly, yes.
There is no sub. Let me just quickly explain how the rates are established for Medicare Advantage. Medicare Advantage is paid by CMS, by the federal government, at precisely the same amount that it expects to spend for Medicare retirees in that community. No additional. They give that money to the Medicare Advantage companies, the insurance companies, and the insurance companies then decide how to divvy it up. And by and large, they divvy it up by spending between 60 and 70. 70 is really the top % of that money on medical care. They take some of the leftover money and they include extra services, which makes it more attractive to retirees. And for retirees like me, although I'm not retired, they cover the gaps that Medicare doesn't pay. The 20% on doctor bills, the $2,000 deductible for a hospital, that other people buy Medigap insurance for, and Medigap insurance costs at least $300 a month for a decent plan, that senior care covers. With Medicare Advantage, the city wouldn't have to pay for senior care. That's what the savings are. But the savings are at the cost of $600 million that's not being spent on the health care of the city's retirees. I'll be happy to answer any questions.
Thank you.
Hi, my name is Jen Gabori. I teach politics and gender studies at Hunter College, and I'm the PSC CUNY chapter chair there. It is such an honor for me to sit with my colleagues here, and especially with Professor Caress. I have learned I feel like all of us have been in a crash course on health policy in the last year with her, and I have learned so much from her. And if you feel like you have questions in the next couple weeks, I urge you to call her up on the phone and she'll talk to you. I want to address a couple of the things that I've heard today. I find it very hard to feel like we are in an open and transparent sort of conversation when union contracts are being held hostage. That we can have a conversation about sort of what is happening when that is one of the dynamics here. I also want to say around the question of sort of playing chicken, and I take this as I agree with Councilmember Ressler and Powers that I think this is at the heart of part of what you have to struggle with. My department assistant has worked for CUNY for 42 years. She is a DC 37 employee. She makes under $60,000. Her spouse is in about the same position in another city job. She has health concerns. She probably has long COVID. She is struggling to stay at work right now. She's going to retire soon. She's an African-American woman. She cannot afford to pay $200 a month. I have advanced degrees. I am in the PSC CUNY. I could scrape together the money if I needed to stay in traditional real Medicare. If you want to, I want you to preserve the option to fight for my coworker. I don't want a racist two-tier system that you have signed off on. And I would rather be put in Medicare Advantage in a privatized system with her and then fight together than have you do this. I want you to preserve the option to keep fighting. I want to focus on costs. I want to drive the costs down. The idea that Councilmember Menon's legislation on transparency is only the beginning of where we need to be. I do not take anything seriously from the MLC or from the testimony this morning about real cost measures. And I hope you take that seriously too. And I hope we can keep fighting together. Thank you.
Thank you. I want to thank both the UFOA and the PSC for not only coming today and being present, but for being active participants in this conversation and actually advising us on our questions and concerns. I only have one question, and it's for Ms. Caress on the federal subsidy situation. Can you explain that a little further?
Absolutely, and I'm sorry, I apologize for being so rushed. So let me start from the top and just explain how much money comes in and how it's spent. So on average, Medicare spends about $1,200 a month for beneficiaries who live in New York City. And of that, 96% goes to pay for medical care and 4% is Medicare's administrative costs. It gives that it gives the equivalent of that $1,200 a month, and there's some bells and whistles, but that gives the equivalent of that $1,200 a month to an insurance company, let's call it Aetna, and it says to Aetna, you take this $1,200 a month for all these people that you're covering, and you give them the equivalent of what Medicare provides. We don't tell you what to pay the providers. We just want you to fulfill the obligation to provide them access to medical care. And the insurance companies over the last 40 years have developed techniques for limiting their costs by creating networks, by having prior approval, by having post-claims denial. Those techniques, they developed in the commercial insurance market and applied it to the Medicare market. The problem with taking the procedures that work so well or not so well in the commercial insurance market and apply it to the Medicare market is that the needs of people 65 and older for medical care are typically greater than the needs of the people under 65. So if you're going to only take 60% of the premium, and that's pretty typical, and use it to pay for medical care, what you're going to be doing is shorting people. And it probably is not, it's probably not 90% of the people are going to get what they need. It's the people who need very expensive, unique services that get shorted in that process. And so 60% goes to medical care, or let's say 65% goes to medical care. Another 10% is used to cover the gaps, Medicare's gaps. Medicare's the 20% co-insurance for doctors, the $2,000 deductible for hospitals. So that's the second part of the piece, so there's no need for a Medigap plan. And the third piece is buying ancillary services, dental, vision, hearing, which make it very attractive to people with limited income, makes Medicare Advantage very attractive to people with limited income because they don't have any other source of payment. And let's say that's another 5%. Their administrative expenses are probably around 10, 12%. My guess is commercial insurance typically is 10 or 12%, and then there's 3 or 4%, which is profit. The profit number, just to not harangue you, but the reason why the profit number is so gigantic, for example, in the case of Humana, which is the second largest Medicare Advantage provider, they have about $3 billion in annual profits, and Medicare Advantage, which accounts for 40% of their participants, accounts for $2 of that $3 billion. Because if the profit is 5% of the cost of senior health care is much more money than 5% of the cost of a working person's health care, right? So Medicare Advantage is, to quote Dr. Don Berwick, who is the previous commissioner of CMS, it's a money machine. It produces enormous sums of money, which, from my perspective, ought to be returned back to the taxpayers and the beneficiaries, not retained by the insurance companies, but that's a whole other set of problems. So that's, but just to understand, there is no subsidy, it's they spend it differently.
Thank you. Thank you so much. And again, I want to thank this panel. We have one question from Majority Whip Brooks Powers. Oh, and I want to recognize Councilmember Riley, who's joined us.
Thank you, Chair. So I just wanted to revisit just listening to some of the testimony throughout the day today, and still looking to get a little bit more guidance or thoughts around next steps should the council not move. What I heard, I think it was the panel before this one or two before this, was that you all have a lawyer that will be able to preserve the option to go back to court. I'm curious in terms of what that means in terms of the actual coverage for the retirees, because I just will say I'm not comfortable with retirees not having choice. And that's what we're all, I think, on the same page for and fighting for. And so I'm not clear on how we preserve that, because my understanding is that if the council does not act and the city moves forward with signing this contract, it's a 5-year contract that's locking in no choice. So I just want to understand the likelihood of, one, getting a stay, because I know you all got a stay before and then it was lifted. I want to know, like, what are some of the other steps that can take place that are in the toolbox and that we can be helpful in, quite honestly, too, because I represent a district in Southeast Queens where we're, made up mostly of civil servants and especially retirees. So this is something that I'm really concerned about. And I'm not looking for, obviously, the easiest way out of this. I'm looking for a realistic way out of this to make sure that our retirees have choice. And I have not really heard that today.
Councilmember, thank you for the question, and I want to respond to it in two parts. One, just to be clear, that our union, the PSC at CUNY, is not a party to the litigation, and our solution is not primarily based on rolling the dice of what happens with the outcome of litigation. What we're seeking, right, is to try to bring together the smartest, best people to figure out this problem and take the gun away from their heads, and that includes all of you. It would also, hopefully, include a number of other stakeholders, whether they come from, whether it's physicians, whether it's health policy experts, MLC, and other union leaders. But in order to clear that space, right, in order to take the gun off of everybody's head, we do have to find a short-term way out from under the pressure that the MLC Stabilization Fund is under, because it's hemorrhaging funds. And it's structurally now situated so that it will never really be stable, as the name implies. So our proposal is less to litigate through this, but to try to legislate out of it. But to get to that place, to be able to legislate forward, it does require not accepting the basic premise that the city is broke and is only going to get broker. And it's very clear that there might be a recession. We've seen the projections both from OMB, but also the IBO projections, which are not necessarily that the city is about to fall off a fiscal cliff. But we believe that there is enough funding in the Retiree Health Benefits Trust to withhold the replenishment of that trust for at least 2, if not 3 years, redirect that to the stabilization fund. It's not raiding the Retiree Health Benefits Trust because you can't do that, but to withhold $500 million a year, not a small amount. But again, we're talking about a very high stakes exercise here. To free up some time for the stakeholders, real stakeholders, to come together, including elected retirees at the table, including hospitals, even insurance companies, if you see fit.
Can I just interject?
To hammer out a long-term sustainable solution.
Just for point of clarification, and I thank you for even sharing that perspective, right? Because that's giving another option. But in those 2 to 3 years of moving that fund, what would that do if the city has signed the contract already? Like if the city signs a contract that says everyone gets Medicare Advantage, you know, how are you looking on the council to like legislate to say we need to look and move that? I just want clarity on that.
So my colleagues may want to respond to this, and so I'll be brief. But my understanding of the judge's ruling is that the city has to offer at least one premium-free benchmark plan. But what I'm still not clear about is why the city couldn't continue to offer both a Medicare Advantage plan, premium-free. It sounds pretty amazing from all the descriptions, and I believe my colleagues who have been negotiating this on the MLC have been doing their absolute best, as they said, and I believe that they're sincere about it, making sure that Medicare Advantage plan is fantastic, and it's not the Joe Namath plan you see on late night TV. Okay, if it's that terrific, people are going to flock to it. Let's continue to offer senior care as the supplemental plan, not charge for it. The city will continue to realize savings, even though it will have to forego that $191 monthly premium. And I don't believe, and someone will correct me if I'm wrong, I don't believe that anything in Judge Frank's decision prohibits the city from doing that. I think it's a political issue, not a legal or financial issue.
Okay, thank you so much, Councilmember Hudson.
Thank you. I wasn't expecting to go so soon. The line has been so long, but thank you, Chair. So one question, or I guess my first question is, who have you had conversations with regarding your specific proposals? And apologies, I just came back after a long absence, so if you've already answered this.
Thanks for the question, Councilmember Hudson. Thankfully, you've been receptive. Many of you on the council have spoken with us and shared your questions and concerns about the proposal. We've also contacted the comptroller's office. We've contacted our colleagues in the Municipal Labor Committee leadership. I would say the conversations are ongoing. I think that the hurdle, the difficult hurdle to get over, is one that's already been expressed here, which is we have to find a way to save $600 million, right? And I guess the difficult or the challenging thing about our proposal is to say we can find that somewhere else in the city, in the reserves, while we figure out a long-term sustainable solution.
So have those conversations been productive? Would you describe them as
Absolutely.
such? Okay.
Absolutely. From our point of view, we began thinking down this road because what we were hearing was you either have to go along with this or you have to say no and see you in court. And we said there's got to be another way out. There's a lot of principled, creative, smart people in this room and elsewhere. We believe there's another way out.
And I don't necessarily disagree with you. But I'm also wondering who would have to make the decision to take this approach. Of all these folks, you've talked to the comptroller, MLC leadership, council members. Who's the entity that needs to make the decision?
Do you want to answer?
You.
Me alone, or me and my colleagues?
Let me say that with more than one word. You guys can convene a stakeholders commission. I believe it is within the power of the council to do so. You can stipulate categories or actual members. You can hand it its charge. You can also you can advocate for solving the problem temporarily by not replenishing the retiree reserves. You have a lot of power here, particularly, and I think the reason why we turn to you for this is that you guys seem to be the most interested in struggling with the problem, in figuring out solutions. I listened to the testimony this morning, and what I was struck by was that nobody was offering anything other than we need to have this $600 million to replenish the stabilization fund, and yes, the problems go on, or the false, what I consider the false promise of their RFP for a new vendor for the comprehensive benefit plan. They're planning to save $1.8 billion. Let me say, I know a lot about health insurance. It is not possible to save 10% without profoundly restructuring the way you have your relationships with providers, and that's not in the RFP.
Okay, thank you. And just in the interest of time, because I believe my time is up, but the chair has been kind enough to let me ask one very quick follow-up question, which is, to your knowledge or in your experience, would you say that all retirees have the same information before them? So I know, like, there's the retirees, there's the organization of the retirees, there's PSC CUNY and your retirees, you know, and other factions. And so I'm just trying to get a better understanding of, are the solutions or the alternatives that you all are proposing, have they been presented to, or are other retirees outside of PSC CUNY, do you think, are they familiar with those alternatives? And that's the end of my questions. Thank you.
By and large, not. But we did have an op-ed in the Daily News today where we actually spoke to that issue.
Yeah, and I saw that, and it was good. But I guess I'm just trying to get a better sense of who knows and has access to this information.
Councilmember, I mean, we've been trying to circulate our proposal as widely as we can. Look, when it comes to being a member union of the MLC is a union body, and we don't speak for the MLC. And so the MLC will circulate as the MLC sees fit, and we try to work with them, and we've been very collaborative in working with the MLC leadership. And nothing that I've done or mean to imply today is challenge their intentions or sincerity. I think they're seeking to solve real problems. We're seeking to solve them in a slightly different way, and we try to maintain that dialogue.
Thank you. Thank you, Councilmember. I just want to clarify one thing. So the Reserve Trust, are you saying that the City Council has oversight over that trust? Who has jurisdiction over that trust? The Comptroller's Office? And would moving money around or repressing money from one side to put in the other, that would be subject to budget negotiations or to some negotiations with the administration, correct?
Correct. And just to say, there's lots and lots of precedent for it. In fact, this trust was created by the Bloomberg administration precisely for that purpose, to stash money year to year because they didn't have other reserve funds. And during the course of the Bloomberg administration, they created it in 2006. They put $1 billion in 2006, $1 billion in 2007. Then the crisis 2008 hit. They started pulling money out. By 2012, there was no money left in the retiree reserve. But it was precisely Bloomberg used it for the purpose that he intended it for. De Blasio did it slightly less, but also in the same way. So there's precedent.
I know the MLC is not here and you can't speak for them, but if that were to occur, do you think that the administration would see that as the MLC meeting their obligation? Or would they still say, thank you for the money, but you haven't met your obligation to the debt that you owe the city?
Yeah, I mean, I'm not in a position to answer that question. I think that the letter from OLR in last fall, I believe it was, is in my view kind of ambiguous about whether the MLC met its obligations for the 2019 to 2021 agreement. Others disagree with me and believe it's quite clear that the MLC is still on the hook for $700 million a year.
Thank you so much, and thank you so much to this panel for answering all our questions. I want to recognize that Councilmember Holden has joined us virtually and call up the next panel. Ellen Gentivizio. Oh, wait, sorry, I skipped, I got excited. Alice Wong, Stuart Eber, and Darrell Sims from the Managerial Employees Association. I want to remind folks who are testifying that you'll be limited to 2 minutes. We're going to try to be a little stricter about that, so if you could summarize your statements for the committee. Thank you.
Thank you, Chair. Also want to greet my City Councilman, Mr. Dinowitz. It's good to see you. My name is Stuart Eber. I am the chairperson of the Council of Municipal Retiree Organizations, COMRO, and president emeritus of the New York City Managerial Employees Association. I became a caseworker in HRA in 1970. By the time I retired in 2004, I had been appointed as a deputy commissioner for about 10 years. During my career, I worked closely with the Office of Labor Relations and the Office of Management and Budget. I understand the need to protect the taxpayers as well as the employees and residents of our great city. The administration has created a false dichotomy. They are forcing you to choose between preserving Medicare as our primary medical coverage with the city paying for our supplemental coverage, or imposing premiums on all members of the city health plan. The attempt to rush you to vote on the amendment to Admin Code 12-126 is just one of their tactics to force us into Medicare Advantage. Your committee has received thousands of emails from concerned retirees documenting the deficiencies in the for-profit private Medicare Advantage plans. In particular, the required authorizations for dozens of procedures and tests has proven to prevent patients from receiving necessary care. The refusal of many doctors and hospitals to accept Medicare Advantage plans, and the billions of dollars the federal government is trying to recoup from fraudulent claims demonstrates why most people do not want to lose Medicare and be forced onto Medicare Advantage. What should be done? I urge that you hit the pause button, table the motion, and form a blue ribbon panel the New York City Organization of Public Services Retirees suggested. The panel would be chaired by a former city official acceptable to all parties and include representatives of the major retiree organizations, the Independent Budget Office, the MLC, the Controller's Office, the Public Advocate's Office, the administration, and the City Council. Their charge would be to find alternate means of saving $600 million or more a year in healthcare costs without imposing premiums or eliminating Medicare.
Thank you.
Thank you and stay well.
Thank you so much.
Good afternoon, Madam Chair De La Rosa, committee members and attendees. I am Darrell Sims. I'm Is there a timeout? All right. I'm Darrell Sims. I'm president of New York City Managerial Employees Association, and with me is Alice Wong, the executive director of the MEA. We would like to thank the committee for providing us with the opportunity to testify in behalf of the 16,000 New York City managerial and confidential employees and MEA members. After 39-year tenure working with New York City Department of Housing Preservation and Development, I'm an architect. I retired in January 1st of 2020 and elected to MEA January 1st of 2022. Based on my knowledge and concerns expressed to me from MEA Executive Board members, especially our retiree chapter, the following is MEA's position. The New York City Managerial and Employees Association objects to the proposed amendment to the Administrative Code, enabling the city to impose Medicare Advantage as the only premium-free retiree health care plan. The current Medicare/senior care plan will then cost at least $191 a month per person or be eliminated. Amending Section 12-126 Administrative Code will seriously undermine and compromise the health care protections for all municipal employees, retirees, and their dependents, insurees. It will allow the city to negotiate premium rates for everyone and placing insurees into different economic class based on financial ability to pay. It will allow for coverage and benefit reductions and eliminate protections and equal treatment that currently insurees have at this time. We strongly oppose administration and the Municipal Labor Committee's planned reduction in health insurance coverage and benefits through the privatization of Medicare for retirees. The city seeks to weaken the protections guaranteed for all municipal employees and retirees and their dependents in the Administrative Code. There are alternatives the administration could use to purchase the power to challenge the hospitals to reduce exorbitant charges, address the skyrocketing cost of prescription drugs, and audit insurance providers on a regular basis. I would now relinquish to Ms. Wong for our closing statement.
Thank you so much.
It is devised that creative, knowledgeable, and competent-thinking individuals representing all concerned parties, including municipal retirees, form a working committee to develop an appropriate and sustainable long-term solution to address the high cost of healthcare. Proposing the amendment section of 12-126 of the Administrative Code is an expression of a quick fix, get stuff done attitude for resolving the high cost of healthcare at the expense and detriment of municipal workers, municipal retirees, and their dependents. Healthcare is one of the most sacred and indispensable necessities required to sustain our lives. Therefore, the quality of healthcare insurance and the performance of the insurer are of the utmost importance. Section 12-126 affects the lives of all municipal workers, municipal retirees, and their dependents. Municipal workers should not be sold off like livestock for a for-profit insurance entity with an inferior medical advantage plan in order for the city to relieve itself from its legal and financial obligations. Based on our many decades of dedicated service to New York City and its residents, we have earned and deserve much better treatment and respect. The healthcare cost burden should not be resolved by diminishing current workers, retirees, and their dependent codified insurance coverage and benefits. Accordingly, the MEA requests of you to please do not vote in favor of amending Section 12-126 of the Administrative Code of the City of New York. Thank you.
Thank you so much. Thank you for coming and for testifying before us today. Thank you. The next panel will be Ellen Gentilvizio, Barbara Waldman, Carmen Alvarez, John Soldini, and Nina Tribble. Please, we need order and respect for everyone as they come up, please. We don't need a gallery of comments. You may begin when you're ready and identify yourself for the record. Ms. Gentilvizio.
Oh, hi. My name's Ellen Gentilviso. I'm a recently retired elementary school teacher after 28 years of service, including having taught during the height of the pandemic. I'm also a recently diagnosed breast cancer patient. I'm speaking today asking you to vote to amend the code 12-126 so I may continue my treatment with my current Medicare senior care insurance that is accepted by my oncology team. Having a cancer diagnosis is devastating, but the threat of losing access to the trusted doctors treating you due to elimination of choice of insurance coverage is even more stressful. I was diagnosed at the end of July, and after months of tests, second opinion, biopsies, and finding the just right doctors that accepted my insurance, I had my surgery at the end of November, and now I will undergo radiation. My treatment team at NYU Perlmutter Cancer Center has given me the confidence in overcoming this life-threatening disease. Not only the physical disease, but uplifting my mental state of mind that's essential for well-being, healing, and overcoming cancer. When someone has an illness, we all say best wishes for a quick recovery. So sorry to hear it. Well, you have the power to do something now to help. So I ask you to amend Code 12-126 that's necessary to preserve the past practice of offering a variety of health plan choices for New York City retirees. Thank you.
Go ahead.
Hello, my name is Barbara Waldman. I'm 76 years old. I taught mathematics for 35 years in New York City schools, including at Erasmus High School in Brooklyn and Tottenville High School on Staten Island. I retired in 2003. My dad was a New York City firefighter, and my mother, after raising 8 children, returned to school to get her degree in teaching. My eldest son is also presently a New York City public school teacher. So you can see that our family has been committed generationally to educating our kids in New York City. Over the years, I have had a number of medical problems, including a ruptured appendix and 2 collapsed lungs. After 3 corrective knee surgeries, I had to have 2 complete knee replacements, followed by 2 hip replacements, and I'm now scheduled to have shoulder replacement surgery this year. It should be no surprise that my grandkids call me the Bionic Grammy. Last year, I was taken to ambulance to the emergency room 3 times in 11 days. Without a long-standing relationship with my heroic surgeon, I couldn't have been put on an expedited schedule to undergo all of the tests and scans that I needed to go have complete complex revision surgery. I'm walking proof today that long-term relationships with physicians are critical to successful medical care at this stage in our lives. In addition to all that, I have also been treated for 3 forms of skin cancer, one of which is quite rare and has no treatment protocol except excision of the offending cells. I must have regular PET scans to ensure that the cancer does not rear its ugly head to somewhere else in my body. It's therefore so important that I am able to receive prompt medical care from doctors who've been following my medical history and have successfully treated me for all of these years. I hope you can understand why having choice is so important to me. I need to continue accessing the physicians who have basically saved my life up until this point. Please vote for the change in the administrative code so we can maintain to have choice in our medical plans. I'd like to live long enough to see my grandkids grow up.
Thank you.
First, I would like to thank
Chair De La Rosa, and Speaker Adams, and all of your colleagues, and all of the voices that I heard today, all very informative and helpful. My name is Carmen Alvarez. I taught special education for more than a decade in New York City public schools. I later served as Vice President for Special Education for the United Federation of Teachers for 28 years. I retired in 2018. My story is a family story. My husband, a Korean War veteran, was an art teacher at Russell Sage Middle School in Queens. He retired in 2000. He developed an acoustic neuroma, a non-cancerous tumor in the nervous system. He needed several surgeries which were covered by our health plans. He then survived 2 bouts of cancer. Nearly 5 years ago, he was diagnosed with a cancerous tumor on his forearm and underwent 8 weeks of radiation therapy at Memorial Sloan Kettering Cancer Center. He has gotten through all of this because he had the same doctors all these years. They know his history. They don't have to ask me the same questions over and over again. We can't go searching for new doctors and ask to create a whole range of new medical files when our current doctors, hospitals, caregivers, and our family members know his history. We need a choice of plans. Our union has always worked to make sure retirees have choice of plans because, as one of my many colleagues have said, one size does not fit all. Right now, we have a choice of quality plans, some free, some requiring a monthly fee. Healthcare may be complicated, but what we're asking for you is to vote yes. It's not complicated.
Thank you.
I just need to say 2 things. Your questions were laser focused on everybody. What would happen if you voted no? If you voted no, my health plan is gone. What am I going to do? Where I'm going to go? If the court cases and the appeals and all that takes time and it's going to rush people to do things in a rushed manner. I would rather you vote yes for the amendment so we could take the time to have all those questions you asked all of us to get answered so we can move, you can make the right decisions after my plan has not been removed. Thank you.
Thank you so much. Please go ahead.
Yes. First, I want to thank you, and I want to thank the speaker, and I want to thank all of you for making these discussions possible. I think it's very important. My name is John Saldini. I'm a retired teacher, as is my wife. I retired in 2002 after teaching social studies for 41 years in the New York City public schools, the last 27 years at Tottenville High School in Staten Island. I also served as the district representative for the UFT on Staten Island for 10 years, and I was the vice president of high schools for the UFT for 15 years. My wife and I now live in Florida part of the year. Living there has shown us the importance of having choice of health plans. 5 years ago, while we were in Florida, one evening my wife suddenly developed abdominal pains. Her city health plan required her to go to the emergency room for treatment because Florida was out of the plan's network. What we thought would be a minor treatment turned out to be a life-threatening emergency. The ER sent her immediately to a local hospital where they removed her appendix and part of her small and large intestines, which were badly infected. She spent over 2 days in intensive care. In an earlier incident, 11 years ago, my wife developed macular degeneration in one eye. Gradually, the condition spread to both eyes and required more frequent injections. She therefore had to find a plan that covered injections in Florida. We also had to find an eye clinic that would accept that plan. She needed a different health plan than I did. One household, 2 health plans. If we had only one plan, possibly her life, certainly her sight would have been over. We are asking you, choice is not a luxury. For many retirees, it could be a matter of life or death. We are asking you to vote yes on the administrative code change so that we can maintain choice. In shopping for clothes, we know that one size does not fit all.
Thank you.
I just finished. In shopping for health plans, we know that as well. One health plan, no matter how good, cannot cover all our needs of retired, cannot cover all the needs of retired city employees and their family members. Choice is a necessity. Please vote. This is the best way to guarantee choice.
Thank you so much.
Good afternoon. My name is Nina Tribble. I'm a retired physical education and health teacher. I taught in New York City's public schools for 32 years, but most of my time was spent at Junior High School 190. We had 7 through 9. In District 28, Queens. This year, February 1st, I'll be retired 9 years. I'm fairly new to Medicare. Last year, 2022, was my first full year in my new health care program, affectionately called Senior Care. I had to learn a lot about how my health care works since becoming Medicare eligible. One thing I wasn't too concerned about was whether or not I liked the plan the MLC was negotiating for us, because I knew I can opt out and choose for others. Now I'm very concerned. I want that choice. Currently, with the new ruling, it's not there. I will not have it unless the changes are made in the administrative code. It shouldn't have come down to this. We've always had choices. And 2 people have said it. I'm just going to say it for the 3rd time. One-size-fits-all plan, regardless of what it's called, using buzzwords like Medicare Advantage or something else, will be detrimental because there will not be any choices to factor in for me as well as other city employees. I'm single. I do not have a significant other, which would make it possible for me to go into their plan, providing they're not a New York City employee. I will be stuck in a corner with the most important years of my life ahead of me. Seniors, as they age, reach new heights in medical care. Rising prices of medications, doctors, hospitals, the cost of living, and other variants make it more challenging as we're navigating our fixed pensions and Social Security. Please amend the administrative code. Don't stack the cards against us seniors at this pivotal time in our lives. Let me choose. Let us choose. Thank you.
Thank you so much for testifying today. We thank you for your testimony. We're going to call up the next panel. Thank you for coming. We have Sue Ellen Dottle, Lisa Young Rubin, Kyle Simmons, and Mark Levietes. If you could please transition as quickly as possible so that we can begin. And identify yourself so we can identify who's not on the panel. Thank you.
May I begin?
You may begin when you're ready.
I'm ready. My name is Sue Ellen Dardell. I'm a lifelong New York City resident, and I live in council member Eric Dinowitz's district. I've been an attorney in city government for more than 43 years. I've drafted many bills, and I've appeared before the council many times in this room. I've devoted my professional life to serving the city. I ask that you defer any action on this bill. I know today's only a hearing, you won't be voting, but if there is a vote, vote no. Let the mayor try to put retirees into an Aetna disadvantage plan. He can't do that legally, and that's why he's coming to you as the council to give him cover. If he does it without changing the law, we retirees will sue and we will win, as we've won before, as you've heard. If we don't win, the council can always pass a law to actually protect retirees, which this bill does not do. You've heard both the OMB and the MLC say that this amendment is necessary to enable the unions to bargain for choice, but that's not true. They can bargain right now. They should do that. As you know, the Section 12-126 has been around for 50 years. It does protect choice. It protects you, employees. It protects retirees. And if you're fooled by the mayor and the MLC's argument that you have to change the law in order to save our choice, you're just completely mistaken. If you really want to give a choice, legislate protection that actually gives choice, but leave the code alone for now. Charging a premium does not give choice. You've heard a lot of retirees would be hurt by this. I know that you're concerned about pressure from the mayor, from the unions, but I urge you to do the right thing for yourself, for your staff, for all city employees, and for vulnerable retirees.
Thank you.
Thank you.
Thank you so much.
And please, I submitted written testimony, and it's much longer, and it has a lot of detail that I think would be useful for you. Thank you.
Thank you. Your testimony has been received.
Hello. Oh, good afternoon, Madam Chair and fellow council members. My name is Kyle Simmons. I'm a 21-year president of Local 924, and I'm affiliated with District Council 37. You're going to hear a lot of testimony today about this administrative code 12-126. Each one of you council members are retirees in training. One day you may need this benefit. Will it actually be available when you or your loved ones need it the most? You may know someone or have family members that are currently retired or will retire one day that need a healthcare system they can count on that will not bankrupt them. This administrative code was put in place for a very good reason, to keep everyone honest on both sides of the table, so that those that made certain wage sacrifices in the past to have a future retirement benefits, which include real health care. If you make changes in this code, you will remove the protection for the retired employees of the City of New York because they don't have a seat at the table. This code is their seat at the table. By creating the code, by changing the code, it will end up looking like the New York City Affordable Housing Program, yet nothing is affordable. That's why we have a large homeless crisis that continues to grow. We are all here today because something that was unprecedented was done before by unions, removing money out of the healthcare fund to pay for salary raises, which Local 924 was one of 2 unions that voted no. These same unions that orchestrated this usage of healthcare funds for items that had nothing to do with healthcare are now vilifying everyone that is opposed to this code change, including city council representatives that don't agree with the code change. This code change is another quick fix Band-Aid attempted so the city can come to the table and negotiate more pay raises. Please don't change the code because it will not solve the healthcare crisis. It will just put the retirees that already have very little economic resources into healthcare insecurities. And do we really want to hurt our aging population? I want to thank the City Council for allowing me to speak and taking my testimony into consideration.
Thank you so much.
Good afternoon, Madam Speaker, Madam Deputy Speaker, Madam Chair, distinguished members of the committee, including my council member, Eric Bottcher, and I also like to acknowledge my former Manhattan Borough President, Gail Brewer, where I was a constituent as well. My name is Lisa Young-Rubin. I'm a retiree from New York City Council, and I reside in Manhattan. I submit my testimony in opposition to the above referred legislation. The bill calls for amending of the health insurance that is now available to the above referenced groups of employees and retirees. However, this bill would harm the members of these groups by impeding their access to necessary health care services. It could end up costing the city and state and federal governments more money. This is so because consumers facing barriers to using their insurance for their health care would be more likely to use costlier emergency room and or Medicaid financed care. I would like to note that in addition to these increased risks and costs, this issue is personal to me. Just this afternoon, I had to go for a pre-surgical medical appointment after my physician said she will have to conduct various tests and procedures, including a biopsy under general anesthesia at the hospital to confirm or rule out a diagnosis. And she explained to me that the sooner these tests and procedures could occur, the lesser risk I would be for harm, including death. While I'm grateful that I currently have the health insurance needed to see my doctor and follow up on her advice on a timely basis, I fear the risks I would face to my health and my life if this insurance were to be gutted by the City Council, acting without any apparent care, quote, at the request of the mayor. As it emerged during a similar proposal by the current mayor and his predecessor, managed care, including Medicare Advantage programs, could result in a healthcare consumer losing access to his, her, or their healthcare providers should the providers decline to join the MAP network. Additionally, the consumer could face health risks, including risks to the consumer's life, due to delays in getting pre-authorization for medical visits, tests, and medical procedures. Thank you. I have additional information. Thank you very much.
Thank you so much, and we've received your copy. Thank you. The next panel is a virtual panel. Leonard Rodenberg. We're going to call the next four names. Just be attentive to when your name is called to unmute. The first person is Leonard Rodenberg.
Thank you very much. I've been watching this is very interesting. I'm Leonard Rodenberg. I'm a professor emeritus of urban studies at Queens College and research director of the New York Metro chapter of Physicians for a National Health Program. When the city and the MLC introduced their Medicare Advantage plan 18 months ago to move all retirees to a Medicare Advantage plan, they claimed that the federal government would make up for the $600 million that the city was then spending on our health care. That statement was repeated today, that the federal government subsidy will make up for that $600 million. That statement is false. It is an untruth. The city is currently contributing 20% of our health care costs. The federal subsidy to Medicare Advantage for the past years has been just 4%. And this year it is reported to be down to 2%. This is documented in my written testimony with data from the federal government. Further, in Medicare, federal money goes directly to doctors and hospitals. In Medicare Advantage, private insurers receive the money from the federal government and then siphon off an average of 14% to pay for everything from the cost of staff to review requests from physicians to authorize tests and treatments for their patients, to profits for stockholders, to salaries for overpaid CEOs like Mark Bertolini of Aetna, the city's chosen insurer, who made $27 million last year. The result is that Medicare Advantage is an inferior cut-rate medicine with 24% less money to care for patients compared to real traditional Medicare. Again, this is documented in data in my written testimony. I want to answer questions. This is ad lib. I want to answer.
Time has expired. Please wrap up. Thank you. Wrap up, please.
A question was asked of whether the state can move us to Medicare Advantage. The state cannot. Federal law allows that only if we're already in an Aetna plan. They cannot move us without offering us an option to Medicare Advantage. They can just say we're not going to offer senior care. That will cost the average city employee, I estimate, between $4,000 and $6,000 a year, because not only would they lose the supplement, but they will, by city law, since we will no longer be in the city plan, we will lose the reimbursement for Part B premiums, and we will lose our drug benefit.
Thank you.
People can't afford that.
Thank you so much. Thank you for your comments today. The next person is Francis Ferrara.
Hello, please excuse me. It's been a day. I'm sure you've all had that. Can you hear me?
Yes, we can.
Okay. I'm so sorry you caught me at this time. I sat here all day without a bite of food, and now I'm eating. I'm actually so appalled how little the city of New York thinks about retired employees. They tried to give away our health insurance so current employees were given raises. The city of New York wants to remove my medical insurance that I worked 41 years to receive. I was promised full medical benefits upon my retirement in 1978. Then it was changed to Medicare and my secondary. Then the city tried to force me into Medicare Advantage plan that was not suitable for me. My other choice was for me to cover or for me to overpay to keep my health insurance. And that was originally promised to me. Now you're trying to tell me that you're promising me, if you vote yes to this, that you won't force us into a Medicare Advantage. And I'm going to tell you that I've worked 41 years and I believed in the city of New York. I no longer do because of this situation. Please do not vote for this. Thank you.
Thank you so much. Up next is Stephen Feldheim.
They actually heard me.
Stephen Feldheim, if you're on. If not, we'll go to Charles Brancato. The next four panelists, virtual, are Cheryl Bluestone, Alan Odzi, Kathleen Donlan Spiegel, and Faye Aronson. Cheryl Bluestone, you're up first. Now, Alan Odzi. Sorry if I'm messing up your last name.
O-D-Z-E.
O-D-Z. Okay, sorry. Thank you. Yes, you're up.
Yes, good afternoon. My name's Al Odes, O-D-Z-E. I'm a retired New York City police officer. I'm born and raised in the city of New York. I was a first responder to 9/11. In 2014, I was diagnosed with a very rare ocular melanoma. Myself and one other cop sustained this type of illness from 9/11. I'm under the care of Dr. Paul Finger, and the doctor advised me that he will have to cease and desist treating me if I'm forced into a Medicare Advantage program. He refuses to accept it. I don't know about the other officer that's also under treatment. He's not in my doctor's group, but he's with another doctor. And these are the problems that we're going to encounter with medical professionals, specific to specialists that refuse to take a Medicare Advantage program. And it's pretty serious. So that's what I have to say. I thank you for your time, and have a good afternoon.
Thank you so much. We have Kathleen Donlan Spiegel. If not present, we'll move on to Faye Aronson.
I'm here. Can you hear me?
Yes, we hear you.
Okay, great. Hi, I'm Faye Aronson. I'm a retired New York City DOE bilingual school social worker, and I'm also a licensed clinical social worker, still actively seeing clients, and I've seen hundreds of families with disabled children and special needs children. My question is, I don't think it's been answered. People keep saying we'll be paying $200 a month. But for those of us who have disabled dependents, we'll be paying $400 a month, or even more than that if we have more dependents. So my question is very important, and it has not been answered. I understand that I, as the retiree, must opt out from my disabled dependent who's on Social Security disability and has her own Medicare in order for her to opt out. So I cannot pay $400 a month and still maintain my home, which, by the way, Farah Lewis has helped me save with her interventions with one of the bureaucratic agencies in this city. So is that I want to know eventually from the city, is that correct? Will I have to be paying $400 a month? And that $400 a month is currently, it's been said by 2 people on the panels or more, that we would be paying more than that in 2023 and with the new plan. So what am I going to be paying? $6,000 a year? I couldn't even maintain my home for that. The other thing I'd like to say is that as a practitioner in healthcare for 35 years, I've dealt with many Advantage Care plans, and it has been said before, they are not traditional Medicare. The burden to the doctors and the burnout and the dropout rate for the doctors is entirely different than traditional Medicare. We don't have these huge constant gatekeepers telling us, dictating us what to do
Time
on
has expired.
Medicare. All right, thank you for your time. Thank you for having this.
Thank you. And just to clarify, I can't speak to the increases because I don't know the answer to that question, but my understanding is that the 191 would be per member and dependent. So you are correct that it would be 400 in your case. So up next we have James Perlstein, Patricia Luce, Rocco Rinaldi, and Christopher Garbarino. We'll start first with James Perlstein.
Thank you. My name is James Perlstein. I'm a retired professor of history at CUNY and a member of the Professional Staff Congress American Federation of Teachers Local 2334. I call on the City Council to reject this effort to amend Administrative Code 12-126. I'm 87 years old, and for 43 of those years, from my mid-20s to my late 60s, I worked full-time for the city, committed to providing educational opportunity to working-class New Yorkers. I earned a living, I raised a family, and although I saw my income slide over the years from near the top of my profession to near the bottom, I took comfort in the city's promise to cover my healthcare costs into retirement. This proposed code amendment is a blatant attempt, unworkable and unnecessary, to constrain escalating healthcare costs at the expense of the most vulnerable and least powerful segment of the public sector, municipal retirees like myself. Still worse, the amendment exposes in-service employees to similar victimization down the road. It does nothing to restructure the inadequate, unsustainable, jerry-built system that passes for New York City healthcare. But there is an alternative, and the City Council is positioned to explore and advocate for it. First of all, redirect funds the city holds in reserve to bridge the Municipal Labor Committee Stabilization Fund for 3 years. Second, create a stakeholders commission charged with finding a path to control healthcare spending with hospital pricing as a priority. And third, develop a sustainable mechanism for funding city health insurance. These proposals, put forward in greater detail by my union, PSC CUNY, are preferable to the surrender of earned rights for an unreliable discriminatory fix. Thank you.
Thank you so much. Thank you for your comments. Patricia Luce.
To be the voice for the most vulnerable retirees in your districts who are unable to research what I have done over the past year. My due diligence has led me to the conclusion that replacing traditional Medicare is an immense disservice to your district's current and future retirees, especially those on low pensions, minorities, and the very elderly, whom research has demonstrated are denied care at the greater percentages by Advantage programs with their troublesome prior approval requirements. My union has historically been vehemently opposed to privatization, as evidenced in the resolution Stop the Privatization of Medicare and the article Preserve Medicare as We Know It, which is on the UFT website. They have done a complete about-face, possibly due to the deals that were made involving unions and the MLC to usurp billions from the stabilization funds for non-healthcare purposes. $1 billion went for raises. The plan is to serve up 250,000 retirees to the inferior Medicare Advantage private for-profit insurer to get the federal subsidy that the union decried in its resolution. Incredulously, there has been no oversight or consequences regarding the usurping of billions from the stabilization fund, which may continue with the subsidy. Please read Who's to Blame for Our New York City Teacher Healthcare Debacle in the GothamGazette.com, November 15th, 2022. Please, council members, protect your own integrity. Vote no to change 12-126 so retirees may litigate if the city and the mayor proceed with it. 92% are currently enrolled in senior care. So they're speaking that they want senior care. Thank you so much.
Thank you so much. Rocco Rinaldi. Christopher Garbarino. Dominic, okay, we're gonna go to an in-person panel. Dominic Martino, Michelle Keller, Robert Pilsker, Yolanda, sorry, hold on a sec. It's okay. Yolanda Pumarejo. Pumarejo. Let's go. Okay. Please come up, identify yourselves for the record, and you may begin when you're ready. Roberta Pixter? Yes. Sorry, I might have messed up your last name. I apologize. So we have Dominic Martino.
Button.
Okay. Hey, start. Yes.
Good day. My name is Yolanda Pumarejo. And my city council person is the Honorable Camilla Hanks of District 49 of the North Shore of Staten Island. I am here today as a career public servant with 37 years in city government. I began my career with the Administration for Children's Services right out of college at the age of 23 as a child protective specialist. My plan was to stay for 6 months and move on. But once there, I realized the rewards of having a career in city government, including the ability to help the most vulnerable children and families of this city. This is one of the most difficult services provided in New York City. Child welfare workers risk their lives every day to ensure our children are safe with little to no recognition. As my career progressed, I became involved with my union, the Social Service Employees Union Local 371, eventually becoming the executive vice president until I retired in December of 2020. You should know that during this time, there was little to no mention of any deals being made by the MLC to divert money from the Health Stabilization Fund for salaries in exchange for this draconian health plan. It was reported that if any changes occurred to the health benefits for retirees, they would have the option to enroll in the New York City Managed Care Program or to remain in their plans cost-free. Never ever was this health plan discussed in detail with union members. Who would agree to be forced into a managed care program knowing what we know? The failures and the mismanagement of these plans by for-profit insurance companies have been well documented and reported in the New York Times and elsewhere. A promise is a promise. There must be a moral obligation to all the women and men who have spent their careers running this city. If the MLC wants to negotiate this moving forward, so be it, but not on the backs of the current retirees. There are other ways to realize these savings. Just ask us. We'll be very happy to share some suggestions and solutions. Also, this body should be aware that the arbitrator's ruling is an opinion and not a decision, as he clearly states in his report. The City Council has historically protected 12-126, and now it's your turn to do the people's work and vote no. Do not be afraid. New York City public service retirees are the backbone of this city. Support us, and we will support you. In closing, I must tell you, it is with a heavy heart that I come here challenging my very own union that I love in order to save the health benefits so many of us worked for and were promised. Honor your New York City public service retirees and vote no. Thank you for voting no to amend this administrative code.
Thank you. Thank you. Ms. Keller.
Thank you. Good afternoon, my distinguished sisters and brothers of the New York City's City Council. Specifically, our Speaker Adams and also Carmen De La Rosa. Thank you for inviting the retired workers into this space. My name is Michelle Keller, serving my union and my community. I am a District Council 37 retiree, 43 years of illustrious public service. I am also the president of the New York City's Coalition of Labor Union Women, AFL-CIO. All fields of labor, essential workers, active and retired. Also, I sit on the DC 37 PAC committee. Protect, do not, don't amend Administrative Code 12126. Everything else will make you sick. We know that all things done in the dark will always come to the light. It has been more than 2 years now that this very madness remains unresolved, even with the positive intervention of our judicial system. No money's being saved here. Why have those who use the service been shutted out of meeting rooms? The retirees and their families use the service, but have been turned away from meeting rooms on several occasions. No vote, no voice. Retirees, no vote, no voice. Retirees utilizing the service are documenting their dangerous, diminished care. Those who opted early on to accept this experimentation of the disadvantaged care are now trying, pleading to return to senior care. We have heard directly from government sources, doctors, hospital professionals, and patients that choice, portability, and the quality of care will be minimized, and we cannot knowingly be complicit with this dysfunctional resolve at our cost. What happened to all of the monies in our stabilization fund set up expressly for the adjustments and financial offsets of healthcare costs to cover actives, retirees, and their families? Has there been a published audit for transparency to offer a security and a reassurance to all members and the public at large that the drainage of our funds will not happen again?
Thank you. Please wrap up.
Okay. Let me just get
And we have your testimony.
Okay, no problem. This I want to get in. We are aggressively trying to assist and attract new and fearless organizing generation. The entitlement of quality health care has been our signature commitment for the strength of our collective bargaining. So what's happening? Construct other ways to save money without peeling away from the retirees that have delivered their worth tenfold. Think of the disasters that have shut the city down over the years. Who has been responsible to reset the business? Thank you, City Council, for yourself, for us, For your constituents, whose side will you be on? Healthcare is a public good, so don't imperil our service. Preserve Administrative Code 126, because everything else will make you sick.
Thank you so much.
Good afternoon. My name is Roberta Pixer. I'm a retired teacher of English as a second language to adults. Is this on?
Press the button.
Okay, I beg your pardon. Can I get my 10 seconds back? Can I get my 15 seconds back? Good afternoon. My name is Roberta Pixer. I'm a retired teacher of English as a second language to adults and a member of the United Federation of Teachers. I served as Adult Education Chapter Secretary. Our students had jobs or were searching for jobs or both. We teachers worked from 8:30 in the morning until 9 at night, traveling between boroughs on a 6-day week. We were available to our students when they called us at home. We were paid for classroom time only, not for preparation or travel or consultations. We chose to do this work in order to help people who were becoming part of our communities in the city of New York. We knew that we would retire with the security of health care for the bodies we had used up in the service of our city. That was the bargain. That is what we earned. Now, the city wants to renege on its part of the bargain. Health savings is not the issue, unless the money is needed to pay the $27.9 million salary of the CEO of Aetna, or to contribute to Aetna's $11.9 billion a year profits. There are other ways for the city to save money besides denying needed medical care to the workers and retirees. They have been enumerated here. You can turn over those rocks. And there are always ways to find money for what you want. We know this. One way that hasn't been mentioned today is that the city could collect the stock transfer tax that is on the books and is now being returned to the stock traders and to their little computers. Amending Section 12126 of the Administrative Code will remove the assurance of cost-free care, though in truth, we've already paid for that care. It will open the way for tiered health care for all future city workers. This is not acceptable for a city that purports to be the most advanced city in the country. Do not sell out the retirees. We are your constituents, and we vote. Do not sell out the current workers. They are your constituents, and they vote.
Thank you so much.
We are all your constituents. We all vote.
Thank you so much.
Thank you.
Thank you. The next panel is Ruth
Thank you so
Solomon,
much.
Lisa Flanzraich, well, I'm gonna mess this up, Flanzraich, Roberta Gonzalez, and Thomas Schechter. Should all be here in person. If you are, please come up and identify yourself. Okay. If there is space on the dais, we're gonna call up as well Maureen McDermott, Barbara Turkwitz, and Teresa Moran. Please come up as quickly as physically possible, and we'll get started when you're ready.
When you're ready to speak, just press the button, okay?
Okay. Anyone else from that list? Ruth Solomon, Lisa Flanzraich, Roberta Gonzalez, Thomas Schechter, Maureen McDermott, Barbara Turkowitz, and Teresa Moran.
You want us to start?
Yes. Just start. And identify yourself so we can make sure we know who's here.
Good day, council members. I'm Roberta Gonzalez. How's that? Can you hear me now? Yes. Good day, council members. My name is Roberta Gonzalez. I'm a New York City retiree with 38 plus years of service, all at the Department of Health and Mental Hygiene. I want to give a special thank you to my council member, Ina Vernikoff, who has supported me along the way. I want to quote former Vice President Hubert Humphrey, who served as Vice President from 1965 to 1969. He spoke about the successful measure of a government or a society at his dedication of the Humphrey Building in Washington, D.C. He said that the measure of societal success is reflected in its treatment of the weakest members of society. He said the moral test of a government is how that government treats those who are in the dawn of life, the children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped. What kind of society and what kind of New York City government will pass this moral test? I say one that votes no to changing Administrative Code 12-126 and does not diminish the health and well-being of its municipal retirees. I have 2 cancers related to working for the City of New York during and after 9/11. The World Trade Center Health Program has a 2-tiered system: responders who are uniformed and on-the-pile city workers, and survivors who breathe the same air but work next to those on the pile. Responders are seen at Mount Sinai, survivors are seen at Bellevue. As a survivor myself and a Bellevue patient, my cancer was undiagnosed for almost 4 years. I believe a 2-tiered system that this Healthcare Advantage program would put into place was not seeing me in the same way and would not see me in the same way that a system designed for all would have seen me. Thank God I eventually went to NYU with my scans for a second opinion, and the doctors there took one look and told me I had lung cancer. Thank God it was slow growing and I wouldn't be here today. I've given you copies of alternative plans, and I hope that you will look at them and vote against changing 12-126.
Thank you so much, and we received your packet. Thank you.
Hi, I'm Barbara Turkowitz, and I sat where you are because I worked for the City Council for 12 years. I know this has been a long hearing. I've submitted comments. I think what I want to say at this point, having listened the way you have to the whole hearing for the day, is that I think we're a stellar city, and I think that we deserve to have the best health care around, and I think that means keeping it government-run. I think government runs things well. I think that the Medicare plan is a much better plan than the Medicare Advantage plans have been. I think that's what everybody who has studied this says. And if the unions really came up with a plan that's so much better than anything that exists, put it on the table, let people join that plan if they want, or keep this plan if they want, and neither one of them should have a fee. It's still going to be cheaper for the people who go to Medicare Advantage because there are these additional benefits. There is a lower deductible. So there are incentives for people to take that plan, even if you still allow us to keep our plans for free. But what I'm hearing is everybody wants choice because they don't want to go into the Medicare Advantage. So even the teachers who came to support the unions in asking you to make these changes, they still were really saying this because they want to keep their Medicare, which is really undermines the argument that the Medicare Advantage is some great plan. But it may be. But then let's make sure that there are people at the table to evaluate how good it is. And I don't personally trust the MLC to be the people at the table doing that. Put together a real task force of people who have backgrounds, include retirees, and give it a shot and let us evaluate what these results look like. They didn't tell us what their performance measures were. Are they going to say how many people didn't get certain tests? How many people were denied ability to get to a doctor? How many doctor changes? I haven't seen any of those performance metrics. And that's what I did for a living for years. I did public policy. I don't hear a policy discussion here. And I think the policy of going private is a bad policy for the city of New York. And that's why I would urge you not to make this change.
Thank you so much. Thank you for your thoughtful comments. Press the button.
Oh.
There you go.
Good afternoon, Chairperson De La Rosa and members of the committee. My name is Thomas Schechter. I retired from HOA after 30 years. I have a lot to say, but so little time to say it, so I'll have to cut out some. First part, in 1975, New York City was literally bankrupt. President Ford told the city drop dead. They imposed a fiscal board on New York City for 20 or 30 years, but they never once changed health plans. And when we were actually bankrupt, and they didn't change pensions when we were bankrupt for people who were already receiving them. Now, we are not bankrupt, and yet they are changing the plans on us when it's really not necessary. Second is a personal problem. I come from my wife who is not yet Medicare eligible. If this plan goes through, who will pay for a bankruptcy lawyer for me? I will either have to pay for some plans so we can both be covered, because the Aetna plan for people who are not on Medicare is $455 a month. So I need to pay for that. I pay for the senior care or senior DC 37 at $195 a month, and I can't afford either. So who will pay for it? City Hall, legislator, MLC, Mr. Simon? The third part is that Mr. Simon seems to think he has big power. He is over the mayor, he's over your office and the city council, over MLC and everything else. He can give deadlines to city council. I didn't think he had that power. And he can impose premiums on health care. I didn't know he had that power. I don't know who gave him that power. I didn't see where it was written. The other part is that—
Thank you. Please wrap up.
Many places like MD Anderson Medical Center, Cleveland Clinic, and Mayo Clinic will not accept any Medicare Advantage plan because of the, and so as other places probably, and doctors, because of the horrors of prior authorization and problems in getting paid. Maybe I'm getting out of line, but I see all these problems popping up. I was lucky. I just had to go to Memorial Sloan Kettering. If I was not with the city, they would not accept a Medicare Advantage plan.
Thank you. I appreciate your comments. Thank you so much, and thank you all for coming. Up next, we'll have a virtual panelist, Teresa Moran, and then following Teresa, an in-person panel made up of Elizabeth Susie Sander, Gloria Brandman, Marcia Biederman, and Adina Schwartz. If you're here, you can start quietly coming to the dais while we listen to Ms. Moran virtually. Thank you.
Hi, my name is Teresa Moran. I retired from New York City service in 2002. I am a resident of Council District 23. Can you hear me?
Yes, we hear you, Teresa.
Oh, all right. I wasn't sure because I fell off the top of the thing. Okay. I'm represented by the Honorable Linda Lee. In 2009, my doctor discovered that I had cancer. Treatment included surgery, radiation, and taking meds for life. Without the medications, I will die. But as you see, I'm still here, so they're working. Plus, I must have different tests at various intervals so the cancer doesn't come back. So when this Medicare Advantage talk started, I followed up with my doctors, none of whom would participate in any Medicare Advantage plan. Their reason was constant denials for permission to order necessary tests and procedures. My research shows that various government and media investigations support that as fact. I certainly don't trust the MLC's word that they will now prevent this from happening to me, since it was the MLC who decided to replace my Medicare Emblem Health Plan with an Advantage plan in order to cover their numerous financial rates on the Health Stabilization Fund. So they gave me no choice but to opt out. Would paying $191 a month be a hardship? It certainly would. Due to the effects that the drinkable radiation has had on my teeth, plus my huge medical bills, my medicine bills, the deductible medical amount I reported on my taxes for 2021 was more than $20,000. In 2023, it's going to cost even more. I went back to work several years ago to be sure I could pay those bills. But as I am now nearing 80, I do wonder how much longer I can work. The New York Supreme Court and the appellate bench agree that thanks to the protection of Administrative Code 12126, I should not have to endure further financial hardship. 12121 is protecting me and every New York City employee and retiree.
Thank you.
All of us are relying on you to protect 12126, just as your predecessors have done for more than 50 years.
Thank you so much, Ms. Moran. Thank you. Up next, Elizabeth Susie Sander, Gloria Brandman, okay, Marcia Biederman, and Andina Schwartz. If you're here, you can come forward. If not, we have Sarah Shapiro, Francine Scolas, or Arthur D. Cesario. If you're here in person, any of these folks can come up, and you can begin when you're ready.
Ms. Sander, you may begin when you're ready.
Good afternoon, council members. My name is Susie Sander. I worked for the city for 25 years, and I am represented by council member Julie Menin from District 5. May I respectfully ask you to take a moment to look at us, and to think of those who are too old or too sick or too far away or too poor to be here today. Altogether, we are city retirees who worked on average 20, 30, or more years for the city. We are labor. New York City is now considering stripping away the Medicare Medigap plan that it has committed to, and to which we expected under Administrative Code 12126. And you, City Council, are now contemplating moving us into a privatized, for-profit plan with the misleading name of Medicare Advantage. Advantage is not Medicare. Many of our doctors won't take those plans. One of mine won't. It will only take Medicare. Why? Because these plans pay the provider very little, burden them with onerous paperwork, and are full of pre-authorizations. Advantage plans are under countless investigation, including congressional, because of denials and delay of care and even fraud. Once one is enrolled in an Advantage plan, it is very, very hard to return to traditional Medicare, Medigap, health insurance, and in some cases, it is denied because of pre-existing condition. Medicare, Medigap provides national coverage, Advantage does not. Advantage policy offer Fitbit watch, dental cleaning, free pair of glasses, some transportation to close by doctor, few hot meals after surgery, and some sort of exercise classes. None of this is good enough. Please keep 12126.
Thank you.
In closing, I respectfully suggest that the council members call their own doctors, their parent doctors, their grandparents' doctors, and ask those providers if they will honor and take Advantage plans. Thank you and have a good evening.
Thank you.
Okay. Hi, good evening. I want to thank
Can you make sure that your mic is on?
Oh. Is it on? Yes. Hi. Good evening. I want to thank the remaining council people for staying to listen to us. My name is Gloria Brownman. I have been a member of the United Federation of Teachers for over 40 years, the last 7 as a retiree. And I want to start by saying my union never asked membership if we wanted this change. I never asked for it. There's never been a vote in any of the Democratic meetings in my union, not at the executive board meeting, not at a delegate assembly, not a retired teachers chapter meeting, never. Mr. Mulgrew was here earlier, but he did not stay to listen to what the retirees here are saying, although there was a panel earlier that he put together, and I appreciate their need for good quality health care. They deserve it, and they want it, but they say they can only get it if you do amend the change. And I also want to say that panel was put here by Mr. Mulgrew, so it was his opinion as well. So I was a special education teacher, and my job was to ensure students increased academic and social skills. I evaluated them, found out what they knew, taught them what they needed to make progress and make choices. And I hope this hearing is doing the same for you, honorable council people. So what do you know? The city told you without amending the code there'd be no choice for retirees. False. Retirees, we already have a choice, actually, between 12 different plans. We want to keep the high-quality, premium-free health insurance we were promised and we earned by all our years of working. If the code is amended, the only free choice will be a privately run Medicare Advantage plan with and you've heard this all day, fewer doctors, need for prior approval. It's not what we want for our health as we get older. You've been told that the report issued by Mr. Scheinman is a ruling. False, it's not, it's an opinion, it's not binding. There was no arbitration, there was no disagreement. It's being used to mislead you. Costs are out of control. Yes, they are. But you have heard all day, you have gotten many, many emails with ways this city can get more money and can afford this health care. Stock transfer tax, the PSC plan is brilliant. Council members, you need to find out what really happened to the Health Stabilization Fund. Do your research, and I am sure you will not amend 12126. Thank you.
Thank you. Thank you.
My name is Sarah Shapiro, retired teacher, lifelong unionist. I'm here to urge you to vote no on amending Administrative Code 12-126. The New York Times article, "The Cash Monster Was Insatiable," reported that nearly all the top Medicare Advantage insurers have been accused of fraud or scamming the federal government by overbilling. One of these companies is CVS, which owns Aetna. The insurance company the MLC and Citi are currently negotiating with. Mark Bertolini, CEO of Aetna, is the highest paid CEO. He made $27.9 million last year. Medicare Advantage is a misnomer. It is not Medicare. Legislation in the House called Save Medicare Act would make it illegal for these private health insurance companies to use the word Medicare. Medicare Advantage plans are in the business of making profits by delaying and denying necessary medical care. Retiree health care is only 0.6% of the city's entire budget. According to the Mayor's Office of Management and Budget, November financial plan, the city has $8.3 billion in reserves, the highest level in its history. The Rainy Day Fund has $1.9 billion. The General Reserve Fund has $1.6 billion. The Retiree Health Benefit Trust Fund has $4.5 billion. The city is not broke. Long-term solutions to cut health care costs are needed, such as the city could create a self-insurance plan, aggressive hospital cost reduction measures. All union welfare funds could be consolidated into one for group drug purchasing. There are several possibilities for long-term solutions. We retirees have thought of many. We urge the City Council to do their work and investigate this. We agree with the proposal put forth by the PSC. Listen to retirees, let the mayor do his own dirty work, and vote no on amending Administrative Code 12-126.
Thanks. Thank you. Can you make sure that your mic is on, ma'am? Thank you.
I'm Fran Schloss, former president of DC 37, Local 1757.
Do you mind bringing it closer to you so that the people in the back can hear? Thank you.
Representing appraisers, assessors, and housing development specialists. I'm here today as a retiree, speaking against the proposed amendment to the city charter. The reason that I remained an employee of the City of New York for 39 years was the promise of future guaranteed benefits, such as a defined pension plan and virtually free health care benefits. I am here today because it is not the fault of the 66,000 DC 37 retirees that the Health Care Insurance Stabilization Fund was utilized for entirely unrelated matters. These were withdrawal of funds without provisions for replenishment. I am here today because of the savings of $600 million that was guaranteed between the MLC and the City of New York that was not fulfilled. It is curious that the Retirees Association has identified over $300 million in savings toward this figure that has not been previously identified. To change the city charter regarding retiree health care benefits is an action that will endanger the financial well-being of retirees on fixed incomes. This is in addition to an insurance company that will act as a gatekeeper, having the power to overrule the judgment of a retiree's primary care physician. I will conclude with this last thought. We, as New York City employee retirees, may not have a seat at the contract negotiating table, but we do vote in great numbers, and we do bring out the vote.
Thank you so much for your testimony. We will now be moving. Okay, we have two more in person, Arthur Di Cesario and Richard Ayes. There will be more, yes, the next panel. Okay, Arthur? Is that, no? Okay. Richard, all right, so we're moving on. We're moving to a virtual panel. Ibeth Mejia, Jacqueline Lyle, and William Terry. Ibeth? Okay, Jacqueline Lyle? Jacqueline Lyle. We're doing virtual. Okay, we're having some technical difficulties, so we're going to move to in-person. The next panelist is made up of Roy Fishman, Michael Brocum, Edward Hernandez, and Jack Latorre. Okay. Seeing as we only have one person for this panel, we will call members of the following panel: Mark Kagan, Max Stapler, Martin Haber, and Gail Littenberg, sorry. Okay, our apologies. It seems like a lot of folks have gone home.
It's on? Great.
Bear with me 1 second. It's okay. You can begin.
My name is Mark Kagan. I'm actually a constituent of Councilmember De La Rosa. I'm sorry she's left by now.
She'll be back. She didn't. She's downstairs.
I seem to be the first one to say that. I am a UFT retiree, angry that my former union is at the forefront of this effort to take away the medical benefits of myself and my wife, a double cancer survivor whose next CAT scan is tomorrow morning. Thankfully, her constant regime of testing is not subject to prior authorizations and denials. She has enough on her mind without fighting with insurance companies. I'm a grateful active member of the Professional Staff Congress, CUNY, grateful not only that the PSC voted against Medicare Advantage at the Municipal Labor Committee, but has gone the extra mile and more, setting forth a realistic alternative plan that the City Council can and should embrace. Councilmember Ressler earlier called this a game of chicken, and he's right that Mayor Adams and Harry Nespoli and Michael McGrew have rigged this as a game of chicken. Councilmember De La Rosa asked, can the city and the MLC do this? We'll see what the courts say, but you are the city too. You can reject the game of chicken. You can reject being the bad guy, Adams's tool. You can intervene proactively. You can tell Adams to use the Retiree Health Benefit Trust. You can use the 36 months that gives you to build a better health plan, not just for retirees who actually cost the city so little, but for all city workers. These savings are a one-shot temporary fix to a systemic problem. What the PSC is proposing is that we look for a real sustainable solution rather than victimize retirees this year, new hires the next, people with high prescription costs, or lots of dependents in a third, and so on. Thank you.
Thank you.
Good day, and thank you for this opportunity to speak. My name is Jack Latore, retired NYPD lieutenant and cancer survivor. First, I wish to thank Marianne Pizzatola and her team for forming the New York City Organization of Public Service Retirees. Thanks to this group, I can present the following facts. 1, the stabilization fund has been misused for many years. 2003, 2006, 2009, 2011, and 2014. To fund raises by taking $1 billion from it is wrong. 2, by changing Admin Code 12-126 to force retirees in privatized Medicare Advantage is both deadly and wrong. 3, to ignore the fact that big healthcare is under federal investigation for Medicare Advantage fraud is wrong. 4, to subject low-income retirees to higher premiums, fees, and copays is wrong. 5, to ignore the fact that Medicare Advantage adds nearly 100 more life-threatening pre-authorizations is wrong. 6, to ignore the fact that Medicare Advantage limits care and access to life-saving treatments is wrong. 7, to believe the so-called Scheinman document issued December 15, 2022 has the force of law is wrong. It is a non-binding recommendation. 8, for the Municipal Labor Council to have 2 unions, the UFT and DC 37, control 2/3 of any vote is wrong. 9, if this City Council amends Admin Code 12-126, it will be taking away the health care rights of the elderly and disabled retirees who have dedicated their working lives to serving the people of New York City. Eric Adams, when running for mayor, said the Medicare Advantage plan seems like a bait and switch. I ask this council to not amend 12-126. I ask this city council to do what is right, not what, as is clearly seen by the true facts, is wrong. Thank you.
Appreciate your testimony. Thank you so much.
Thanks. Good luck with your wife.
Okay. Our next in-person panel will be Rosalie Frangella, Anna Juarbe, Carmela D., and James Hayhurst.
Rosie Vartarella. Rosie Vartarella.
I have Rosalie Frangella, but
Okay, that's not me.
you can stay.
I don't know.
Okay, you may begin. Make sure that your mic is on.
Hello, my name is Rosie Vartarella. I am a retired vision teacher for NYC DOE from Brooklyn, District 39. I want to thank you, Shahana Hanif, for your support. For 25 years, I worked with blind and visually impaired students, most of whom were the only visually impaired students in their schools. I traveled to three to 5 schools per day. I love my job, I love my students, I love my life. Along with my husband, Rick, also a retired NYC DOE teacher, I juggled work, family life, just like everyone here. I saw Medicare come out of my paycheck without much thought until last year when I moved on to Medicare. It has been a seamless transition with senior care. I do not worry about my future health care on Medicare. I do not want to change to Medicare Advantage, and pay up senior care will be unaffordable. That is not an option. The UFT does not speak for me on this issue, though I am a dues-paying member. When you are young, busy, juggling, making your life, you do not think about future health insurance, but you must, you should. You will care when you are a retiree. You will want to know you can go to an MD of your choice, not worry about pre-authorization delays for needed testing, be covered when you travel, not have to worry if an MD no longer accepts your coverage. Each of you will be just like me in the future, and trust me, you will want original Medicare, not Medicare Advantage. When you are covered and medical emergencies arise, whether young or old, you do not want to deal with uncertainty. My family has dealt with many medical emergencies and unforeseen illnesses, but we did not worry about health care when they arose. I'm living and enjoying life today. I want to know that what I paid into all of those years of pay-stub deductions, all of those happy and incredibly hectic and juggling years, what I bought into is what I earned and what I have. The most important skill I taught my students was self-advocacy. I'm speaking out for myself today with my students, my family, and all of you in my heart and on my mind. Do not change Administrative Code 12126. Thank you.
Thank you so much. Thank you.
My name is Carmela D. I'm a DC 37 retiree and worked for New York Public Library as an archivist for 18 years. I now work at a local library to supplement my $16,000 annual pension. I do not deal in misinformation. The city and the unions have betrayed us by breaking their promise to those who served the city for decades. And at the height of the pandemic, my husband suffered a retinal occlusion in his left eye. His doctor called it a stroke in his eye. He will require retinal injections every 4 to 6 weeks for the rest of his life. Traditional Medicare and GHI senior care cover it, except for the $15 copays. In a Medicare Advantage plan, he could have to wait for authorizations and suffer further retinal damage. Although we live modestly, to have to pay almost $5,000 a year plus copays to keep our current health insurance was not something we planned for. This is also a social justice issue. Those who cannot afford to pay premiums and copays will be forced into a MAP despite the wealth of data proving these plans provide inferior health care. We all understand the need to save money, but amending the code and forcing people into a MAP are not the only ways. Martin Scheinman's report is only his paid opinion. It is not binding. No previous city council has fallen for the scare tactics. Code 12-126 has protected our health care since 1967. If it's amended, the door is open for the city to go after any of our benefits. Does this city council really want destroying the health care of retirees and employees to be its legacy as well as its own fate? Please vote no. Thank you, and thank you for being here.
Thank you so much. Up next, we have James Hayhurst, Jay Flynn, and Earl Roberts. If you're present, please come forward. James Hayhurst, Jay Flynn, Earl Roberts. Okay. Sure. Let's try Robert Bookman, Bob Greenberg, Renee Dinnerstein. Okay, thank you. We have a few. Okay. Angel Medina, Brenda Berkman, Jackie DeSalvo, and Leslie Williams. If any of those folks are present here, please come forward. If not, you may begin.
Start.
Identify yourselves and begin. Thank you.
Excuse me a minute. My name is Renee Dinnerstein, and I'm a retired New York City teacher. And I'm here to ask you not to amend Administrative Code 12-126. I began teaching in public school in 1968 and retired in 2003. The idea that the city and my union, the UFT, might deny me the medical coverage that I've had since retirement has caused me great distress. I've been told in no uncertain terms by my 6 medical specialists who literally keep my body going that they will not accept Medicare Advantage. Dr. Estia Silausi, my pain management doctor, Dr. Nancy Coles, my ophthalmologist, Dr. Nancy Silver, Karen Silver, my podiatrist, Dr. Stuart Katchis, my orthopedic surgeon, Dr. Hal Mitnick, my rheumatologist, Lisa Primick, my physical therapist. The older I get, the more specialists I seem to see, and I have many friends who are in the same position. I also fear that this change, or this possible change, will add to the unfortunate two-tier system in our city. My teacher's pension after taxes is $39,768. I could keep my Medicare and pay for supplementary insurance for my husband and myself, reducing my net pension by 12.5%. A municipal worker retiring with a much smaller salary might possibly have a net pension of $12,000. The cost of the same supplemental insurance that I would sign up for would end up being 40% of their pension. Anyway, please don't change it. It's a bad idea.
Thank you for testifying.
Hi, my name is Jay Finn, and I'm a retiree from the New York City Police Department. I'm here today on behalf of a couple of retiree organizations, the Superior Officers Association Retired, the New York 1013. We represent around 15,000 retirees, and we're asking that the council not make any changes as requested to the 12126. I've been requested by a number of retirees in their 70s, 80s, and 90s to please not change the administrative code. When they retired and they worked for the city, there was promises made, and we've heard that time and time again today. One of the things that I heard today was disconcerting. It was about when the city was testifying, they constantly referred to the MLC. And I just want to point out that the MLC does not represent the retirees. And in fact, it wasn't really discussed about the weighted vote in the MLC. When it was originally formed, the MLC has evolved, and that's one thing that the council can review about how we got here today. What authorities were vested originally in the MLC, what was the original intention of the MLC, and how did the weighted vote goes. Typically, when you have a more powerful organizations like the UFT and the DC 37, there would be some sort of protections for the minority that don't seem to be really heard. I give a lot of credit to Marianne Pedizzoli and her staff that has brought a lot of these issues to light. When some of the questions that came from the council today were posed to her, she said she would love an opportunity to talk to the different unions, and we've kind of been shut out. So that is one thing that I think the council is empowered to do, look at who actually speaks for who. The retirees, when you look around, we feel that we have been neglected. A lot of people couldn't come down here today, and we ask that you, take that into consideration of how we got here today and how we get there, a solution that listens to everybody. Thank you.
Thank you so much. Thank you for your testimony. We have Damian Andrade, Robert Thompson, Elsie Newman. You're present. Ed Delgado, Colette Switchnicki, and Nestor Daniluk. Ed Delgado, Colette Switchnicki, Nestor Daniluk. If any of those folks are here, and I'm sorry if I messed up your name. All right. Juliet Giorgio, Lynn Bender Max, Elaine Kitt, Denise Rickles. Michael Kellner, Michelle Kellner, Laura Judith Dajian Ayala, Anthony DiLeonardo, Monica Leila Benefante. You may begin when you're ready and identify yourself so that we can track you. Thank you so much. Whatever makes you comfortable. Make sure you turn on the button. There you go.
Oh, hi. So I'm Denise Rickles, and I'm a retired special education teacher, and you are my district person. Thank you. So in the past years, during a budget crisis, mayors have asked the City Council to amend 12126. The City Council chose not to. That is the decision I'm urging you to take, not to amend. We sacrifice salaries increases in order to keep our benefits. We were promised premium-free health care at retirement. Now, Aetna Advantage is being proposed in a so-called effort to solve the city budget crisis. The cost of senior care is 0.6% of the total city budget. Do you really think that putting us in an advantage plan and eliminating 0.6% from the budget will go a long way to solving the budget crisis? I don't think so. The only thing it will do is to have a negative effect on the health and financial well-being of retirees and contribute to Aetna's billion-dollar yearly profits. You are putting us in an advantage plan in spite of the fact the Medicare Advantage industry is under federal investigation for billing scams, fraud, waste, deceptive marketing, and abusive practices. The New York Times has written a number of investigative articles exposing their practices that cheat, scam, harm, and sometimes kill people as their profits soar. Why are you putting us in this plan? Doesn't make sense. Mr. Scheinman's recommendation is an opinion and not legally binding, and so agrees Michael Mulgrew and Randy Weingarten. No one asked? Okay, I'm going to try to just finish. The MLC and the OLR are desperately lobbying because they have already given raises to municipal workers. The money for the raise was calculated on the projection of health care cost savings after putting retirees into a Medicare Advantage plan. We retirees rejected it, and we sued the city, and we won. And they have not been able to have cost savings because it never happened. So what I'm asking you is to please let us fight the good fight by not amending 12.126. And we would like to have the good fight. Let us do it in court. We understand your fear. I really heard it. You know, you want to know what happens if we don't win. Well, you know what? I'm willing to take that risk. And I think most of us are. And I'm speaking for many people. We're not going to put it on your shoulders. It's not your fault. We want to fight that good fight. We think we have a great chance of winning. We won twice before, and we would love you to give us that opportunity. Thank you very much.
Thank you so much, Denise. Thank you.
I think, there we go. Thank you, Madam Chair and Council members, for still being here. We really appreciate being heard. My name is Laura Dagan Ayala. I am a retired, good last name, right? Retired New York City public school teacher. I served this city beginning in 1981, retired in 2016. You can do the math because a teacher probably taught you how, very likely a public school teacher. During the last 2 decades of my service, I worked for the United Federation of Teachers Teacher Center as a literacy coach in a bilingual school in Washington Heights, and subsequently as a teacher center instructional specialist for English language learners. Seeing my former union, my union to which I still pay dues, here advocating for Aetna, for the privatization of healthcare when they so stridently fight against the privatization of education is just surreal to me. The next thing I know, they're going to invite me to a birthday party for Eva Moskowitz. I'm going to put aside some of my testimony today because I want to point out one thing. The entire morning was spent convincing us that Medicare Advantage had addressed all of the concerns that we had about pre-approvals, about doctor care, about people accepting our doctors continuing to accept us as patients. But when the people who spoke for the UFT, and they came with a contingent of about 20 people, when the 5 people spoke about choice, and I want to say dike choice, which means supposed choice, each one of them talked about their right to maintain Medicare. Not one of them spoke about keeping this wonderful Medicare, or changing over to Medicare Advantage that was touted by Michael and others as being so great. Why? I ask you to ask yourselves why. Would they therefore choose not to change? So please don't be blackmailed or intimidated or gaslit. This is not an advantage to us, and we count on you to represent our best interests.
Thank you so much.
Good evening. Hi, my name is Lynn Bender-Max. I'm a New York City retiree, 36 years in the Human Resources Administration. I am urging you to vote no to amend 12-126 of the Administrative Code. I am fortunate to be represented by the extraordinary Councilmember Gil Brewer, who, quote, is a supporter of retirees who are concerned about maintaining their current health providers and not having insurance companies be gatekeepers. Much has been made of the so-called arbitrator's opinion that the city should switch 250,000 retirees and their dependents into an inferior Medicare Advantage plan. But it is just that, an opinion, not legally binding. This was not an arbitration, and Mr. Scheimer was not an arbitrator in this situation. This was a discussion between 2 parties that agree with each other, and organizations representing retirees were not part of that discussion. Retirees gave their all to New York City. They worked for substantially less money in their paychecks in return for guaranteed quality health care at no additional cost to themselves. If the Council votes to amend 12-126, They will be voting to establish a two-tiered healthcare system for retirees. Those who earn less money in their careers and have smaller pensions will be forced to accept an inferior plan with long waits for pre-approval of life-saving tests and procedures and often denial of care. Many studies, including the 2022 report by the Inspector General of the U.S. Department of Health and Human Services, show that for profit-making Medicare Advantage plans offer substandard care. Those retirees with higher pensions will have better health care options. Please, in 2023, in the City of New York, do not vote for inequality. Finally, on a personal note, last summer my husband was rushed to the hospital in excruciating pain. He had a scan at 2 a.m., another at 4 a.m., and emergency surgery at 11 a.m. If we were covered by a Medicare Advantage plan requiring prior authorizations for each test and procedure, he might not be alive today. This is what is at stake. Please don't amend 12-126. Thank you.
Thank you so much. Thank you all for coming today and for testifying. Up next, we're going to call Merrick Claude, sorry. And then virtual, if present, right after Ms. Claude, we have Ebeth Mejia, Jacqueline Lyle, William Terry, and Mary Claude. Yeah, thank you. Take your time. And also put the microphone a little lower so we can hear you. And then when you're ready, just press the button and you can begin.
Okay, can you hear me? Am I right?
Yes, we hear you.
Okay, good evening. I am Merrick Gelfand Claude, member of DC 37 Retirees Association, a lifelong New Yorker, a graduate of Hunter College, and a constituent of Councilman Eric Dinowitz, 11th District. I retired from the city as a supervisor in the Agency for Child Development after 34 years of service. Please do not approve the 12-1-26 measure. Please allow us to keep our Medicare and GHI emblem. MAP, Medicare Advantage programs, notoriously intentionally limit, impede, bar, and deny our needed medical services that are legally and contractually free. As we age, we develop a variety of medical issues which can necessitate medical intervention. I have had serious cardiac surgery, brain tumor, breast cancer, and other things that require immediate and continual medical services for these critical issues. For over 20 years, I have chosen to utilize doctors, hospitals, and medical facilities within the city and on Long Island for various necessary ongoing diagnostic services, MRIs, CAT scans, further surgeries, biopsies, sonograms, etc., needed for my medical conditions. It is imperative that I continue to have the choice of my doctors. It is imperative that I be allowed to use these services without being subjected to prior approvals, denials, appeals, which can allow a cancer to spread. Life-threatening medical nightmares require appropriate measures that cannot wait for approvals or dealing with denials and appeals. I implore you to keep our GHI emblem choice plan, which allows us to choose our medical providers without the restrictive time delays of gaining authorizations from a MAP bureaucrat, our urgently needed life-saving tests and interventions. Thank you for your time and any efforts you may make in consideration of my situation and the similar situations of most of the retirees of the city services. And I have an addendum on here. Okay,
Thank you so much, Ms. Clark. Thank you. Thank you for coming. We're going to turn to our virtual panels. I'm going to call the names. I'm going to call 3 names right now. If we could start with Ebeth Mejia, followed by Jacqueline Lyle, followed by William Terry. Ms. Mejia, when you're ready, you may begin. Not here. Ms. Jacqueline Lyle, when you're ready, you may begin. Okay. Ms. Lyle, are you on?
I am on.
All right. Thank you, Ms. Lyle. You may begin when you're ready. Oh, there you go. Okay. You're unmuted. Yes, we can hear you.
You can hear me? Okay, great. Good evening, and thank you for giving me the opportunity to speak with you today. My name is Jacqueline Lyle. I'm a retired New York City teacher. I worked many years in District 24. I received my health care coverage from New York City. I want to explain why that coverage, in its current form, has been valuable to me and to my family. I also want to discuss our research on Medicare Advantage plans and explain why the care is problematic. My husband, Kevin, experienced kidney failure in his early 50s. On Thanksgiving evening in 2004, we received a phone call from Columbia Presbyterian. They had a kidney for Kevin. We needed to leave immediately. If we had had to get prior approval, I'm not sure Kevin would have received that kidney, as his operation took place over a holiday weekend on the eve of Thanksgiving when insurance offices are closed. He did receive that kidney, and his transplant was successful. The point I am making is that medical emergencies and opportunities can happen at any time without warning. Requesting approvals and using a prescribed network of doctors can jeopardize treatments that must be done quickly to get needed life-saving results. A Medicare Advantage plan would require those authorizations. In addition, there's a dark cloud over our relief because my research shows me that his transplant is considered a pre-existing condition. If you move my husband into an Advantage plan, he might find, as many Medicare recipients do, that Medicare Advantage does not cover all that he needs. And if he tries to move back to traditional care, he will experience problems getting back on traditional Medicare. If that's not enough, his transplant status will be seen as a pre-existing condition, making a Medicare supplement unaffordable. Please do not change Code 12-126 and refrain from introducing Bill number 874. It is my belief that traditional Medicare will provide the best coverage for us. We have been retired for several years and we cannot afford to pay additional premiums.
The time has expired.
You've been entrusted by your constituents to represent their interests. Please do just that by helping to preserve their earned benefits and maintain their health and to continue productive, active lives. Thank you.
Thank you so much. Thank you for testifying. William Terry, if you're here, please unmute and begin your testimony. If not, we will move on to Ms. Jacqueline Lyle. Go ahead. Oh, wait, you just testified. Oh, your hand is up. Okay. You can put your hand down. Thank you. And then Vincent Licitera, Margaret Feely, Martin O'Neill, John Lanzilotto. If you could identify yourself.
Okay, my name is Vincent Licitra.
Oh, sorry. Okay, go ahead.
I just want to remind some people 30 years ago, this private medical insurance came into existence under administration you could figure out. And those are the same people that brought us the savings and loan scandal. This is going to turn out to be a scandal eventually. I say keep your hands far away from it. I heard some threats today. Some people saying you're going to get this no matter what. I don't think that's nice to threaten people, elderly people, people who are trying to make a living. Threaten them, you're going to take this no matter what, and they're telling you the same thing. People work a lifetime, and then they try to make it in their retirement. Who thinks kicking the stool out from under an elderly person or a disabled person is a funny thing to do? That's what you're doing at this point in life. You say, let's kick the stool out from under these people. Who cares? I got a 12-year-old type 1 diabetic daughter, an 18-year-old going to first year of college, and a 53-year-old wife. I got to bring them up. I got to get them into their life. How do I do that? When you guys are all dumping down on working people, how do we do that? I tell you one way. I take a gallon of milk, and when it's halfway down, I pour some water into it to get it a little bit further. I don't tell them about it. I do it in the dark of night. What I got to do? Go get on a food line now? Because you guys want to start adding more cost to our living? Go get on a food line now, right? I'm still trying to contribute to people that need food. But now I got to think about maybe I got to go on that food line. I don't want to do that.
We have over 200 names we have to call.
It's a shame. You guys should know better. I think you're courageous enough to make the right decision here. I know my council person, Carr, he said, we don't want this. Already knows it. We don't want this. You guys should realize that too. We go to fight for our country. We go to work for our country. We work our whole life hard. And then we get to the end, and they say, who needs you? Who needs you? We'll take whatever we want from you. Go to hell, they say. Because that's what they're saying. Please, let's get serious. We're all grown up. Let's get serious here. It's very important.
Thank you so much. Thank you so much. Margaret Feely, if you're here, Martin O'Neill, John Lansley Lodo. They're virtual. If you're virtual, Margaret, you can unmute yourself and go ahead. Martin O'Neill, John Lansley Lodo, Jack Hafiz, Richard Gannon.
What the fuck? She said my name. I can't. Oh, hello? Could you hear me?
We definitely heard you. Please do not use curse words. Thank you. Who are you? What's your name?
No. Oh, my name's John Lanzalato. I didn't.
Okay.
I don't know.
John,
Maybe
you may begin, John.
Okay. In respect to you, Councilwoman De La Rosa, and I wish there was more constituents and union members left, but it seemed like everybody's gone. But I'm going to tell you about me. I'm a retired New York City Department of Sanitation supervisor. Over 20 years. I retired at the end of 2001. My wife is waiting a double lung transplant, and she was turned down in New York, and she's listed in Philadelphia because it was the only place, you know, we could get her on a lung transplant list. I have emphysema, I've had bladder cancer, on and on. I'm keeping my wife alive. You know, New York City said they were going to take care of me, and I promised my wife I was going to take care of her. When they came out with the plan of the original New York Medicare Advantage plan, I opted out. And they didn't even have a plan. And today they did a lot of talking, and they have no plan. It's like a used car salesman. It's easy to talk and talk and talk, and they have nothing. Really. Vote no, okay? Now, I just want to say this. Medicare, which I pay for, pays 80% of the hospital. And the other plan, which I pay $300 a month for, the GHI, pays 20%. So I really don't, and they said you're going to be forced into Medicare Advantage. Medicare is a federal government thing. The city cannot force me or any of us in Medicare Advantage. And I don't know why they kept saying that. We cannot be forced into Medicare Advantage. The city does not, this isn't Russia. So Chairperson De La Rosa, I mean, you understand that, don't you? I want to ask you, when you said I heard you ask a question, I believe. You said that the city, if they decide to...
Your time has expired.
Huh?
Your time has expired.
Please wrap up. Thank you. Wrap up.
Well, I just want to ask you a question. You said if the mayor said to push you into Medicare Advantage, can he? No, he cannot. I mean, you guys understand that, right? Medicare is a federal government plan that we paid into. Please vote no. Please vote with integrity. Please take care of your seniors. Please.
Thank you.
Thank you. Could you
so
answer
much.
me, Councilwoman?
Thank you so much. My understanding is that the mayor and the MLC can agree that Medicare Advantage will be the only offering that the city will pay for, making it zero cost to retirees. And that is what is up for discussion here today. I appreciate your testimony, and I certainly do wish you and your wife good health. Thank you for coming. Jack Hafiz, Richard Gannon, Cedric Fergus, and Cindy Matthews. Jack, if you're here and you want to testify, please unmute yourself and begin when you're ready. Richard Gannon, you can go ahead, please. We hear you.
Yes, my name is Richard Gannon. I'm retired from 2009. I retired out of the New York City Department of Correction. I started my employment with the City of New York with New York City Parks Department at 16 years old. I'm here representing myself and also additionally my father, which is also a city retiree who retired in 1999. In my opinion, the council should not do the mayor's bidding and force us to go into, as we've always had, and by changing the administrative code, it would be no longer a choice. We would be stuck with what the labor relation has deemed what's best. I feel that the administration code shouldn't be changed because it's been sitting there for 50 years protecting the rights of all these city employees. I think the City of New York, as employees, we're the best employees in the world. I still have additional family members who do work for the city. I have one that works as a teacher. I have one that's still in NYPD. And I really feel that was one of the promises that we all stayed. We didn't go into the private sector and make more money. We stayed where we were at because of the promise of the pension and the additional lifetime medical coverage that at this point you're looking to get rid of, putting us in a Medicare Advantage plan. The city no longer pays for it. The city makes out. I just do not agree with that. Thank you for your time.
Thank you, Mr. Gannon. Cedric Fergus. Cindy Matthews.
Yes.
You may begin. Ms. Mathias, you're muted. If you could unmute yourself, you may begin.
She's muted. What should happen is they have to accept the request to unmute. Okay. But Elizabeth's looking at me like she.
There should be a request to unmute. If you see it, please unmute.
We can just move to the next four.
Okay, so while we figure this out, we'll come back to Ms. Mathias. Robert Cohen, Carmen Olivares, Jean Inauzi, and Dulce. So if Robert Cohen is on the virtual line, oh, Ms. Mathias, can you hear us?
Yes.
All right, you may go ahead.
I can go ahead? Okay,
yes,
1 minute.
We hear you. Thank you.
Hear me. Okay, I'm a little disheartened that there's nobody left in the city council, and I've been on this meeting since 9:15 in the morning without eating or moving from my computer. I'm also disheartened that there was only 10 people that voted to open it. The 5 people from the unions that sat down at the table from the MLC, and only 5 people gave testimony to say they wanted you to open it. Every single other person that came to testify today is against you opening this. My name is Cindy Mathias. My city council member is Carlina Rivera, District 2, who is not there today. I'm a retired high school secretary with 22 years of service in public education. I'm extremely distraught with the harmful position that the UFT leadership is taking in forcing you to open Admin 12-126. It's been in effect since 1967, protecting us for 56 years now that it's 2023. Are city council members at risk of being forced into this disadvantaged healthcare program as well? The MLC negotiated behind closed doors. Rank and file had no voice. Who is the MLC? Certainly an organization with hardly any transparency. There is a two-third majority voting bloc in the MLC, consisting of the UFT and the DC 37. That is not fair to all the other unions that are against this. They are strongly on the side of privatization of insurance and giving all the power to insurance companies. Please look into the history of the mishandling of the stabilization fund. Because of the misuse, we stand here today. What is the point of making a promise and then changing the rules at the end game? This is what you are doing. Who will want to join a union or work for the city when you take away the very benefits you sold them to entice them into service and membership? There are many other ways for the city to save money.
Your time has expired.
No, it didn't. I timed myself. Reinstate the commuter tax. Opening 12-126 sets precedent to opening the administrative code in Albany for all of our pensions.
Thank you, Ms. Matthews. Your time has elapsed.
I want to make my final statement.
Thank you.
Complicit.
Thank you, Ms. Matthews. Your time has expired. Robert Cohen, Carmen Olivares, Jean Inauzi, and Dulce. If Mr. Cohen, Robert Cohen is on, you could begin.
Good evening. I am a retired professor from Queens College, CUNY, where I taught math for over 40 years. I urge you not to amend 12-126. Medicare Advantage plans put roadblocks in the way of their members as to which doctors they can see and what care is appropriate. I have had several bouts of melanoma, the deadliest form of skin cancer, and I am being carefully monitored for any recurrence. A few years ago, I was told it might have spread to my brain, a condition that is life-threatening. Fortunately, after several scans, it turned out to be a false alarm. Would I get the same level of care in a Medicare Advantage plan? I doubt it. And if it does later spread, could I then choose any doctors I want to treat me? No. I understand that the city needs to save money. However, there are other ways to save money, as outlined by my union, the PSC. There's a good op-ed in today's Daily News by Barbara Bowen and Barbara Caress. For example, the city, like many large corporations, could self-insure, hiring an outside company to administer their plan. Hospital and doctor charges need to be carefully monitored to make sure the city is not being overcharged, etc. As the PSC has proposed, these and other ways to save money should be carefully studied and would produce even more savings than adopting a Medicare Advantage plan run by a for-profit insurance company. Recent articles in the New York Times and elsewhere have exposed the money-grabbing behavior of such plans. Please do not throw us under the bus. Thank you.
Thank you so much. Carmen Olivares, if you're here and or virtual and on the Zoom, you can unmute yourself. If not, we'll move on to Jean Inauzi.
Can you hear me now? Hello?
Yeah, yes.
Hi. Thank you, Chairwoman De La Rosa, and thank you to the members of the council who have stuck it out as long as you have. My name is Jean Inauzi. I am a 71-year-old, recently retired registered nurse. I'm also a paramedic, and I concluded my city service as a college professor at the Borough of Manhattan Community College as the director of their paramedic program. 20 years of service in HHC and CUNY, and over 40 years in healthcare. Most of that was in emergency care. And because of all of that, I steadfastly oppose the proposed amendments to 12-126 and the coercive attempts to push retirees into Medicare Advantage plans. And I totally reject the testimony by the city administration this morning as absolute fiction and spin delivered by people who do not know the human costs of taking care of other people. On the other hand, since we really haven't heard from too many actual healthcare providers today, I note that the biggest proponents for privatizing retiree healthcare, with their army of lobbyists and blind followers, are a teacher, Michael Melgrew, a sanitation man, Harry Nespoli, and I'm not exactly sure what Henry Garrido does. Besides that, I doubt seriously if any of you would seek medical advice from a teacher, a sanitation man, or a bureaucrat, nor would you be comfortable with a doctor or nurse who never examined you, remotely reviewing, denying, or delaying care based on their employer's bottom line, as they absolutely would in Medicare Advantage
Your time has
and
expired.
all other private plans.
Thank
These
you.
are the ones who are telling you that everything is okay.
Thank you so much for your testimony today. Your time has elapsed. Thank you. We have someone who signed up by the name of Dulce, virtually. If you're on, you can unmute yourself. Apologize, we don't have a last name. If not, we'll move on to Stephanie Fine, Wilson Guzman, Carl Ailman, and David Himmelstein. Stephanie Fine, if you're on, you may begin. Wilson Guzman.
Good evening, Chair De La Rosa and members of the Civil Service and Labor Committee. My name is Wilson Guzman, and I am the Associate State Director for Community and Engagement at AARP New York. I am here on behalf of AARP New York's 750,000 New York City members to voice opposition to Intro 874, which seeks to amend the administrative code of the City of New York in relation to the health insurance coverage for city employees, city retirees, and their dependents. Retired city workers are the very people who built this city and made it great. They deserve what they were promised, and above all, they deserve the assurance of good health care in their later years. The city's Medicare Advantage scheme could instead saddle retirees with higher costs, smaller networks, and greater administrative obstacles to accessing health care and preferred doctors. A promise made should be a promise kept. These retirees were promised solid health plans at no cost, and that is what they should be guaranteed. No retiree should be forced to pay more to get the same coverage or to lose coverage they currently have. But this is even more than about what's fair and what's right. This is also about placing retirees under undue financial stress for the purposes of saving the city some money. Cost savings should not be brought to bear on the backs of retirees. For that, the city should look elsewhere. Last year, we released AARP New York's Blueprint for Action titled What New Yorkers 50 Plus Deserve, which is filled with recommendations to help city officials address vital issues facing older New York City residents. This blueprint lays out the financial hardships faced by our older residents. These hardships already impact housing and hunger. Let's not add healthcare to the mix by making it more expensive for retirees to see their doctors. A promise made should be a promise kept. That's what older adults deserve. If there's any change to retirees' health insurance, and again, any alternative plan must offer what retirees get now at the same no-cost basis. There must be an education effort to support retirees.
Your time has expired.
Them making a transition. So many things today are confusing enough. Let's not add health insurance transition to the list for our former city workers. Thank you.
Thank you so much. We're gonna go to an in-person panel to switch it up here. We have Ms. Gail Benjamin, Stephen Fisher, Wei Ning, Janice Dunham, and Robert Whalen. If you're here, please come over and identify yourself for the record. Since there's some room here, let's see, Teresa Roth, Deborah Royna, James Rossi, Zesley Blyden, you may begin when you're ready. Thank you.
It's on? Okay. Hi, my name is Stephen Fisher. I appreciate the opportunity to speak with you today on my opposition to amending City Administrative Code 12-126. I'm a 71-year-old City of New York retiree, and I'm a resident of Council District 3, Eric Botcher's district. My path to working in government started in 1972 when I was a college intern, and at that time I never thought that I would be sitting here 50 years later talking to you about preserving my health care. I retired in August of 2018 from the New York City Department of Social Services, the Human Resource Administration, as an Assistant Deputy Commissioner for the Office of Procedures. And in my first stint at HRA, I also was the Assistant Deputy Commissioner for the Division of AIDS Services, which you now know as HASA. So I've been around a long time. You have my written testimony. I'm not going to read from it. I just want to get some of the highlights. A lot of people today have given a lot of good information and food for thought. But what I want to leave you with is a couple of things. 2 courts and 6 justices have ruled that the city may not impose a premium to remain on GHI senior care and reject enrollment in the Advantage Plan. And let's be clear about this. This issue is before you because of the misuse of the Health Insurance Stabilization Fund by the Municipal Labor Committee that allowed the UFT to provide funds for raises for city teachers. This occurred, as has been discussed, because it was not monitored. One of the things that I would want to stress with you is to sit down with the New York City Organization of Public Service Retirees. They have outlined many cost savings that Marianne Pizzola mentioned that OMB was unaware of, and I think you need to look at that. Also, in listening to everyone today, one thing that struck me, a lot of these folks from the city and from the unions are not going to be around 5 or 10 years from now. So promises made today are not necessarily going to be promises tomorrow.
Thank you so much, Mr. Fisher. You may begin.
Okay, is it on? Hello? Yeah. Yes, on. Oh, okay. Madam Chair, I'm Della Rosa and members of the City of the Civil Service and Labor Committee. My name is Zesley Blyden, and I live in Council District 35. I'm a New York City municipal retiree from the Brooklyn Public Library with 32 years of service. Thank you for the opportunity to speak. It was always said, working for the city, the pay might be low, but the benefits are good. We are here today because the Municipal Labor Committee in the city want the City Council to change Administrative Code 12-126 that has been in existence since 1967. The code protects retirees and future retirees equally. I'm no longer a union member, but my benefits were earned and paid for. However, my former union, DC 37, seeks to take away my traditional Medicare care and have me pay for GHI senior care. This City Council and the Administrative Code is my only wall of protection as a retiree. The changes given for wanting these changes are, The reasons given for wanting these changes are, 1, amending the code will allow choice in the retirees' health plans, but we already have choices right now. The active employees have 11 choices, and the retirees has 14 health plans to choose from. Just stopping right there, just listening today to the MLC and the city this morning, and they kept on saying that they want to force us into Advantage Care to give us choice, but forcing us into Advantage Care is giving us no choice. 2, it would allow the MLC and the city the ability to offer pay-up options for retirees' senior care. When the Care Advantage plan was rolled out last year, I decided to opt out because MAP wasn't as good as traditional Medicare.
Thank you. If you could wrap up.
Oh, okay.
Thank
But
you.
to keep my medical plan, I would have to pay $191 monthly for GHI's senior care. Paying $191 monthly would have been a financial burden with my modest pension, and GHI only accounts for 20% of my medical expenses. 3, I'm almost finished. By transferring retirees into a medical advantage plan, it would help stop the depletion of the stabilization fund. Medicare Advantage plan versus traditional care. Medicare. Medicare Advantage is managed care by a for-profit corporation.
Thank you. We have your testimony and
You
we've
have
submitted it for the record.
Oh, all right.
If we could just keep going, because we still have hundreds of names on the list and we want to make sure we get to everyone tonight. Thank you so
Okay,
much.
sure.
Thank you. Ms. Benjamin.
Hi, my name is Gail Benjamin, and I was an active city employee for over 37 years. I volunteered as the chair of the no, that's not right, of the Charter Revision Commission for over 2 years, and I now work with a city agency. I would like to talk briefly, I'm watching the clock, about the actual amendment that's before you, because it's not a specific amendment. What it basically does is gives the municipal labor, MLC, and the city the ability to decide for the class of people. They don't say what they can decide. It just cedes to them this ability to take any class of employees, which could be active employees, and to make a decision for them as long as the MLC and the administration agree. So my first request is that if you are going to consider this, that you not adopt that language, which is basically a promise to consider something tomorrow that you will then have no control over. So if you decide that you are going to approve something and you think that's worthwhile, I think you need to amend the mayor's message and substitute language that is specific as to the authority that you wish to give up and how you wish to do that, and to whom. Secondly, just as a quick aside, when people have said earlier in the day that they did not understand why there was distrust of Medicare Advantage, and I would say quite simply, when something sounds too good to be true, it generally is. And if Medicare has problems meeting its bills, which it does, how is a for-profit company that is going to get the same amount going to manage it such that they can make a profit on the money that Medicare could not manage to run the agency? The only way people think they can do that is if they are either limiting the administrative functions, which means delays in paying out money one way or another, or obstacles to consumers who are trying to access their benefits, or a reduction of benefits. That is why people are suspicious of what the Medicare Advantage plan offers. And last but not least, 65,000 employees opted out of the Alliance plan. They downplayed it, but that's more than a fifth of the retirees decided that it did not offer them anything. Part of the issue I think you should be asking is, are they guaranteeing Aetna a minimum enrollment? Part of the reason Alliance said that they were opting out of continuing with the contract was because of the low levels of enrollment. It is my understanding that the enrollment levels are vital to how this program, the Medicare Advantage program, works. So,
thank you so much for your thoughtful comments. Thank you.
I'm Teresa Roth, and I worked I retired from the retirement system. My name is Teresa Roth, and I retired from the Teachers Retirement System, TRS. The majority of my service was as a supervising investment analyst of the pension fund. I am a constituent of Councilman Eric Botch's District 3. I seem to have outstayed him. I am here in opposition to amend Section 12-126. I joined the city 25 years ago specifically for the city's benefits and pension, instead of continuing my career with Wall Street firms at higher salaries. So strong was my belief in the civil service system that I served as a term as an executive board member for DC 37 Local 1407. Giuliani sent us back to work after 9/11 on the infamous Christy Todd Whitman Day to 220 Church Street with minimal electricity, no air conditioning, windows wide open, and I had a smoldering car under my window. I have thyroid cancer, which was removed, malignant, and now I have malignant neuroendocrine tumors. Switching to this plan, the plan will kill me sooner than I'm supposed to die. I urge the City Council not to amend this. Thank you.
Thank you so much. Thank you all for your thoughtful comments. I just want to say quickly, I know a few people have mentioned it. Although you may not see many council members present, our deputy speaker is here, we have Council Member Dinowitz here, and members are watching both virtually and live. And, you know, there will be robust discussion. This is the first hearing, and, you know, this is part of the process. Don't feel as though we're not listening. We're here, I am here, and our deputy speaker is here, Dinowitz is here, and all are watching and paying close attention. So I just want you to know that your comments are not going into the Ethernet. We're listening, okay? Okay. Is Carl Ailman here or David Himmelstein? Virtual. Carl Ailman and David Himmelstein.
This is David Himmelstein. I'm here.
Oh, thank you, Mr. Himmelstein. You may begin when you're ready.
Thank you, Dr. Himmelstein. I'm a primary care physician, a distinguished professor of public health and health policy at Hunter College, and a lecturer in medicine at Harvard Medical School, where I spent more than 30 years on the faculty. I want to just comment on the rapacious and disgraceful conduct of the Medicare Advantage programs and the lies about it that have been put forward in this hearing by representatives of the city and of the unions advocating for it. The Medicare Advantage programs make enormous amounts of money at public expense by denying care. That's not just anecdotes, there's hard evidence of that. Aetna alone has paid $265 million to its CEOs over just the last decade. It takes 17% of every healthcare dollar it receives for its profits and overhead. And to put that into perspective, the average Medicare patient brings $2,200 in overhead and profit each year to its Medicare Advantage plans. And the way they make that money is by denying needed care to patients and hassling doctors. So earlier, folks said, oh, why would doctors not join this plan? But in fact, doctors often refuse, and despite the lies about networks, in fact, when you ask doctors whether they participate in managed care plans, only about 18% of all psychiatrists, 40% of cardiologists, and 60% of primary care doctors actually participate in managed care plans, despite managed care plans often claiming high membership. We have recent, just this year, strong evidence of the poor quality.
Your time has expired.
Medicare plans are delivering. Mortality rates for cancer patients, 90% higher in Medicare Advantage for pancreatic cancer, 40% higher for liver cancer, 40% higher for stomach cancer, and refusal of expensive diabetic drugs
Please wrap
by
up.
Medicare Advantage plans. Thank you for your attention.
Thank you so much. Thank you. On virtual, we have Jacqueline Shuhas Barnett. If you're on, you may begin.
Hello, hi, can you hear me? Yes.
We hear you.
Hi, my name is Jacqueline Schoenhaus Barnett, and I'm a retired bilingual school psychologist for the New York City Department of Education. In July 2021, the MLC made an announcement that it will be switching all city retirees to a Medicare Advantage plan by January 2022. Unbeknownst to the majority of the 250,000 people who would be impacted by this decision. At that time, we were assured by the MLC that we would be able to keep all of our doctors and receive exactly the same health care we enjoyed under regular Medicare. Bingo, everyone proceeded to call their doctors, and of course we were told they never heard of the Medicare Advantage plan. Those verbal promises made to city retirees were clearly duplicitous fabrications, not based on reality. And guess what? We are hearing the same promises today. What this really means is that if we wish to keep our regular doctors and senior care, we would have to pay a premium of $191 per month, which would create a two-tier system, or be switched to a MAP and be burdened with pre-authorizations and bureaucratically encumbered paperwork, often involving reimbursements after treatment. At that time, no one really knew about the protections of the City Code 12126 until the retirees won the court cases and learned about its provision that 100% of the full health care insurance costs are to be paid by the city. After the court cases and the disappearance of Alliance as a senior care provider, our UFT union leader declared that they would only sign on to a plan which was tailored exactly to the needs of his constituency. This was obviously in retrospect, since initially he enthusiastically supported the switching of all city retirees into a half-baked advantage plan that the courts found irrevocably flawed in its implementation. So now I'm wondering about how the ironclad checks and balances that he's promising in an infrastructure, how is he going to afford to pay people to assure this quality health care they're promising us?
Thank you, Ms. Barnett. We have to wrap up. Thank you so much. Okay, we have Lena Haber, Robin Weiner, and Carol Anshine. Virtual, Lena Haber, Robin Weiner, we see you, we hear you, you can begin.
Okay, hi. Thank you for everybody's attention to this very, very long day. I want to thank the councils for its attention and congratulate the retiree organization on its beautiful presentation. I ask the council to please don't delegate your authority and your legislative powers to the union and to the city. It's simply not necessary. The Scheinman document is not worth the payment. The paper it is written upon is not binding upon a legislature. You are a legislature. You have the power, and I trust that you're going to exercise it very responsibly. And I just want to thank you for your very kind and very kind attention.
Thank you so much, Ms. Weiner. Carol Anshine, if you're here, you may begin.
Hi, can you hear me?
Yes, we can.
Okay, great, thank you. Hi. I had on my paper here, good day, but now it's good evening. And good evening to you and your perseverance Ms. De La Rosa. My name is Carol Anshine. I'm retired 16 years from the New York Public Library. Oh, whoops, I meant to put on my video. There we go. Retired 16 years from the New York Public Library, where I worked for over 29 years. I was also active in my union, DC 37's Local 1930. I'm here today to ask that you not support the amendments to the proposed amendment changes to Administrative Code 126 now. I heard what Marianne said earlier, and maybe there'll be another time to possibly do those changes, but not now. The cost would be very prohibitive to many retirees who are currently on low fixed incomes, and also take away the ability of retirees to litigate. I do not want to be in a Medicare Advantage plan and didn't with the first effort to do this. I fear it will not cover all my healthcare needs, as others have said. I've been satisfied with the coverage provided by traditional Medicare and by Empire Blue Cross Supplemental, which I am one who pays for, and everyone keeps talking about senior care, but there are other plans, and I'm happy with that one. I do not have copays. I am worried not only that it might become unaffordable, but also scared that I will no longer have the plan of my choice. I am a multiple cancer survivor over 25 years and continue to receive excellent preventative treatment and care from Memorial Sloan Kettering. The increased cost for basic healthcare services should not be coming out of the pockets of retirees. This additional stress on our aging bodies and minds is unconscionable. We earn the right.
Thank you. Your time has
with years of
expired.
Service and low salaries to continue to receive quality health care with choices in our health care insurance and traditional Medicare benefits promised. The mayor and the union should not be using us as pawns in their negotiations for current worker contracts.
Thank you,
There's a
Ms.
history-
Sunshine. Thank you. Your time has expired. Thank you so much.
All right, do you want to jump to
Person?
in person?
Yeah.
Give me a second and we can.
All right, we're gonna go back to in person for a little while. Bennett Fisher, if you're here. Antonia Manuela, if you're here. And Karen Anderson, you may step up to the dais.
And then we have more in person here.
Let me call Deborah Polshak, Deidre Burke, Trudy Silver, Evelyn David. Any of those folks in here? One more? Okay, one more. Let's see. Glorianne Kirstein, if you're here. Okay, you may begin. We can go down the line. Identify yourself so that we can track it here in the system. Thank you so much, and thank you for your patience.
Okay. Good evening, Madam Chair Carmen de la Rosa and council members. I stayed to speak to the moral issue. Firstly, I wish you all a healthy new year, for health, as we all know, is everything. My name is Antonia Esperanza Manuela, and I am a proud member of DC 37 Retirees Association. I am a retired and former employee of the New York City Housing Authority. But I am also included in the demographics of Black and brown elders on fixed incomes, elders on small pensions, elders with heart disease, and other multiple medical issues whose society has historically and disproportionately subjected to and still attempts to subject to inferior medical care. My body and all of our bodies cannot afford poor health care by poorly administered private health care insurance. And that is what will happen to all of us, to all of you, to all of us. If Administrative Code 12-126 is amended. I have been outside of your gates with my fellow activists, unions, organizations for 3 years in 90 and 20-degree weather, begging for the health care security of traditional Medicare to remain unchanged. And now I've come inside to wait and to beg you for the health care security of Administrative Code 12-126 to remain unchanged. I'm not ashamed. I beg you, do not change Administrative Code 12-126. Thank you.
Thank you. Thank you so much. You may go ahead, sir. Thank you.
Hello, I'm Bennett Fisher, and I'm a retired teacher with 29 years of service in our public schools, and I am a career-long UFT activist who is very distraught and very angry at the harmful position my union leadership is taking. All of us here are public service employees. On whichever city health plan we are enrolled in, the cost of that plan is protected by a defined price threshold set in a city law. If your insurance costs less than the threshold, you're covered. If it's more than the threshold, you pay up. That's fair. The law applies equally to all city employees. It ensures a decent and equal subsidy for the city health plan we choose, and it lets the most vulnerable among us stay on traditional public Medicare and doesn't coerce anyone into the private, regional, for-profit Medicare Advantage ecosystem. Why would the City Council ever even consider taking our health care protections, the people's protection, out of the law and putting it into the hands of a few, very fallible, very self-interested group of politicians? New York City mayors come and go. Union presidents come and go. The law offers us the stability that we need. Keeping 12-126 intact doesn't mean we can't negotiate for quality health care and savings. But amending 12-26 the way it's written here means we will be at the mercy of a few men in a room. I thought we were beyond those days. We dedicate our careers to public service, not for great pay, but to do good for our communities and our families. What we sacrifice in pay, we expect to make up in decent, stable benefits, both in service and in retirement. Don't give away our legal protections. What we give up in law, we will never get back.
Thank you so much.
Am I on? Yes.
You're on.
Hi. Good evening, Honorable Chair De La Rosa. Thank you very much. And all honorable City Council members who are here and are listening and are partaking in this. I know it's been a really long day and I'm a little woozy actually, but okay, so anyway, thank you for this opportunity to allow me to voice my request actually in favor of amending New York City Code 12126, and I'll explain because it's a really big issue here, back and forth. If you add a clause that reaffirms the Municipal Labor Committee's bargaining rights to negotiate retiree health care and enable the city to continue offering retirees the options of pay-up health care plans, and it guarantees the unions and the council's bargaining rights and rights to arbitration, which are contractual and protected by the state constitution. It's what this gentleman said is amend the amendment, in other words, right? If you have, and if there's an opportunity for that. Again, by amending New York City Administrative Code 12-126, you need to guarantee, uphold, and affirm the council's rights and the union's rights to bargaining and arbitration for health care coverage and choice. Whatever you decide, please vote to uphold and reaffirm those contractual rights. Thank you.
Thank you.
Yeah.
I'm Gloria Ann Kirstein. I'm a 74-year-old retiree from HPD and a member of the DC 37 Retirees Association. I'm also chair of the HDFC Coalition Anti-Foreclosure Committee, but I'm here today to testify on a personal basis. Being a retiree whose two main doctors have said, we will not accept a privatized Medicare plan, including a specialist I've been seeing for 27 years. So I don't know how to replace something like that. I do not understand that the current law forbids unions their collective bargaining power, but that's one of the problems we've had during today's testimony, is that there's a lot of conflictual information. And the problem is that the city council, you who have given us, retirees who heretofore had no voice, the first forum where we can discuss these issues, you have not been given adequate data. You've not been given adequate research or study. You don't even know what the contract would look like. You're in the dark, as we have been since 2014, when MLC and the city and de Blasio and everybody were making all these plans for those of us most affected without a voice. Look, the 250,000 who we are, we, if all together, would be the third largest city in the entire state. We'd be bigger than Rochester, but we didn't get to vote for the mayor or the council or the health plan. You are providing us for the first time with that opportunity. So what I would encourage this council to do is continue the collaboration, continue to collaborate with the retirees and those most who have a lot to lose. True justice requires that voices heretofore that were silent be heard. True democracy requires time, and important legal decisions require data and research, which you and we deserve.
Thank you so much for all of your comments and all of your opinions. I just want to reemphasize, this is the first hearing. We're not taking a vote yet. The council will deliberate on this and decide the path forward. So thank you so much, and thank you for your patience. We have Penny Mintz, Kathleen Cahill, Michelle Ravid. And Gerard Longarzo. If you're here, you may come up. How many are? Okay. Norman Scott. If you're here, come up. I'll call one more. Oh, this one already went. The Citria Vincent.
She did, okay, thanks.
Yeah.
There might be some
John Halen. Santos Crespo. Okay. And when you're ready, you may begin. Thank you for waiting.
I can start. Good evening, and thank you for holding this hearing and allowing us to speak. My name is Michelle Ravid. I'm a retired educator and a member of the UFT. I'm here today to urge City Council to vote no to amending Administrative Code 12-126. This law has equally protected the health care of municipal workers since 1967. It's the only health care protection that retirees have. If the city forces us into a Medicare Advantage plan, retirees will indeed have legal recourse to challenge this action in court. And they'll certainly win. But however, once this code is amended, legal action will be difficult. I personally worked for the City of New York for nearly 40 years with the understanding that I'd be entitled to traditional Medicare once I retired and turned 65, and that the city would bear the cost of my Medigap plan, less than 20% of my total health care costs. Now the city wants to renege on that promise. However, a promise is a promise. Why should more than 200,000 retirees like myself be coerced into abandoning our excellent health coverage for a substandard Medicare Advantage plan valued at about $7.50 a month because of a misused health insurance stabilization fund that was supposed to be there for medical and health needs, but was used for purposes other than the health care of its workers. The city presently has $8.3 billion in reserves, the highest level in its history, and it has $4.5 billion in its retiree health benefit trust fund, which supports health care benefit obligations to retirees. Surely this $4.5 billion can be used to help finance the Municipal Labor Stabilization Fund with the help of the Controller. I'm calling on you, City Council members, to use your voice to stand up and protect those disenfranchised retirees who have no voice. Let your voice speak for them. Vote no to any changes. Don't let the fate of more than 200,000 retirees be decided by 3 labor leaders and a mayor who all refused to sit down with retirees to explore any other cost-saving options.
Thank you.
A promise is a promise. Do the right thing.
Thank you so much.
Thank you.
We can go down the line, I guess. Ladies first, you can go ahead. And we got the gentleman. Oh, can you press the button? Thank you.
Good evening, and thank you for this opportunity. My name is Kathleen Cahill, and I retired in 2004 after working at the New York City Office of the Corporation Counsel as an attorney, where I spent most of my career. I'm in my 80th year, and I am now in the winter of my life, facing the following fearful, stressful, anxiety-producing situation. Approximately 1 year ago, I was told that my osteoporosis has accelerated and my bones are rapidly disintegrating. I found a renowned endocrinologist at Columbia University. I applied to be one of his patients because he only accepts very challenging, serious cases. I was accepted by him as a patient, and I'm now getting 2 injections a year of medicine. When I was at my last appointment getting my second shot, the doctor's assistant told me that all of their Medicare Advantage patients have been denied the use of this medication. This is such a harrowing story because these patients are desperately in need of this medication. This is the same insurance plan that New York City wants its retirees to have: privatized, profit-seeking plans that can deny what doctors deem necessary for their patients. Please show your empathy, step into our shoes, and deny any alteration to Section 12-126. You know that Mr. Scheinman has no jurisdiction over city council nor the retirees. Please protect us who are so vulnerable in the winter of our lives from losing our health care and being in financial peril.
Thank you so much. Thank you for your thoughtful comments. Thank you.
Thank you.
My name is Gerard A. Longarzo, Department of Education, 41 years service. Councilmember Dinowitz, Woodlawn says hello. Delay treatment, deny treatment. This is the way for-profit Medicare Advantage plans operate. It's the way they pump up their bottom line at the expense of the people they cover. It's not just me who's saying it. It's the investigators from the federal government. As per the New York Times, December 3rd, 2022, I quote, Medicare Advantage plans often deny needed care. A federal report finds insurers deny tens of thousands of authorization requests annually. The change of Administrative Code 12-126 is a giant step, but in the wrong direction, because it would be a giant step toward inflicting vastly inferior health care coverage upon retirees, individuals who dedicated decades of their lives in service to the city of New York. Shameful. Vergüenza. Why are we in this mess? Was the Stabilization Fund a fund that was to be dedicated to the healthcare needs of all city unions? Was that used improperly? Were funds from this fund taken out in order to cover a raise for the UFT? Is that simple mismanagement? Who orchestrated that, Mr. Muldrew? Let's mention Harry Nispoli, chairman of the Municipal Labor Committee. He refers to retirees as rump retirees. Shameful disrespect. Remember, Medicare Advantage care plans delay treatment, deny treatment. My wife of 46 years was diagnosed with triple-negative breast cancer. In the absence of rapid access to advanced medical care, she would be dead. Me, I was diagnosed with numerous tears in the retinas of my eyes. In the absence of rapid access to advanced medical care, I would be blind. The loss of rapid access to advanced medical care is not acceptable. In conclusion, we, New York City retirees, are not a throwaway card. And Harry Nispoli, we are not rump retirees. Hands off our Medicare. Don't buy the lie.
Thank you. Thank you.
Thank you, Madam Chair and the City Council for allowing me this opportunity to speak to you. My name is Santos Crespo. I'm the former president of Local 372, the largest local at DC 37, and I'm also a former vice president of District Council 37. When I was discharged from the Navy back in 1973, I was hired by then the Board of Education as an addiction service counselor. We were not unionized at that time. And in 1975, when we finally decided to join DC 37, it was with that promise that at the end of our tenure, we would have not only a pension, but we would have a good health care benefit. What's happened? What, in fact, has happened? For some reason, the MOC wants to say that we are afraid of change. We're not afraid of change. We want to be part of the process. When we approached them to be part of that process, their response to us was, how dare you want to speak to us? You don't trust us? Well, the reality is no, we don't, because you have not been transparent. Now, I was born in East Harlem. I was raised in the Bronx, and for the last 20-plus years, I reside in East New York, Brooklyn. So when you want to talk about trust, those are my credentials. If you cannot answer my questions because you don't have the answers, don't tell me about trust. Thank you.
Thank you so much. Thank you all for your testimony and your thoughts today. Up next, we have Mark Kagan, Dr. Mary Lutz. Kagan spoke, okay. Anthony Amato. Naomi Harris, Joseph Faramasco, Joseph Faramasco, Douglas Hantush, Aria Mangal, Aurea, sorry. She's not. Neil Frumpkin. Joyce Cheddick Wilcox. Joyce. Logan Clark. Abigail Martin. Judith Fox Miller. Marilyn Copa, Michelle Russell, maybe? Yeah, Russins, John Mudd, Andrew Ellen, Rosie Bartolrella, Susan Caspian, Philip Seals, Seelig, maybe? Philip Seelig?
Yes. I like on the board.
No. Judy Arnow. Come on up, Judy. Oliver Fine. Oliver Fine. Neem Elperstein. All right, we have a few. Susan Petito. All right, I think we have 4. You may begin, sir, when you're ready. While your colleagues sit, you may begin. Oh, can you press the button? Thank you. Thank you so much.
Thank you. I am female.
I am so sorry. I am so sorry.
I have a point of order question.
Yes.
Will you be voting tonight, or can you anticipate a vote?
We are not voting tonight. For the record, this is the first hearing. We have not scheduled a vote yet. So after this hearing, the city council will deliberate amongst ourselves what the next steps are. And I apologize for misgendering you. You may go forward.
Thank you. And good evening to all of you who are here, both online and in person. I'm a constituent of Council Member Rita Joseph and a proud member of my union, PSC CUNY. I am 73 years old and served City College for 34 years before retiring during the pandemic. Throughout my service, both myself and my husband receive health insurance coverage through my union, the Professional Staff Congress, under its contract with New York City. Now we are both dependent upon and very satisfied with Medicare and our current retiree health benefits through the union. I am one of the many that you've heard today who are vulnerable retirees who have a target on our back put there by Aetna, hoping that we'll die during the next 5 years. I have multiple pre-existing conditions, including cancer, diabetes, and asthma, for which I receive excellent treatments and prescriptions covered by these benefits. It has not been easy to enroll with multiple providers who accept my insurance. If you and your council colleagues disrupt the current arrangement previously negotiated and still under contract, you will undoubtedly shorten my life and the lives of other retirees. You are accountable to us and to our survivors. We strongly oppose any administrative codes that weaken our benefits and gut our health insurance lifeline. Please help take that target from Aetna off our backs. Please vote no on any administrative code changes. Thank you.
Thank you so much.
Hi, my name is Judy Arnow, and I'm a retiree. I retired in 2009 from the city, and I am on original Medicare for a long time, and it's great. I'm going to tell you a brief story about why we need it and give you a window into why NYC retirees are up in arms about this threat to our original Medicare. I'm 75 years old, and I've had health issues over the last 20+ years, including spinal stenosis, osteoporosis, bone fractures, as well as other typical aging issues. I don't tend to talk about my other medical issues, and no one besides myself and my doctor needs to know what they are. Because of modern medicine, I can continue to live a pretty active life, walking, exercising, climbing steps, hiking around town and in the country. My life is better than I would have expected at this age, and I'm optimistic for the future. But not quite a year ago, I tripped on the sidewalk in my neighborhood. Afterwards, I found it was a struggle just to get my body out of bed, never mind be walking out indoors or outdoors, since I had pain whenever I moved. I live on the 3rd floor of a building with no elevator, so if my bone did not heal appropriately, I would have to move from my apartment of 26 years. An X-ray showed nothing, but my pain continued, and I did not seem to be on the mend. I wondered, would I ever be able to walk normally again? I spoke to my doc, who said he was concerned about my lack of progress and that I needed an MRI to diagnose the problem. and determine how to treat it. I was able to schedule and get the MRI done quickly, and afterwards I was told I had a fracture of my sacrum. I was told to be careful because if I fall, I could easily break those bones again. But I was lucky to get a diagnosis quickly. I later spoke to a friend who was on Medicare quote-unquote Advantage, who said her doctor has been trying for years to get her an MRI, but has been unable to get approval from the private for-profit insurer. This is why some people call out Medicare Advantage as the double D plan, delay and deny.
Thank you. Thank you for your testimony today.
One more sentence.
Go ahead.
So when someone tells you they want to keep their original Medicare, you can understand why they are so adamant and so willing to make phone calls and write letters to their council person to fight this good fight. Thank you.
Thank you so much.
Good evening, Madam Chair. I'm Susan Petito, lifelong city resident from Chelsea. I served for 33 years as an attorney with the police department, retiring in 2015 as Assistant Deputy Commissioner, Legislative Affairs. I chose to work very hard for a very long time, notwithstanding the possible rewards of private or corporate legal practice over those many years. I am therefore appalled that the city has broken my trust. You know about the inherent flaws and rampant fraud associated with Medicare Advantage plans. You also know about the misrepresentations which the city and the MLC promulgated in order to convince retirees that their new, specially designed Medicare Advantage plan would provide better health coverage for them. That was completely untrue and reflects the fact that retirees were never consulted. The city's unions do not represent retirees and sold them out without hesitation. I'm lucky. I can afford to pay for good Medigap coverage. Many city retirees are not so lucky. But there is also a dirty little secret embedded in this controversy. The city's plan will likely have a racially disparate impact. Based on the city's employment patterns and history, retirees who earned lower salaries and receive lower pension payments will more likely be people of color. They will be less financially able to choose to opt out and will suffer the consequences. This is an unacceptable result. The city and MLC are trying to entangle you in their scheme. They say it's about protecting retiree choice, when in fact they want you to provide a fig leaf for their illegal intentions. If they decide to force all retirees into a Medicare Advantage plan, let it be on their heads, without your help. The city and its unions can find more responsible ways to address spiraling health care costs without scapegoating retirees. They should bring the retirees into the conversation and see what happens. City employees rely upon the promise of Section 12126. For many employees, this is an important element of their decision to enter and remain in city service. I know it was for me.
Thank you.
Our lives were devoted to making the city work, and our future health care should be a promise kept rather than destroyed.
Thank you so much. Thank you.
Thank you.
Thank you for your perseverance. You have stood the day.
Thank you. Make sure that the button's pressed. There you go.
Okay.
All right, there you go.
My name is Nemi Alperstein. 28 years as a teacher for the New York City Department of Ed, UFT member, proud union member until this whole debacle evolved. I will tell you that I have a lot of family members in healthcare, and the rule of thumb was nobody goes into Medicare Advantage. Now, the other piece is a CEO getting $27+ million a year while saving costs for retirees. There's only one way to do it: cut services, cut testing. I even had a family member who was a doctor. He was in a Medicare Advantage plan or some such, it might have been HIP, and he was told not to order the tests. He lasted 2 days, stood up, shook everybody's hand, and left. He said, "This is not the way to practice medicine." We have heard that the hospitals agreed to take MAP. Well, that's the trick. They may take it, but when you show up, does your doctor? Chances are your doctor does not. Now what if you have a serious condition? Now, to put us on Medicare Advantage, that's a ploy for profit, and it's on the backs of retirees. My question is, every time the city doesn't want to make good on a contract, are they going to come to you and say, could you change the law? Could you change and amend the regulations? I don't think they should burden with that. You should be burdened with that. City Council has a lot of bright people on it. I have seen all day. You guys are bright. And my question is, failure is not an option. To think outside the box, we have cell phones, we have computers, we do SpaceX, we do NASA. Don't tell me there's no option. Find it with us. I know it can be done. If the mayor can't, I'm so sorry. I know my city council can. And I hope that you will vote not to amend 12126 so we can find savings instead of diminishing care. Thank you for your perseverance. You are awesome for doing that.
Thank you. Thank you for your patience, and thank you for your testimony tonight. Up next, we have Bill Schillinger, Bonnie Nelson, Susan Herzog, and Jacqueline Frazier, and William Russo.
We have a stack. If you want to avoid calling them because they'll scan them into the record, you could just ask if there's anyone else who filled out a slip to testify but has not been called yet. Okay. And they can raise it.
I think we're going to need an extra chair. I think we need an extra chair, Mr. Russo. And you may begin when you're ready.
Check 1, 2. Yeah. Good evening. My name is William J. Schillinger. I'm a retired FDNY lieutenant. For the past 20 years, I've been retired. And during those 20 years, I've enjoyed the best health care that is guaranteed to me because of 12-126 of the New York City Administrative Code. My pension is guaranteed by the New York State Constitution. My health care benefits come under the New York City Administrative Code 12-126, which has been in force since 1967. During the last 20 years, 17 of which were in Medicare, I've had multiple surgeries. I've been treated by neurologist Dr. Ira Cason for 2 concussions, which I suffered on the job. I'm under his care for cognitive issues. He's now the senior advisor for the NFL on concussion syndrome. I'm also under the care of Dr. Abrams at Columbia Presbyterian for precancerous lesions in my esophagus. He's the senior specialist at Columbia Presbyterian for upper disease in the esophagus. During this time, I never had to worry about my health care, not have to worry about premiums, pre-certification, prior authorizations, or even denials of care. If you amend this law, 12-126, that may all change. There's nothing more retirees worry about than losing their health care benefits. By amending this law, this code, 12-126, which has been in force since 1967, would be a disaster. I'm sure there are people in this room who can come up with a plan to save the city money. Put your heads together. Have some cooperation with all the unions. Don't balance the budgets on the backs of the retirees. If this goes to a vote, please vote no. I hope it doesn't get that far. Thank you.
Thank you so much.
Hello, my name is Susan Herzog. I live in the West Village. Eric Butch is my representative, but he's not here. But I thank you very much for sticking it out. And I guess a shout out to Councilman Dinowitz, who came back and is still here. I'm a retired science teacher. I love teaching. I always supported the UFT, and I'm devastated that my union would sell away its members' hard-earned retirement benefits and then resort to telling lies when the plan was judged illegal, like this lie that they keep repeating and repeating, that the judge ruled that there could only be one plan. I'm retired, I have enough time to read, and I've read that, his judgment, and he did not say that. When the city first attempted to force us into the plan, I discovered that some of my doctors, one of whom literally saved my life, would not participate in a Medicare Advantage plan, as you've heard many people say. Even though that company at that time claimed that he was in network, which was a lie. They lied to us, and I don't expect they would not continue to do so. I pay for Medicare monthly and for my drug insurance. The city only pays for a supplement policy that covers 20% of the cost that Medicare doesn't cover, and Medicare's rates are controlled, so they're not the ones who are raising the cost of Medicare, of medical care. Why, after more than 50 years, is this unbearable burden on the city? Why is this now an unbearable burden on the city? Apparently, because the MLC made a bad deal that now requires us retirees to pay for. Because the court said that the protections of 12-126 made the deal illegal, they need to amend it to create a class of municipal employees. For now, this class would only be us, Medicare eligible retirees. Do you really want to undermine the only legal protection all municipal employees have for their health care? The city and MLC want you, the city council, to take the blame for doing this to us. We have confidence that you won't do that, that you'll be our heroes and vote no.
Thank you so much.
Good evening, and thank you for giving me the opportunity to speak to you today. My name is Bonnie Nelson. I'm a retiree from John Jay College of the City University of New York, where I worked 37 years as a librarian. I'm also secretary of the Retirees Chapter of the Professional Staff Congress. I'm asking you to vote against changing Administrative Code 12-126. Changing the code will allow the city to move 250,000 elderly city retirees into an inferior Medicare Advantage plan while allowing those retirees who can afford it to pay $2,400 a year to keep the Medicare supplemental plan we currently have. I'm asking that instead of changing the administrative code, you urge the city and the MLC to take another path, to buy time to find a better solution by adopting the plan the PSC has proposed, using money in the Retiree Benefits Trust Fund for a few years as a bridge, while a stakeholders committee tries to come up with better long-term solutions. Changing the code and forcing retirees into private Medicare Advantage to save $600 million a year does not solve the long-term problem. It buys at most a few years before other cuts will need to be made. Since the first healthcare savings agreement in 2014, city workers and retirees have seen increasing copays, reduced doctor networks, and now an attempt to degrade retirees' health care. Meanwhile, the CEO of Aetna made $24 million in 2020, the CEO of New York Presbyterian makes $9 million a year, and the CEO of Mount Sinai is paid $5.5 million a year. But city workers can't get a raise unless they accept reduced health insurance benefits. There's something gravely broken here, and forcing elderly, infirm retirees into an inferior health plan is not going to fix it. Every single retiree who spoke today spoke in favor of keeping senior care, including those from the UFT who asked you to change 12-126. That's because traditional Medicare is better for everyone, not just those who can afford to pay $200 a month.
Thank you so much. Can you press the button? Thank you.
Good evening. My name is Jacqueline Frazier. I'm a retiree. I've been working for the city for 34 years. My concern, as of everyone else here at the retirees, is my health. A lot of people say, okay, so what about your health? I was diagnosed with what they call Sjogren's syndrome a few years ago, which is a rare disease, and it's an autoimmune deficiency disease. What happened is the body immune system attacks these healthy cells that produces the saliva and the tear glands. this is, like I say, this is a rare disease, and this is something that I'm going back and forth to the doctor for at Mount Sinai, and I'm under what they consider a specialist program. Now, if this program is taken away from me, I don't know what I'm going to do, because as of yet, and I was just told again last year, the latter part of last year, they still have not came up with a prognosis of this disease, because it's still like pretty much fairly new to them. Mount Sinai, which is undergoing the studies, they have asked me, you know, in the process of doing so, you know, like later on, would I be willing to be one of, you know, the testants, you know, to do the studies or whatever it is they have to do. I have to think about this because I don't know what the plans are for this 12-126, you know, I mean, if they change it. I don't want any change, because as of right now, I can only speak for myself. I know my health is more important to me than, you know, everything else that, you know, that's been said and done. And also, I'm an asthmatic, and of those that know about asthmatic, you can catch an attack from different things such as dust, colognes, or anything of that sort. And if you don't have that medication to, you know, to stop it right then and there, you can go into cardiac arrest. And a lot of my family members and coworkers have died. Just recently, last year, I lost 4 relatives to asthma. So I'm not going to be a statistic in this matter. Thank you.
Thank you so much. Thank you.
And I just want to add one more thing. With this disease also, it has caused my teeth to deteriorate. So now I cannot smile, you know, and how to say, put on a pretty smile? No, because it deteriorated my teeth. It's like brittle. I look like a piranha, okay? You know, I mean, I'm making a joke of it, you know, because I have to keep my, you know, sense of sanity going. But thank you.
You are very beautiful, and we all acknowledge that, okay?
Thank you.
Thank you. Thank you for coming, and thank you all for your testimony. Yeah, you can go ahead. And I have Marilyn Yogit Downey as well. If you are here present and your name has not been called, please see the Sergeant at Arms. Instead of reading through everybody, we're gonna just ask you if you're in the room to come forward. You may begin when you're ready.
Go ahead. I'm not a lady.
Folks, once again, everyone that's in the room has spoken, correct? That has signed up? Perfect.
Okay, you may start when you're ready.
I'm ready, but I just want to say that for these to be hearings, as a teacher for 26 years before I retired from high school at City Ave School, if somebody was having a hearing, if I didn't trust anybody was listening to me if I couldn't look them in the eye in the class. And for you to have hearings and listen to the people who are coming in with this plan, and then go to dinner when it's time to listen to all these incredible voices, I think it's really an insult to us. And I suggest you have lunch breaks or dinner breaks when you get hungry, because we get hungry too. And that way there'd really be hearings, because this material that you've heard, have not heard today, is invaluable. And I don't think they'll get it otherwise. Yes, I'm a retired teacher, and I wanted to say also about the presentations. I wouldn't have accepted the testimony of the people who came before you for the administration this morning. They had no data. They kept scrambling around trying to find the data in their books. Oh, we'll get this for you sometime. Oh, we don't have that. Oh, sorry, we don't know this. It was an embarrassment. I would have thought they'd say, sorry, maybe we better come back another day. But they just kept going. And in the end, they didn't have even the document that they're asking you to approve. It was a sham, and I'm surprised they went that far as to be so bad. And I hope you genuinely reject them. On why Aetna wants to do this, yeah, it's for the profits. And how do they do that? My doctor refuses to work for Aetna. And the reason he says is because one of the ways they make profits is by making sure you don't spend very much time with each patient. And if you spend more than 15 to 20 minutes with a patient, you have to fill out lots of paperwork. And that means that doctors really don't have a chance to get to know you, and even if they know you, they don't have a chance to really check in with you because doctors need the time they think they need. And Aetna doesn't want you to do that. The other thing I want to say is accountability. They say, this morning the speaker said, oh yes, we'll go to the MLC. We'll always have account. The MLC, as other speakers have said, is not democratic. Not only is it the UFT and the DC 37 officials, the ones who control the vote, even though there are over 100 unions in the MLC, they have really no voice. And by the same token, teachers in the UFT don't have a voice either.
Thank you.
We didn't know about this except by it had been there for years until PSC told us about it.
Thank you.
I just have one last point to make, and that is the New York State Health Care Act was up at the legislature. UFT officials opposed that, claiming we had a better plan, while they were opposing that and going to impose this on us, so that we could tax the rich and have health care, Medicare for all. That's an answer they didn't even think of bring up this morning.
Thank you, thank you. I actually agree with your last point, but thank you. Go ahead.
Does this work?
Yes, and introduce yourself so we can track you here
Yes,
in the system.
hello. My name is Suzanne Kanabi. I'm a retired New York City teacher and UFT member. At this time, my husband is very ill. My primary health insurance is Medicare A and B, and my secondary is GHI. I do not support amending Admin Code 12-126 for the following reasons. The code was enacted over 50 years ago to protect and guarantee city retirees and their families, as well as the long-term health insurance benefits of active New York City municipal workers. The city pays the entire cost of health insurance coverage for city employees and their dependents incommensurate to the HIP HMO rate. Admin Code 12-126 offers equality and choice in our health care for all municipal workers. We are offered a wide variety of plans: GHI, Cigna, Empire, HIP, Humana, Aetna, and Medicare. The code also pays for a welfare fund. Why did the city, OLR, and some unions propose to amend Admin Code 12-126? The money that was allocated in the stabilization fund for our health insurance was spent on teachers' salaries, etc. Now the city is hard-pressed and scrambling to save money on the backs of retired municipal workers. And eventually, this change will affect active workers. Our health insurance is non-negotiable and cannot be privatized. By attacking the most vulnerable during the COVID pandemic, when municipal workers were dying, you are demonstrating a depraved indifference to our senior population, employing coercive tactics, misinformation, and a chaotic rollout implementation plan to attempt to force us into a MAP plan, insurance plan. So I guess my time's up.
Yes, thank you so much. Thank you for your testimony, and if you submit it, we have the full
Yes.
testimony for your record.
Yes, thank you.
Thank you. You may go forward.
Honorable Chair, thank you for your patience, and thank the other council members. I thank them for being here. My name is William Russo. I'm a retired New York City Housing Authority employee who served for 34 years, from 1976 through 2010. I want to say right off the bat, I believe you should vote no and not amend the code. With that, I want to speak about the history of where we are in terms of leadership. I think what we have is a failure of union leadership. We have a failure of the city administrators, and we have people who are characterizing each other, meaning the unions and the city, characterizing us retirees in a very bad manner. I served 34 years, 20 of which were in a managerial capacity, and 14 with the Teamsters Union, Local 237. I recall a time when we had labor leaders like Victor Gottbaum, Barry Feinstein, Michael Quill, John Delory. They were leaders of the union. They would never do something like this to their membership. In fact, many of those union leaders founded the employee retirees divisions of their union. They were sensitive to the unions. What we all have in common is in this room, those who left the room, those who support those who are in the room, is public service, the noblest profession in the world. I taught civil service exam techniques for 30 years during my career. I taught young people how to take promotional exams. We all believed in public service. This decision behind the scenes is a betrayal. One of the speakers earlier today talked about we're referring to ghosts of the past. There are no ghosts of the past. The ghosts were those people who went into a room and using smoke and mirrors reflecting on each other came out and said they made a decision. James Madison warned of tyranny of the majority. It wasn't a majority here. It was what he warned also, a minority. It's tyranny of a minority, and we can't accept it.
Thank you so much. I know we had this wonderful woman here waiting, and then we can go to the gentleman. Sorry, I can't keep track of the names at
No,
this
that's
point,
all
but
right.
go
No,
ahead and identify yourself. So,
Good evening, and thanks for being here so late. My name is Laura Genovese. I live in District 1, and my council member is Christopher Martin.
can you press the button? Thank you. Sorry.
Should I begin again?
Just repeat your name again.
My name is Laura Genovese. I live in District 1, and my council member is Christopher Marte. I'm a retired city worker with 21 years of public service, 18 of them as a DOE school secretary. I have a deep feeling for the labor movement and am strongly against both privatization of our schools and health care. I gave up a high-paying private sector job to work for the welfare of children while counting on the city's commitment to provide me with the benefits I earned, benefits that also help raise the standard for all workers. I have to say that I'm a bit tired, but I'm glad I stayed because I heard a lot of people speaking very well. The question about why these individuals who I've stopped trusting, and I'm sorry that I'm very upset with how even Mr. Mulgrew spoke. This was my union leader. I paid union dues. I'm watching him before my eyes saying, well, we were always going to give you, a Medicare Advantage plan. They know very well what they're doing. This is the same individual with others that they blatantly violated Code 12-126. They blatantly violated it. Had it not been for that wonderful lawsuit by the retirees, they wouldn't have gotten caught. They thought they could get away with it. Now they're back, and now they're holding you hostage. We have a big problem right now in the country. Wendell Potter was here. They're trying to privatize healthcare like you wouldn't believe. They're watching New York City right now. That code is like a star, and there are insurers that are just waiting. And please, stand firm. Do not amend it. My husband has cancer. He said, tell them don't amend it because we want them to go to court. They cannot abuse us like this. Sorry.
It's okay. Thank you for sharing your testimony. I really appreciate all of your thoughts and your sentiments. You may go ahead.
Hi, I just came running back from a UFT executive board meeting because I heard my name was called.
Okay.
My name is Norman Scott. I worked at the DOE for 35 years, and I'm retired for 20 years as an elementary school teacher in Williamsburg. I am obviously here to support keeping the 12-126 intact while we negotiate for quality health care and savings. I had a statement that I want to just address. Well, I heard my union people speak today for my union, all of whom in some way or other have been on the UFT payroll. You do not see scores of rank-and-file teachers or retirees coming here to tell you to change the code, and there's a reason for that. At no point did we have an open, did we have a way to vote or give out choice on whether this should happen, and the right way to have done it would have been to open this up to some debate before they threw this at us. My wife worked in the medical field for her entire career, and she has always been against Medicare Advantage because she has dealt with all these companies for years, and she always said the most qualified, efficient company was Medicare. They had professional people working there, people who were in a union. They were civil servants, whereas all these private companies just hire anyone. And she had the most difficulty with the people from the private companies. And she felt that, and also Medicare costs are so much less than Medicare Advantage in terms of administrative costs. So what I did want to do is answer the choice question, because that's been thrown around. And you guys asked some legitimate questions. Well, I want to give you choice. Well, they're not offering choice for everybody. The choice is for the people who can afford it. Luckily, my wife and I can't afford it to opt out. And originally, that seemed okay. Then I started to realize how inequitable the choice is. It's only for the people who have decent pensions and can opt out. The majority of people probably cannot opt out. So that's what we're putting. So it's a faux. Offering the word choice is a faux option. It's not for everybody. And they're using sophistry to try and say, oh, we want to give choice. Well, they don't really want to give choice. They only want to give choice to a relatively few people, and I think if you change this code, you will give me choice, but you will not give people who are making much less money than me a choice at all. They will be locked into an inferior Medicare Advantage program, and you'll be creating a two-class system. Some of us get to keep Medicare and senior care, and many people do not. And I think that's something that we have to address, very important. And also, go read all the articles that are out there about Medicare Advantage. Somehow, this city and the unions are coming up with a magic plan that exists nowhere else in this world. I'd like to see that in operation, because I don't believe it's happened. Just the New York Times alone has savaged Medicare Advantage plans time and again. That's pretty surprising. You would think the New York Times would not be the one you would be reading that in, but we have been. Thank you very much.
Thank you all so much. You've been very thoughtful, insightful, and we appreciate your comments here tonight. Is Ibeth Mejia here? Yeah? Yes, it's okay. We called you earlier, but you can please come forward, and then we're gonna, if everybody else who's here in person has testified, we're gonna go back to virtual. If there's anyone who hasn't testified, please see the Sergeant at Arms who will take your card. You may begin when you're ready.
Hi, I am a teacher and UFT elected representative on the UFT High School Executive Board. I represent the majority of high school teachers that voted in the last UFT election, along 15,000 UFT members voted for us, not our president. I represent in the high school division, and I urge that the City Council to vote no on the amending 12-126, for this will affect in-service teachers, not only retirees. I suggest putting together a blue ribbon panel, as has been proposed, but has not been executed by our union president, Michael Mulgrew. Find other ways to save money with new audits and other savings that were in the 2018 agreement. But please leave 12-126 as it is and support our retirees and our active employees. Thank you.
Thank you so much. Thank you for your comments. Thank you. So we're gonna go back to the virtual panel now. I'll call 3 at a time. If you're on, please unmute yourself and begin. We're gonna start with Rose Dizitazi, Matthew Weber, and Diane Scalera. Rose, if you're on, please unmute yourself at the request. Rose is Not here. Matthew Weber, if you're on, please unmute yourself at the request and begin your testimony.
Good evening. Can you hear me?
We can hear you.
Thank you. Thank you so much for taking the time to allocate this time for all of us. I'm a retiree from New York City Health and Hospitals, but I want to speak to you from a different perspective. I'm speaking on behalf of Judith, a nearly 97-year-old retired teacher residing in a senior care facility near Harrisburg, Pennsylvania. Judith taught for 26 years at PS 241, during which time she cared for and nurtured students, actively supported parents, and mentored young adults who expressed an interest in teaching. She dedicated a significant portion of her best years to helping others, purposefully choosing to work in an impoverished community to make a meaningful differences for many. When it came to her well-being, Judith trusted OLR and UFT representatives who assured her and subsequently reassured her that when her turn came to retire, she would enjoy premium-free traditional Medicare supplemental health insurance for life. These reassurances allowed Judith to remain laser-focused on fulfilling students, parents, and mentees' needs. As many New York City retirees, Judith's health has declined. Aging, coupled with illness and accidents, have left her frail. Not by choice, formerly vibrant, caring people like her are now at the mercy of this council. Judith needs and deserves continuity of health care with providers she's familiar with, clinicians knowledgeable about her history and needs, and close to her home. This backdrop is intended to ground council members' decision-making around the 250,000 Judiths who gave selflessly to make the Big Apple the biggest and the best city. Retirees earn their benefits, were promised these benefits by the same organizations that are now working to diminish benefits. Please, for all the Judiths, place a moratorium on making any changes to existing retiree health care benefits. Thoroughly examine why the MLC did not pursue combining the 100+ welfare funds to achieve monumental savings and enhanced benefits for all. Place Aetna's CMS overall star quality rating under a microscope.
Thank you. Your time has expired.
And OLR formally meet with Marianne Pizzatola. Thank you. I've submitted additional recommendations in writing.
Thank you so much. Thank you. We have Diane Scalera. If you're on, please unmute yourself and begin your testimony.
Can't unmute.
You're unmuted. We hear you.
Oh, you can? Okay, because it looks like it's not here.
Yeah, we hear you.
Hi, Diana Scalera. I worked for 26 years in the New York City DOE, 13 years as a teacher, and 13 years as an administrator. And so I want to talk about something that we haven't spoken about. A couple of people mentioned, some groups mentioned used up bodies. And first of all, I want to say to everyone, I have just loved being with my colleagues again. And to be with city workers, teachers, and to remember what it felt like and how passionate we are about what we do. So I thank you for being here. I thank you for sharing your thoughts with me. It's been really an amazing day. I never thought I'd stay on this meeting until now, and it's just wonderful to have met you. Thank you. So my special talent is to organize things and to think about how to put them together and what they look like. And we heard about used up bodies. We hear about a lot of stories about people in the middle of treatment who are really suffering emotionally because they're terrified that this treatment is going to be ruined or taken away from them and something like that. And that's a really powerful story. And it's really grand because it's affecting almost all of us. All of us have had, at this point of our lives, serious medical problems. So that's something that we can really take in. But there's another side to this. Picture the day that they decide that we're going to switch to Medicare Advantage. None of us know how it works. No, they don't know how it works. Everything is unknown. And so imagine that you have a medical crisis on that day, and you have no place to go.
Thank you. Your time has expired.
You can wrap up. Wrap up your thought.
Okay, so you have no place to go, and So this is, you can't just switch one day to another 250 people, 250,000 people onto a new medical program. It's unfathomable that anybody could think that they can do that. And it's dangerous. There'll be many people who die.
Thank you. We have Sheila Siegel. If you're here, please unmute yourself at the request. Followed by Edward Farrell, William Laziza, and Paul Russ. Sheila Siegel? Not here. Edward Farrell, if you're here.
Yes, I'm here.
Yes, you may begin.
Thank you for the opportunity. It's been a long day, and I will be very brief. A lot of good points have been made. Let me just say for the record, our association, the Retired Public Employees Association, for over 50 years, has been representing the interests of state and local government workers. It's our position that health benefits should never be diminished for those who have already retired. If plans or changes want to be made prospectively, that's one thing. But once you've committed yourself to a career and you retire, you should be entitled to the benefits you earned. I just have a couple of comments on what transpired today. We've been through this Medicare Advantage issue with other municipalities around the state. And I heard a lot of smoke and mirrors today. When one of the union representatives said it was a secret plan that had a lousy rollout. Well, that's an understatement. It was a secret plan that nobody knew about. And the rollout was horrible. Even when they tried to implement it, they still didn't have everything in order. And I was really surprised that when members of the council pressed them, that they just blew you off. They had no information. They weren't going to give you any information. That included representatives from the administration as well. And then to say, well, regardless of what you do regarding this code issue, we're going forward anyway. I mean, that's the height of arrogance. So there's one other point I want to make, and then I'll wrap up. We work primarily with retirees in the state retirement system. And the state pension system, of course. I think you should look into this because it's been referenced. In the state pension system, 24% of the retirees have a pension of $10,000 or less.
Please wrap up.
Yes. And when you say what percentage have a pension of 20,000 or less, it's almost 50%. You know, and I think someone needs to look at this in regards to the city, because the cost impact is really significant for those at the lower level and those who retired years ago when salaries were much smaller. So
thank you.
I thank you for the opportunity.
Thank you. Can you submit your testimony so we can take a look at your suggestion? That would be great.
Yes, I did submit it already. Thank you very much.
Perfect. Thank you so much, and thank you for your patience. We have William Laziza. If you're on, please unmute yourself and come on. Paul Russ.
I can't. Oh, hello. Can you hear me now?
Oh, yes, we hear.
Oh, hi. This is William Laziza. Greetings and salutations to the honorable members of the Service and Labor Committee of New York City. Thank you for allowing me to speak, and thank you for staying this late. I am a retired CUNY employee and a member of the PSC CUNY Retirees Group. I chose to work for lower wages at CUNY because of the retirement package offering a small pension and health care for life. During my tenure, I became disabled due to illness, partly brought on by stress from long hours and constant worry with keeping my assignments under control, on budget, fully functioning to serve CUNY, NYC, and its citizens day in and day out. My particular story is too long to detail here. Although the work was challenging and I had to put in more hours than I was being paid for, I was happy and I felt that my wife and I were protected in the long term by the benefits that I was earning through my years of service. Now that I have retired, the healthcare benefit has been a lifesaver for me. I have a limited income and need to maintain my health more than ever. Please reject the proposed changes to amend the City Administrative Code's Section 12-126. I urge you to vote no on the proposed change when it comes up for a vote. But then, what is to be done with the entire issue of retiree health care? Here's a suggestion. The PSC has put forward a proposal for an alternative to resolving increasing health insurance costs for city workers and retirees that takes a longer-term view while protecting vulnerable retirees from the many dangers of Medicare Advantage plans. Please take the time to give this plan a fair chance and your full consideration. This plan has been put together by experts who are familiar with issues confronting the city and today and how we got here. In not too many years, you too may face retirement and find yourself in the same situation that we retirees here face today. This is not the time to kick the can down the road with the decision to compromise one group or the other. This is the time to find a lasting solution that will serve all New York City employees and retirees in the best way possible. Please think of us and find a way to honor the commitment that CUNY and the New York City government made when we were hired, with the understanding that if we worked hard and did our job, we would be rewarded with the benefit package that was agreed to at the time.
Thank you so much.
We did our job for you.
Thank you. Thank you for your comments. Thank you. Paul Russ, if you're on, please come on now. Not here. We'll move on to Fern Skolnick Cruz.
I'm here.
Thank you. You may begin.
Thank you so much, and thank you for holding this meeting. I don't want to repeat talking points. I do want to say this. This is important. Not all of us reside in New York City or New York State. I, for one, live in Maryland. It's sort of a double whammy, because in Maryland, physicians don't even accept Maryland-based Medicare Advantage plans, while traditional Medicare enables me to live where I want within the 50 states, travel for medical care or to see friends or relatives, and if faced with a medical emergency, go to a hospital, find a doctor. A state-based or city-based commercial Medicare Advantage plan really restricts your access and almost confines you to not leave the state. I've heard people give testimony that they had to travel out of state for life-saving medical interventions. That might be precluded, and I would like you to think about that. I also want you to know that as a resident of Maryland, I pay taxes on my pension. So I retired from the GOE after 22 some odd years with a smaller pension than it would have had if I had stayed on 25. So I was, in a way, I lost some pension and I'm taxed as well. And I know I'm not the only person who still lives in a state where there's it's reciprocal. You're not taxed. So that's something to think about. The last thing I want to say is, Aetna has a fiduciary obligation to its shareholders to keep making money. The city of New York has a fiduciary obligation to its public servants. And I sincerely hope that you put together a task force.
Thank you. Your time has expired.
All of the relevant and affected stakeholders and experts, and work collaboratively to develop a viable plan consistent with social justice, which is what we as public servants have earned and deserve. So please vote no. Let it go to court. Optionality can be exercised after that happens.
Thank you. Thank you so much. We have Drew Ninos. If you're here, you can unmute yourself at the prompt. Drew Ninos, if you're on, please unmute yourself at the prompt. We'll move on to Paige Dorothy Delano. If you're on the Zoom, please unmute yourself at the prompt. Paige Dorothy Delano. Not here. We'll move on to Rose Distasi. If you're on, please unmute yourself.
Yes, I'm
All
on.
right.
Can you hear me?
Yes, we can hear you. Please begin.
Thank you.
You're welcome.
I'm sorry, I tried to unmute before, but it didn't happen.
No worries. Go ahead.
Okay. The city council is being threatened that they don't amend, that if you don't amend the statute to force retirees into the Medicare Advantage plan, the mayor will do so on his own. Amending the statute does the same thing. Why should the city council amend a law that the mayor will do anyway? Why do his dirty work? Let the mayor take care of the political hit for hurting retirees and removing city council members from the eye of retirees and constituents in their next election. If the mayor does this act, the retirees will be able to challenge and win this in court where we have been successful before. Please do not change the Administrative Code 126. Thank you so very much for your attention.
Thank you so much. Deborah Bigelson, sorry. Bigelson. Deborah Bigelson, if you're on. Moving on to Ben Scarcella. Ben, if you are on, please.
I'm here. Can you hear me?
Yes,
This is Deborah.
Deborah,
Yeah,
you may begin.
Thank you. I'll try to be as quick as possible. Thank you. Thank you. You actually are my representative. I will try to cut out as much. I know you've heard just about all of this today, so I'll read what I wrote. My name is Deborah Bigelisen. I just turned 65 and I'm a retired New York City high school teacher. I taught for 27 years. When I retired, I was promised my health care would not change. I'm distressed that you are considering changing Law 12-126 to undercut my health benefits. I worked as a dean of students with many troubled students who brought guns to school, knives, and box cutters. I attended gang training. I worked with other children that lived in shelters and considered school their safe place and home. Now that I have retired, you are trying to undercut my health care. I am urging you not to do this. I am clear on the rising costs of health care in this country. Politicians that make laws should be fighting the hospitals, should be working for us, not for the mayor and some other committee. I'm trying to run through this. I question whether you have ever been in a New York City school with troubled children, a burning building, or in an ambulance saving someone's life, or even worked in a city hospital through this pandemic. If this is your way of saying thank you to all the responders, the first responders in New York City, then you don't deserve to be in office. I'm urging you not to make these changes. The mayor will do whatever he wants to do anyway. I question your motives in politics. It's dishonorable that you would want to change the healthcare of thousands of people that have served this city. It's reprehensible to have a mayor that wants to do this. I question whether you really know the difference between healthcare plans. My doctors, as you heard before, do not take Medicare Advantage. I have had many healthcare issues. I won't go through them because of time.
Thank you. Time has expired.
Okay. Thank you for your time again, and thank you for staying so late.
Thank you so much. Ben Scarcella, if you're here, please unmute yourself at the prompt. Moving on, Adrian Bele, if you're here, please unmute yourself at the prompt.
Hello, I'm here.
Yes, you may begin.
Okay, honorable council members, my name is Adrienne Belay. I was a police officer in the NYPD. I worked undercover and anti-crime in the 1980s. Unfortunately, I got hurt going after a murder suspect one evening. I was hospitalized for 10 days. And then afterwards, now the result is I'm in a wheelchair most of the time. I can't go anywhere without being in a wheelchair. My husband 3 years ago was diagnosed with bile duct cancer, liver cancer. If it wasn't for Sloan, he would be dead today. They rushed through the testing. They operated on him 3 times. And they took care of him with the chemo. He was hospitalized twice for chemo reactions. And as for me, last year, I was diagnosed with colon cancer. So I've been under doctor's care. Now that we're on, but the best part is that we're on traditional Medicare. It's a blessing. And I don't want to have to wait to get any tests done. If we had to wait and get denied and have to appeal and to get our tests and not be able to get our tests, I know that we would not be here to see future grandchildren. I'm from Brooklyn. I have a master's from Brooklyn College. I became one of the finest because even though I could have gone into the private sector and made more money, I wanted to give to the city. I want to protect this code. Too many retirees will suffer and possibly die if we're forced into the Advantage Plan. The city is spreading too many lies. I appreciate your support. Thank you for protecting
Thank you.
us.
Time has expired.
Thank you very much.
Thank you so much for your comments here today. John T. O'Malley, if you're here at the prompt, unmute yourself.
Hello, thank you, Chair De La Rosa. Appreciate your work on this and your ability to be both compassionate and inclusive in this process. It's very much appreciated. I'm a pre-Medicare retiree of Verizon, and my union negotiated a Medicare Advantage plan for post-Medicare retirees with no choices. And without any choices, we have no lawsuit, not for forcing people onto Medicare Advantage, not for cutting benefits, not for the union not being authorized to negotiate on people's behalf, none of that stuff. Anecdotally, there's no complaints from any of the retirees. The members live all over the United States, outside the United States, but there aren't any people complaining about their doctors not being in or their care not being as good or anything like that. Now, I understand the concerns, of course, about Medicare Advantage, and I hate privatization. I hate private companies siphoning off the top of either city services or any sort of municipal service. But this code change has nothing to do with Medicare Advantage. That's coming no matter how this vote goes. This is a vote yes for choice and for senior care, or no for no choice and no senior care. Council can do investigations, go find money, look at the funds, but that doesn't change the fact that this code change is not about Medicare Advantage or no Medicare Advantage. That decision has already been made in a different forum. I have no choice, only Medicare Advantage. Maybe it'll be fine. But you have the power to give the New York City retirees choice, at least while you figure out the rest of it. So you should give them the dignity and give them the choice while you figure out what you want to do next. Thank you very much. I appreciate the hearing and everybody who testified.
Thank you so much for testifying today. Up next, we have Pamela Markscheid. If you're here, please unmute yourself at the prompt. Pamela Markscheid. Not here. Moving on to Joanne Greenbaum.
That's me.
Great.
Hi.
You may begin.
Thank you. So my name is Joan Greenbaum, and yes, Carmen De La Rosa, you are my councilwoman, and I thank you for hanging in here. I'm hoarse from just listening. I don't know how you do it. started at LaGuardia Community College, a job I loved, after I was a programmer and a systems analyst at IBM. You can imagine the pay change. People in the computer field, and I'm going to get rid of much of what I was going to say, but I thought I'd bring this perspective. People in the computer field have a number of sayings, one of which I really love. We fail more often because we solve the wrong problem than because we get the wrong solution to the wrong problem. And I think that's what we're looking at here today. I think what the MLC and the city have given us is the wrong solution to the wrong problem. It's almost like they're singing a song, what are we going to do about the problem about retirees? It's not us. For starters, I want to take us back to the 2018 agreement in which the city and the MLC agreed to form a tripartite committee. And in this committee, they said the MLC and the city would get savings. They never showed us any data, and I'm data-driven, you could guess that, about what those savings were. And that's what part of the PSC plan is about, is let's build up a trust of showing savings. But let me go on with this tripart committee. The MLC, it was made up of the MLC, the city, and you know who the third party is, Carmen. It's Martin Scheineman. And then when the savings didn't materialize, Scheineman appointed himself.
Thank you. Time has expired.
Ah, really?
You may conclude your thought so that we can go on to the next person.
Scheineman became the arbitrator, as we well know. And I just asked this last thought, besides the PSC proposal, I ask you to look at the percentage or the number that's being promised to Aetna, because that's going to have to be in the contract or in a letter of agreement. And I'm really frightened of that one. Thank you very much.
Thank you. Thank you for your insight today. Up next, we have Matt Shapiro. If you're on the Zoom, you may unmute yourself at the prompt. Not here.
I'm here.
Oh, you're here. Okay. You may begin.
Can you hear me?
Yes,
Can
we
you
hear you now. You may begin.
Okay. I agree with most of the testimony against changing 12-126. That is, 12-126 guarantees cost-free healthcare up to a reasonable cap, and changing that cap so that the MLC and the city can do whatever they want doesn't make any sense if you care about the retirees. So please don't do that. I have 2 points that haven't been made. I chucked the rest of my testimony. One is that any Medicare Advantage plan cannot meet the terms of 12-126. They're not cost-free. They may be premium-free, but they're not cost-free. And the proof of that came out after the judicial decision, about a month after, when the Inspector General laid out in his report about all of the denials of care that go on in Medicare Advantage programs, where Medicare would have approved those procedures. Those denials of care have a cost. Take any procedure that's been denied, a $50,000 surgery, whatever you want to look at. Who's going to pay that cost if it's denied? Obviously, it's left up to the retiree to pay for it if the person wants to live. So the plan is not cost-free. It's very expensive. If that point is made, if the plan is shoved down our throats, as the city intends to do because of the sham arbitrator, then it's going to be knocked out of court. It can't withstand that challenge. That's one thing. And the other thing I wanted to say.
Thank you. Your time has expired.
Oh, one more point, please.
Just if you could conclude, that would be great. And please do submit your full testimony.
But quickly, you can resolve this problem if you want to by passing a law or expanding 12-126 to require a supplementary program, a supplement to Medicare be offered free of premiums, free of copays, free of deductibles. Require it in the law. You can legislate it. We don't need judicial decisions anymore if the council wants to act. The council can solve this problem. You're in charge.
Thank you. We appreciate your comments tonight and your patience as well. Barbara Baker, if you're here, please unmute yourself at the prompt. Not here. Eileen Moran.
I am here.
Oh, Barbara. Yes, Barbara, you can go ahead.
Yeah. Hi, thanks. Thank you for your perseverance in staying with us. I have written testimony, which I've submitted, but most of it has been covered. My name is Barbara Backer. I'm a registered professional nurse. I have professionally practiced nursing in the city for more than 30 years. First as a psychiatric nurse clinical specialist at Bellevue Psych Hospital, and ending my career as a professor emerita of nursing at Lehman College in the Bronx. I speak in opposition to the proposed administrative code changes. And I'm going to make one point which I feel very, very strongly about, and I don't think maybe has been mentioned during this hearing, but it is about the relationship between the patient and the healthcare provider. Those of us in mental health know how important this relationship is, because the therapy or the cure in many ways depends on the trust between the patient and the provider. And in a Medicare Advantage program, if you are moved from pillar to post because you can't get a physician, you don't establish this trust overnight, not just in mental health care, but are you going to trust the cardiac surgeon to open your chest and move around in your heart if you don't know who that person is? There are many analogies to make in terms of that development of trust. And that is the core at the point of delivery of healthcare. And I don't believe that is considered in the Medicare Advantage plan as presented here. We can't move people around similar to that of an Amazon assembly line, where you are in one distribution center as a package and then you're moved to another because you don't fit the right package size or delineation of what that package could be. And then you move to another distribution center where there is no recognition of that package at all. And you may or may not get to your destination, but there has been a delay and the package may be damaged. And the people at the new center have no idea how to repair that.
Thank you, Ms. Backer.
Thank you. Your time has expired.
Vote no on the amendment change. Thank you.
Thank you so much for your patience and for testifying tonight. We have Eileen Moran. If you're on, please unmute yourself at the prompt and begin your testimony. Not here. Marthy Gold, if you're here at the prompt, please unmute yourself and begin your testimony.
Thank you. Can you hear me okay?
Yes.
Hi there. Thanks for persevering. My name is Martha Gold. I'm Professor Emerita of Community Health and Social Medicine at the CUNY School of Medicine at City College. I'm a physician whose career has been in healthcare delivery and as a senior policy advisor in the Federal Department of Health and Human Services. Thank you for holding the meeting. I'd like to remind New York City governance that Medicare for All is endorsed by a majority of Americans. A recent survey found that fully 80% of Democrats support a public insurance option. Medicare Advantage is all about privatizing medical care, for the city of New York to place its municipal workers in a private for-profit plan is completely out of sync with the desires of the vast majority of the constituency. People will not forget. Relevant to the city's presentation that the federal government will pick up much of the missing $600 million tab, a December 7th Congressional Budget Office study reported that the federal government pays Medicare Advantage plans an average of 4% more than it would cost the Medicare fee-for-service program to cover a similar beneficiary. The CBO recommends that benchmark payments to U.S. plans be reduced by 10% in 2025. You have to wonder how Aetna will manage that little program and satisfy its shareholders. Enrolling us in Medicare Advantage is a Band-Aid solution to restraining long-run cost growth. PSC CUNY's proposals are far more likely to accomplish the ends the city seeks in cost control while keeping its promise to us. Thank you for not succumbing to the pressures of the union leadership. Thank you. I see, but here I am. Thank you.
Thank you. Michael Antwerp, if you could unmute yourself at the prompt, that would be great. And you can start your testimony.
Hello, can you hear me?
I hear you.
Thank you. Thank you so much, Ms. De La Rosa. I want to say my name is Michael Antwerp, and I'm married to a city public retiree and received my health care plan under her. Number one, Martin Scheinman's participation in this situation was not an arbitration and has no legal jurisdiction whatsoever, as confirmed by Michael Mulgrew, Randy Weingarten, and several attorneys. Number two, New York State Supreme Court and the Appellate Court ruled that retirees should not pay for their current supplemental plan premium, which costs only 0.6% of the city operational budget. It's an extremely cost-effective yet powerful benefit. Number three, viable solutions as recommended by the PSC, healthcare economist Barbara Caress, and measures like self-insurance, welfare fund consolidation, and placing all unions into the same drug plan can save the city at least $500 million a year. MAPS should never be an option. Number four, MAPS deny and delay treatment, which puts patients at risk, resulting in increased illness and even death, unlike traditional Medicare. Don't allow the mayor and the MLC and Michael Mulgrew to subject retirees to this heinous stress and risk. Number five, retirees took lower paying jobs, giving their labor, health, and in some cases, even their lives. This is a slap in the face to 9/11 responders, their spouses, partners, widows, and widowers who rely on solid health care at this point in their lives. A MAP will not deliver that. And finally, number six, hundreds of thousands of retirees have small pensions like $35,000, $25,000, $15,000. They are women and people of color and cannot afford $200 a month plus copay to keep themselves safe in traditional Medicare. The city council is one of the last bastions of protections. Retirees built the city, maintained it, protected it, made it function properly and on time, and were the backbone of making New York City one of the greatest destinations in the world. Let us not forget them and their critical contribution in their time of need now. Remember that this will also be your legacy as a city council, and it will have far-reaching consequence for elections and civil servants in this cohort and for generations to come. I beseech all of you to please leave 12-126 alone. Do the right thing. Thank you.
Thank you so much for your testimony. Jane Buchanan, if you're on. Go ahead.
Okay, by Michelle Otis.
Okay. Do you, Mr. Antwerp, do you think that it would be appropriate to submit the testimony instead of reading it out loud? We're on hour 11.
I did. They were submitted, but I was asked by the two people who could not attend to have it read for them.
Okay, I'm asking you to consider just submitting because we're on hour 11 and we still have a few more folks signed up. Is that okay, or do you want to proceed?
Well, I would like to proceed, and I have to say their testimonies are very short.
Okay, go ahead.
From Jerry Maestriano, I know the mayor is pressuring the city council to amend Code 12126. This would allow the city to provide a cheaper and grossly inferior Medicare Advantage healthcare plan to retirees and pave the way to eventually force inferior plans on the in-service workers. As a retiree myself, I selected an Emblem HIP Medicare Advantage plan for my first year of Medicare coverage, and it nearly killed me with the insurance companies denying and delaying of my diagnostics. The insurance company even attempted to delay my urgent heart surgery. I thought I'd have to choose between being on the hook for $500,000 for the procedure that wasn't covered or else die waiting for the insurance company to decide to pre-authorize it. In my desperation, I was actually considering going to the ER, hoping they would perform the surgery as an ER procedure, which would then have to be covered by the Medicare Advantage plan. All this aggravation did my heart condition no good. I'm lucky I survived Medicare Advantage. The costly bad decisions of the NYC Central Labor Council should not be paid for by vulnerable New York City retirees. Please vote no to any administrative code amendments that would breach the hard-fought-for collective bargaining agreements that protect city workers' health care and for in-service city worker and for New York City retirees. Thank you. Signed, Jerry Maestriano. The next one, the last one, is from Tracy Avon Ford, who could not be here tonight, and she writes, I have been a school social worker with the New York City DOE for 24 years, and I'm at work right now. I was working at PS 142 in Lower Manhattan on September 11, 2001. In the months after, as part of my job, I walked to daycare centers just blocks from Ground Zero. I passed the smoldering remains of the World Trade Center. The smell of death lingered for months in PS 142. I continued to work at 142 in the years following 9/11, and I was diagnosed with upper respiratory disease and chronic rhinosinusitis. My conditions are chronic, and I will need the same specialized Medicare treatment I receive now when I retire in 5 years. Any Medicare Advantage plan will deny the treatments that I need. I receive all treatment from NYU Langone, which does not accept Medicare Advantage plans. The respiratory disease and chronic rhinosinusitis is a direct
Thank you. Your
result
time has expired.
Thank you.
Thank you so much. Jane Buchanan, if you're on at the prompt, please unmute yourself. Yes, we hear you. You can go ahead.
In City Council District 3, Eric Botcher is my city council member. I am not a New York City employee or retiree, but I have many friends and neighbors who are. I am here to support them in their efforts to protect the senior care health insurance plan. Senior care, full senior care, including Medigap coverage payment, was guaranteed, and that promise must be honored. Please put your efforts into working together to come up with alternate ways to solve the problem of rising healthcare costs. Though I'm not a city employee, I am a proud union member in another sector of the economy. I am very concerned to see union leaders promoting advantage plans to their members instead of valuing Medicare, original traditional Medicare. It's my understanding that a number of city council members have come out to oppose this amendment to the administrative code. I urge council members to join together in opposition. I urge you to vote down this amendment. Thank you for your attention. Good night.
Thank you so much for your testimony. I will read out the following names. If you are online, please indicate so. Lupe Hernandez. Donna Centorino. Elga Jaffe. Robert Rosenbaum. Walter Zwartzaki. Andrew McLaughlin. Susan Ortega. Professor Irving Robbins. Sandra Kaplan. Ralph Palladino. Nick Zuragusa Sr. Valerie Marie Glasgow. Pulikizu Thomas. James Eterno. Phyllis Hoffman. Mark Tropufka. Christopher Balchin. Karen Bracco. Andrew McLaughlin. Doreen DeLeandro. Margaret Cohen. Lolly McEver. Tanisha Grant. Peter Bronson. Kevin Cutton. Sandra Kaplan. Eva Lee Bard. Jules Hirsch. Peter Allen Lamprey. Leonardo D. Paletta, sorry. Stephen Klein. Aline Bistreacer. Gary Barnett. Patricia Luce. Marianne Stewart Titus. James Bonanno. Annie Friedman. Alex Stein. Thomas Scotto. Genesis Cordero. Cecilia Braxton. Marsha Neufeld. Bobby Zimmerman. Eva Lee Bard. Harold Delancey. Shari Lopez. Jerry Mastronani. Tracy Vaughn Ford. And Margaret Feely. Okay, there's two other folks here. Leslie Williams, if you're on, please unmute yourself. You may begin your testimony.
Hi, good evening. Thank you for hanging in there, Ms. De La Rosa. Thank you so much. I'm a CUNY retiree. I retired in 2016. And when I joined CUNY with the understanding that I would be getting a lower salary, but also great benefits when I retired. If I went to the private sector, I could have made a lot of money. But I decided to stay with CUNY, and I lasted through 17 or 18 years when I retired. People who retire should be continued with their benefits that they signed up for, that they were eligible for, that they put in their time for. And there are many people who have lower salaries, lower pensions, who really are being discriminated against by not being continued in this plan. And also long-term, new employees who come into CUNY or to the city should be mindful that they may not have a pension or health benefits when they retire. And I fully endorse PSC CUNY's plan. Thank you.
Thank you, Mr. Williams, for your insights. Gary Barnett, if you're on at the prompt, you can unmute yourself and begin your testimony.
Okay, wait a minute. Okay, now.
We hear you. You can start. We hear you.
Okay. My name is Gary Barnett, and I am a retired spouse of a retired Department of Education employee. Who amongst the rank and file and their dependents even knew of the important protections Administrative Code 12-26 provided when we were blindsided in July 2021 by the proclamation that our health insurance would be switched from traditional Medicare senior care to a Medicare Advantage plan as of January 1st, 2022. On top of the absurdity of even thinking of switching 250,000 retirees in a time frame of less than 6 months was the fact that the vehicle for announcing the new plan was merely an entry in the Office of Labor Relations website on or about July 14th, 2021, with no direct communication to rank and file members and no legally required public hearing. It took a successful lawsuit and appeal to shed light on what I suspect was known all along by the MLC and the New York City Office of Labor Relations, that they had acted illegally, and that in order to put in place the money-saving and inferior quality Medicare Advantage plan alluded to in the fraud agreements of 2014 and 2018, Administrative Code 12126 had to be amended. It would appear that the MLC and the city knew that amending the code would be a heavy lift, which is why they introduced the Medicare Advantage plan clandestinely, not anticipating there would be much pushback, and certainly not a lawsuit. The new plan, known as Alliance, was portrayed as, quote, better than traditional Medicare, that it was custom-designed Medicare Plus plan that would allow a retiree to see any doctor, provider, or specialist who participates in Medicare, which of course turned out to be false, along with other misinformation about prior authorizations and a convoluted system of paying for a procedure.
Thank you. Your time has expired.
What? Can I just read another? All right, let me read my final statement here. As the retired spouse of a retiree, I'm very grateful for the past negotiations between MLC and the city that ensured I would never have the stress of mountains of paperwork and fighting with health providers. But in attempting to switch retirees to a Medicare Advantage plan, the MLC and city sadly acted irresponsibly and illegally. It's incumbent on the council to protect the rights of those affected by the city and MLC's actions. Not only would it set a dangerous precedent to enable illegality by changing the rules to accommodate such actions, but changing Administrative Code 12126 at this time will set the stage for potential future diminution of benefits, such as Medicare Part B reimbursement, pegging a less expensive benchmark to certain classes of individuals, among other known and unforeseen consequences. So I implore you to vote no to amending the Administrative Code 12126. Thank you.
Thank you so much. And with Mr. Barnett's testimony, we are officially concluded with the testimony here. I want to take the opportunity to thank Speaker Adams for her leadership in allowing us to bring this conversation forward, Deputy Speaker Ayala for hanging in there with me, all of my colleagues really who have really came here with the intention to listen, and all of the staff, Sergeant at Arms, committee staff, and all the council staff that's here at this late hour. We're just short of 12 hours on this hearing, and we set out, I think, to do what the intent was, to lay the table for all opinions to be heard in a fair fashion and for us to get the answers to the questions as the council continues to deliberate on this very important matter. I want to thank all of the retirees, the actives, the union leaders, and all of our constituents who have come out today to express their opinions, their concerns, and their serious issues with the amendment before us and with the healthcare issues overall. Thank you so much, and the hearing is adjourned. Oh, I want to remind folks that you can submit testimony up to 72 hours after the conclusion of today's hearing at testimony@council.nyc.gov. Thank you all. The hearing is adjourned.